Okay, good morning. Good morning. I'll work on it. Don't make me have David Hook start this meeting. So there we go. Everybody's had a good breakfast, hopefully. A little bit of sleep. So I have some announcements from from Debbie, who's our meeting manager. So we're trying to arrange to make sure everybody smoothly gets back to the airport. So make sure you let her know what time you want to be picked up here and what time you need to be at the airport. She's trying to coordinate rides. So, and Debbie, where are you, Debbie? And there she is. Everybody knows Debbie by now. So thank God Debbie's been here to help us. Okay. A couple other things. So we're going to run over. That's just the way the meeting is set up. We have a lot of good talks. We're not worried about that. We have some periods to catch up. It might be that we're having our coffee while we're still talking. It might be that we're having lunch while we're still talking. We do have to be out of here at 5 because they have to clear the room for the dinner. And then there's a board meeting at 5:45. Next to the bar, there's a board room. So dinner will start at 7. So that's what I got to tell you. Also, we are broadcasting live through our app. So speak into the microphone so that people can hear us and get captured. We'll also be available on demand after the meeting. So you don't have to take notes. They'll be available for you. And with that, let me start by saying thank you for our industry sponsors. Where is Keith? Thank you, Keith. Tom, you're close by. Tom, thanks so much. And where is Justin? So thank them. Without their support, we don't have a meeting. So thank you very much. And I want to thank the team that's been helping set this up. Debbie, thank you very much. Ian, Ia, who lives in the Philippines. So thank you all. It's my distinct honor to welcome you to the first International SCR Association academic meeting. It's truly impressive how many of you have traveled great distances to attend this inaugural founding meeting of our association. Your commitment to being here reflects the great significance and impact you attribute to this procedure. We are here because we share a deep understanding of the principles and practice of superior capsule reconstruction as it was first pioneered 2 decades ago by Dr. Mahata. We are here because we understand the meaningful benefit of the original Mahata SCR for our patients, and we are not merely having a meeting. We are having a movement. There are 10 U.S. states represented today. We are here in the USA specifically to demonstrate to our U.S. colleagues that the real SCR with fasciolata autograft is already here in the U.S. It is highly successful and well accepted by the U.S. patients, and it is very much needed by the U.S. patients. We are broadcasting this meeting live so that through our conference platform, we can extend the dialogue far beyond these walls, engage colleagues across the globe in real time. This gathering reflects the true international scope of our work. The 50-plus leaders assembled in this room, together with the participating attendees digitally, represent 20 countries. 20 nations working together as the essential advocates and educational resources for our global surgical community. And this is our purpose today. We are formally launching this association. You are the launch of this association. The shared collective experience and outcomes in this room using SCR. We're going to be defining best practices. We're initiating education and training of surgeons, which we started yesterday. We're going to be identifying priorities for future research, and we're going to begin organizing the development of regional centers in the U.S. and worldwide. This is to extend the application of superior capsule principles to improve both superior capsule reconstruction and the outcomes in ARCR. The result of our collective work today will lay the foundation and launch an organized, sustained international effort to advance the science, the education, and the clinical application of the original successful SCR. You, the founding members and participating attendees, are the essential collective force for the global initiative, and I appreciate that every one of you is here. Let's be absolutely clear that because of our patients whose lives have been disrupted by the profound dysfunction of a massive rotator cuff tear, an irreparable tear, or a failed rotator cuff surgery, we are here because of the great benefit this procedure can bring to our patients. We here have witnessed time and time again that as patients return to function and reclaim their lives. We know the original SCR reconstruction using fascial autograft performed rigorously and in adherence to foundational principles represents the gold standard of care for a properly selected patient. It is the gold standard that our patients need and deserve, but too few have available, particularly in the U.S. We are here because our colleagues need us to be here to lead the way, and even if they don't know it yet, they need us because their patients need them. Our collective energy and commitments is a movement needed to cause the breakthrough and break free from the missteps and the misunderstandings of the past to lead the global surgical community to better future. Patients and colleagues are depending on us. And with that, I want to introduce our first speaker. Thank you all for being here, Dr. Mahata.
In the session today. So my first talk, the history and can you open my file? Yeah, history and the concept of the SCR. So first, I want to tell the story how the SCR was born. Actually, first breakthrough moment is a meeting with Tarly. Yeah, it was a long time ago, you know. He has hair. Yeah. Yeah, that is 2002 actually. Yeah, at that time I work in the University of California, OBL. Yeah, his lab. And the main research was the instability. At that time we did many biomechanical studies in carpal shoulder. Then we realized that primary stabilizer in the Graham joint is the shoulder capsule. So this picture already we take out the rotator cuff muscle. Only the capsule is intact. But if the capsule is intact, even we push the humeral head but does not dislocate. But once we cut the capsule, dislocate very easily. So we realize the shoulder capsule has important role for the stability in the Graham joint. And also the superior shoulder capsule, at that time, 2002, like a neglected anatomy. So even the textbook did not show anything. But we had many studies, and actually I dissected the shoulder specimen more than 100 cases or 200 cases. Then we realized the super part, the shoulder cuffs there, and it seems to be the very important role for the Graham joint. So they are actually, Dr. Nimura published in 2011 regarding the anatomy of super shoulder cuff. So before this study, actually just neglected. But we know the super shoulder cuff has an important role. And also we did a biomechanical study by comparing the intact tear and the defect of superficial capsule. Of course, just a capsule tear, super translation does not change too much, actually not significantly, but super shoulder capsule defect model significantly increased, like it's an irreparable cuff tear model. At that time, 2002 or 2003, we realized that this picture is the irreparable cuff tear. It's not correct, actually. It's not exact accurately. So we realized it is an irreparable tear of the rotator cuff tendon and shoulder capsule. Then we hypothesized that if we reconstruct super shoulder capsule, we can prevent the supermigration of the humeral head even for irreparable cuff tear. Even we cannot repair the tendon, maybe we can stabilize the joint. That was our hypothesis. And of course, at that time, the many studies showed the conventional patch graft surgery, but result was terrible. It's not good because the graft was attached to the torn tendon. Of course, the torn tendon edge is very degenerative, so it's not good healing. So that's why they are very poor outcome at that time. But so this was our idea. We fix the graft to the glenoid superiorly, like making a special capsule. Then maybe we can stabilize joint. That is our hypothesis. And finally, 2005, we did a biomechanical study using carpal shoulder. This is a really fast SCR using carpal shoulder in 2005. Then we did biomechanical study. Then, as we expected, very nice result. So once we cut the rotator cuff tear, we created a rotator cuff tear model, super translation, increase. But tendon patch, it's a conventional patch graft surgery, did not research completely, but super cuff reconstruction completely normalized the interest level. So we are excited at that time, but actually at that time, no one believed this result, unfortunately. So that's why this study we did of 2005, but published 2012 because they are all rejected at that time. But I believe this results, we studied this surgery for the patient in 2007. This is a real first patient, 60 years old male gardener, so massive tear. And this is a fast graft. Actually, it's not excellent. I don't want to recommend this graft, but this is a fast graft anyway. Yeah. Then I did this surgery. Can you click this bottom?
You guys start the movie? You said
Yeah.
click.
So this is a real first the patient, il parvocaster. We put the suture anchor on the glenoid. Then we inserted the graft first. Then at that time, we attached all of the suture to the graft inside the joint. Now I attach the suture outside the body, so much more easy. But at that time, we did all suture attached inside the joint, so it takes a long time. I remember 3.5 hours. This is the first cases, and finally, this is a teres minor, so we make a side suture between the graft and tendon. It looks very nice. There are even fast cases, and it's a subarachnoid space. And even inside of the joint, maybe they're here, good tension. And afterwards, we found the increased acromion distance for this patient, and MRI looks good. And he returned, actually, he improved the function, actually, elevation. He got the full elevation at 6 months of surgery, and he returned to the gardener. Then we saw the SCR works for the patient. Then we keep doing, and then this is the first paper of the clinical study in 2013 in journal arthroscopy that accepted. And then we keep doing. So until last year, we did more than 1,000 cases already. So now I can recommend this surgery because we have many data of this surgery. And also we published a long-term follow-up, 10-year follow-up in the AJSM 2024. I want to show this data briefly. And this is a 50 patient, actually the 48 patient, the 50 shoulders. Unfortunately, 5 died, 5 moved and 2 had a health problem, 2 refused to participate. So the 34 patients were enrolled in this study. Then, of course, the fasciolata SCR and the result. 3 months of surgery, 2 patients had graft tear, and 2 years we found 1 patient had graft tear, and 5 years 1 more patient graft tear, but 5 to 10 years no graft tear at all. So the survival rate at the 10 years after surgery is 89%. So this is a really fast 50 cases. So that time the graft thickness, some patients very thin. But so if I do this similar study now, maybe we can get better graft survival rate, better than this result. And active shoulder elevation, 1 year after surgery increased from 89 to 149 degree. But one year after surgery, it's not maximum. Still, we can get a better elevation. And 5 year, 162, and 5 year to 10 year, no change, 159. And this is a 10 year after surgery. So maybe you cannot realize which side I did SCR. Actually, the patient also, they forgot which side they did surgery 10 years ago because they feel normal. Yeah, and we, of course, no donor side bone mobility there at 10 years surgery. So next, I want to tell my the indication of the root cuff tear. I checked irreparable before surgery. Then before starting the SCR, the irreparable case, I did a root cuff repair. And in irreparable cases, I did many surgery techniques, partial repair, LD transfer, other debridement or other technique. But actually, the result was not consistent. So that's why I started the SCR 2007. Then after 2007, irreparable cuff tear, I did SCR. All of the tear, irreparable, I did SCR. Of course, some bad poor outcome. So we changed this, modified now, but and also 2013, we developed the SCR for reinforcement of root cuff repair. It means SCR plus root cuff repair. So from 2013, we changed the reparable cases and good quality of the tender, of course, local repair, but poor quality, now HUR plus car repair. Then very nice result. Maybe in the afternoon, I will show the result. And this is the current indication. Calf repair, SURA, and irreparable cases. Two tendon tear, irreparable, of course, HUR alone. But now irreparable supra infrasubscapularis. Now I'm doing HUR plus anterior capsular reconstruction. And the posterior side, irreparable supra infrateres minor tear. Now I'm doing HUR plus lower trapezius. But still, we are looking for the clinical outcomes. So just we study. And for irreparable calf tendon tear, I don't recommend the HUR. Now I do the reverse. And also fasciolata HUR, technical difficult. Maybe everyone feel this thing difficult or no. And this is from the young surgeon from Hong Kong, Dr. Lee, Dr. Chan. They observed my surgery around 1 week, just 1 week. Then they returned to their hometown, then started the issue, and they sent message. The Dr. Lee, he did a 7 issue and 2.5 hours, actually very quick and very smooth. And Dr. Chan also very smooth, and the patient is doing fine, he said. And his patient, very good elevation and good external rotation. Yeah, he's from Hong Kong. So even young surgeon, maybe if you copy my surgical technique, it's not so difficult. And how about USA? There maybe everyone think about maybe how to harvest fasciolata, but actually Paul Lodge, yeah, he studied this surgery. He came to my clinic maybe 4 years ago or 5 years ago during the COVID. And this is a second breakthrough moment, I think. He studied my technique in USA, even fasciolata HUR he did. Then and he had many publications now, and maybe he's had the HUR fasciolata USA. Yeah, and he's big fan of fasciolata HUR. And also yesterday, we visited, actually the day before yesterday, we visited his surgery center, and he showed his HUR using fasciolata autograft, and he's kept changing. USA actually, yeah. Yeah, but anyway, yeah, he started a show using fasciolata in USA. That is a big step for the HUR surgery. And he also sent a message, completed 50 cases in the last 20 months. It's 2 years ago. So now maybe more patients he did. And they said my happiest group of patients, and look forward to helping other surgeons run the HUR fasciolata in North America and beyond. That's why we started the International HUR Association meeting right now. Anyway, even for American patients, fasciolata HUR works. So maybe I hope you can keep in your mind. And third breakthrough moment, we meet these founding board members, Frank Alvaro and Ty, John Kelly and Ben Mar, Paul and Buddy and Pablo and Clara and Catalina and Hiro, Bancha, Iho, Erica, Dinsho, Patrick, and Noble. So these guys, we studied this association, this group. So that's why now we can collaborate more closely. So this is a big step, I think. Then we met John Kerry. Yeah, he's Anna president, and actually I presented Anna almost 20 years ago, maybe in San Francisco. At that time, this is the first presentation of HUR in Anna, actually in US. At that time, after my presentation, everyone says just crazy, actually. Why you just fix the glenoid? So, but 20 years later, yeah, John Kerry invited me the Anna specialty there is an innovation lecture. Actually, it's great honor, and thank you very much, Dr. John Kerry. Yeah, this is a great honor. Yeah, anyway, HUR has gained widespread acceptance worldwide.
March 6th, tell them.
Yes, next week. Yeah. So it sure has moved forward over the past 5 years, I can say. And here's the innovation life cycle: discovery, proof of concept, engineering, prototyping, commercial, and adoption, and standardization. Actually, now already we finished 1 to 5. So now we are adoption and standardization, I think. So in this group, I think that we focus on this number 6 and number 7 now. So finally, I want to tell rationale of SQL or SQL input short function with a rod cuff repair. SQL input short stability, input delta function. That's why they can level arm and also decrease the pain. Like it's a space effect. Then input the delta function. And also we make a site suturing posterior side and also subscapular repair, input tension, subscapularis, and the infraspinous tendon. So then we restore the fourth couple. So that's why it shall improve the shoulder function. So to achieve these biomechanical benefits, I can say graft is the key. So that's why today many doctors are talking about the graft and various graft material and the technique, I think. So you can enjoy the talk. Thank you very much today, and yeah, please enjoy today.
Next, we'll hear from Dr. Lee. Let me know if that's working.
Let's go forward. Well, it certainly is a pleasure and honor to be here. It's great to see all the familiar faces, and I can definitely see I'm getting old. There's no question about it. But I decided to change my talk last night just because the audience, I was going to just talk about all the engineering things. How come I can't see it here?
I don't know. He's working on an update.
Okay. Picture that Dr. Miyata showed. This is actually 2 years before that when he was finishing his fellowship. And he has to be like one of the smartest guys I work with. And he has true grit because he still holds the record. The first paper that he wrote with me, I made him rewrite it 42 times. And I have every version. But that just went down to almost nothing after 2-3 papers. So, which was really good. And I really want to thank Dr. Paul Roach here. This is just an amazing first meeting, and he always came up and talked to me about the concept. So today I'm going to spend time talking about the thought process and some of the things I know you guys seen it before, but I couldn't really get into depth. But this is a very systematic way of thinking about a joint, and you can simplify it, and you can apply this concept to anything that you do. So that's what I'm going to talk about. So these are my disclosures. So I always talk about how shoulder is the greatest range of motion. We all know that. But that also makes it really complex because that means there's much more interaction going on between different types of systems that are in every joint. And it's important to note that there are passive and active. So muscles are going to move. Passive things like bone, it's not going to move or do anything. It's going to provide hard surface. And then there's soft tissue that's got complex anatomy that is designed to do what it's supposed to do. Shoulders does a lot of things. And reason why engineers have problems really trying to replicate this and study this is that this is a combination of a lot of complex motions. And then the magnitude varies. So we have to have a systematic way of thinking. And I try to teach that to my medical students and residents as well as where I would talk about it. And this is a system I've been using for ever since Dr. Savio Wu kind of explained this process to me, and it kind of stuck in. So I say this to my students now. He used to tell me, you're an engineer, you should be able to study any joint. There are a lot of people just stuck on one joint because we're all using same mechanical principles. Only initial and boundary conditions change, which is anatomy and function. So how do we look at this? So basically, every joint, you can break it down. I talked about complex interplay. For it to work, it has to have interplay between all these things. So passive stabilizers, first in the shoulder, it's the glenoid and the humerus. If there's a glenoid defect, that's what you have to think about, and you got to think about what it's doing. So you have a convex humeral head, and concavity compression somewhat stabilizes it, and you have systems to make it work, like the soft tissue stabilizers. That's passive soft tissues. They're the capsules and ligaments. they're going to keep it in the joint so it won't come out of the, and then bone is mainly designed for mid-range of motion because it keeps the center. Now, when you get to extreme range of motion, it's a ligament that kicks in, or the capsule kicks in, and it stops the humeral head from going out. And the active stabilizing muscles, they're going to work everywhere. So whenever something breaks or something you have to fix, if you can anatomically fix it, great. But if you cannot, if you're doing something else, you have to think about what it's doing, what you're replacing, and can you compensate for loss of function. And a lot of things are not anatomic and they work great. Like even implants, they look like they're anatomic, but they're far from being anatomic. But they work great because the expectations and all the good work that you guys do. You guys probably know by now, I'm not a real doctor. I'm staying here talking about it. So, so rotator cuff, basically you all know this. But the important thing to recognize that what it has to do. It keeps the humeral head in the joint. And for other muscles to work, it's got to be a humeral head depressor because you got the acromion on the top. You got to push it down so deltoid can work better. And you can't forget about the whole thing is you're trying to keep the humeral head in the joint for a long time so it can work. So what does it take to look at things like this? So passive soft tissue stabilizers, they do very different things than bony defects. And the tendons, the muscles, they also do very different things than the capsule and the ligaments. It's really important to know that. And even within soft tissue passive stabilizers, can't forget about the labrum and the biceps. So when you think about, when you break it down to these three components and look at what it looks like and what it's supposed to do, and then you as a surgeon is trying to rebuild that. When you don't have everything to rebuild it anatomically, then you got to start thinking, well, can this compensate for this? So that's exactly what superior capsule reconstruction does. A lot of the arthroplasts, especially reverse, does that because you're thinking about the function and then you have certain parts that are gone, but the design itself has to take care of the parts that are gone. So we all know that by now it involves superior capsule and the tendon tear. And once you get this massive tear, there's not much left to depress the humeral head. And even when you do superior capsule reconstruction, you still don't have your supra. So you got to think about that. And I'm going to explain that's why Dr. Miyata's SCR is the way it is. So this is same principle I've been using, but I was educated on where it actually came from. So it was first described by a guy named Louis Sullivan. He's an architect. He said the object's shape should be based on its intended purpose. And most important consideration for any design is what it's supposed to do. So if you put it simply, if it looks like something and you think it'd be good for something, basically the function and the form, they correlate, they go together. If something looks totally different and you're compensating for something, you might be barking up the wrong tree or you're thinking deeper than others and you know it's going to work. So like human body is amazingly intricate and complex, but it's designed to do very specific things. And it's fascinating when you start looking into it. And obviously that's why you guys are in orthopedics. And I try to get that message across to a lot of my students and residents. So Dr. Ben Kubler should be coming out very soon. It's a really good paper. He's using that principle to look at clinically significant labral injuries in athletes and describes it really elegantly. So when it comes out, it'll be a great paper to read. So superior capsule of the shoulder, anatomically you can find drawings showing the superior capsule, but it wasn't really clearly described until 1990. And I can't remember when I got these anatomy and histology slides from Dr. Mochizuki. I think I was in Japan or China, and he gave a talk on this. So I asked him for these slides. They're beautiful slides, and it really shows the separation. And when I was talking about that passive stabilizer, soft tissue stabilizers, when it goes from bone to bone, it does very different than what tendon is doing. So if supra has two layers, one attaches to the glenoid and one attaches to the supra, it's performing dual function. So one of the things to think about is all the rotator cuff repairs that surgeons have been repairing rotator cuff, not the capsule. The capsule has a function which works like a check rein, so it actually protects the rotator cuff. So think about rotator cuff repair. even though you have a very robust repair, you don't have that protective fence or check ring underneath. So it probably gets overloaded. That's what I'm thinking. It hasn't really been shown by anybody yet, but Dr. Miyata also published rotator cuff, I guess, reinforcement using a very thin fasciolata. And those, by the time you do that, it's going to be super strong and it's going to protect the repair and it should make the healing go better. But also takes longer and harder. So those are also challenges that come up with it. So Dr. Miyata went over this. It's a significant anatomic structures. I'm not going to spend time on this. So like Dr. Miyata said, when he first told me about it, even I've been practicing those principles. I'm going, how can superior capsule reconstruction actually restore function? And these are the days when reverse was starting to grow like crazy. And basically, functionally, it does the same thing. You make the deltoid and the remaining muscles work. And the key component was keeping the head down. But superior capsule itself, as we saw anatomically, it's a significant structure, but it's not really that strong. You can't do two things at the same time because it's really in a biomechanically challenging environment. So what do you do? So proof of concept, you guys all read these papers. I'm not going to spend time on it. You went through different stages of capsular continuity, acromioplasty, what was that? Including the reinforcement. And then Dr. Tiboni, we're talking about this procedure, and obviously there are other factors involved as well. What are we really doing? Because we felt like we skipped a step looking at the native superior capsule, comparing it to fasciolata grafts that Dr. Miyata uses. So if you look at those, overall, even though Dr. Miyata's graft is super thick, the initial stiffness, ultimate load was about the same, but they're structurally different. And if you look at the failure mechanism, it's not the graft that's a problem. It's actually the fixation most of the time. And that's why, like, when I look at biomechanics papers coming to JSCS, people just typically do report initial stiffness and ultimate load, but there's a lot more information. This paper has all the detailed information. And also the explanation of failure modes and sequence of failure is critically important to look at, because when you look at that, then you know where the weak point is and you know where the strong point is. So it can actually improve your surgical strategies. So I'm purely looking at all this from like structural and mechanical engineering perspective, because even though it's human body, to me, it's all structures. So by understanding it, it makes things actually simpler. And people ask me, why do you publish papers in every joint in the body, and even the spine? And I'm going, it's the same thing. Just got to do the right thing. So I think it doesn't get much attention. This is one of the real important papers for SCR. When we actually looked at the kinematics, it shows you acromial-humeral distance. It actually depresses the humeral head. But with Dr. Miyata's, it depresses the humeral head, but it actually depresses it more than what normal capsule would do, because it has to compensate. So obviously it doesn't do much once you get your arm up because it's deltoid, but when the arm is at its side trying to initiate that abduction, that is critically important. You can see the lower curves of SCR, different abduction and different curves show different levels of depression with the arm at its side. So this functionally demonstrates what Dr. Miyata's SCR is intended to do. So Dr. Miyata's SCR, I think first thing is unquestionable advantage of the autograft. And second is it effectively depresses the humeral head. It's a thicker, stiffer, stronger than most of the graft materials out there. And thinner graft, I think that's one of the primary reasons that dermal allografts failed. And I had some crazy discussions with Reinhold. You can see how that went. And he would be on my face. We've done 3,000 cases all day. Well, I go, not going to work because it's got to do more work than what you're thinking it has to do. And I think the important thing about the shape and the thickness for Dr. Miyata's graft, what it does is by making it thicker, obviously structurally it's bigger, so it's going to decrease the stress that's going through the graft, but keeping the humeral head lower actually also decreases the stress going through the graft and protects the graft. So it's a structural adaptation, like how your body would respond, where Dr. Miyata's doing that by design. So I encourage all of you to kind of think about what bone's doing, what ligaments and capsules doing, even the labor and passive, and then what the tendons are doing. And at different positions, different demands, they're going to do different things. And depending on what your patient's expectation is, that's how you want to design your reconstruction strategy. Again, it's a passive stabilizer, structurally robust, but not that robust. And it's trying to compensate for both active and passive stabilizers. So something has to change structurally. That's why it's so thick, and that's why it has to be. And again, thing you want is depressing the humeral head and decreasing mechanical demands on the graft so healing can occur more effectively. So this paper came out a few years ago. And of course, we need this because when new thing comes out, everybody tries it. Everybody has their own ways. They come up with all these variations from, I started telling people, you can't call, like biceps SCR, you can't call this SCR because it's not. So, so all those things are variants driven from this concept to make it easier, make it more novel, somebody having different ideas, different applications, which is great. That's how we're going to advance the field. And I think in this country, like Dr. Miyata was saying, graft is really important. If they can pre-make the suture grafts, different sizes, and that'll save half of the time and make it easier to develop proper instruments to do it. It's really, truly an honor to be here around all you smart people. I always tell people, actually, I'm not that smart, but I'm smart in a way that I only work with smart people. And yeah, it's going to be fun, I think, because I think it's not, I know Dr. Roach calls it Miyata SCR, reintroducing it to US, but it's actually, we're trying to improve understanding and educate on how to think about these things and what it's exactly doing. And if you intended for certain reconstruction to do something, is it really doing it? And if you break it down, you can figure that out. So all of you, you're always welcome. I'm over at Creighton now. We got a bigger and better lab. I'm loving the life out there. So if you want to do any studies, feel free to reach out. Thank you very much.
Dr. Hasegawa is going to discuss his graft technique for Dr. Miyata and all of his great work.
Okay, good morning, everyone. I'm Aki Hasegawa from Osaka. I've been working under Miyata for more than 10 years for not only preparing a graft, but also shoulder surgery by myself. Okay, so today's my topic is graft harvest, preparation, fixation, and biology, all fascial related topics. So as you know, SCL is developed by Miyata, and the principle of SCL is to reconstruct the capsule and stabilize the glenohumeral joint. So to achieve this stabilization, the graft material and graft stiffness is really important. So this slide shows the optimal length and width of the fascial lat graft. The optimal width of the graft is the same as the width of the superior capsule defect. And also the length of the graft is distance from the glenoid to the lateral edge of the greater tuberosity plus 1.5 centimeter to ensure the footprint on the glenoid side. And Miyata have determined the optimal graft thickness by this biomechanical study. He compared the subacromial contact pressure and superior translation among 4 conditions. So intact conditions and rotator cuff irreparable supraspinatus tendon tear model, and SCL by using 4 millimeter thickness graft, and SCL using 8 millimeter thickness graft. This is the result. Left panel shows subacromial contact pressure, and the right panel shows the superior translation. So after creation of the irreparable supraspinatus tendon tear model, both subacromial contact pressure and superior translation were increased. And after SCL using 4 millimeter thick fascial lat graft, subacromial contact pressure was decreased. However, the superior translation wasn't changed. And however, after SCL using 8 millimeter thickness graft, both subacromial contact pressure and the superior translation were decreased. So the 8 millimeter thick is optimal graft thickness to restore the superior stability. This is my video of graft harvest. I usually make the 13 centimeter skin incision and expose the fascia ladder. Gelpi restructures are very useful if there were no assistant for me. And after making the incision size, I usually use a bobby to cut the proximal, anterior, and distal side first. And after cutting the anterior, posterior, anterior, and proximal distal, we flip the fascia ladder. Then we can find the intermuscular septum here. And including the intermuscular septum is a key point to achieve a graft thickness. So I usually harvest the fascial ladder graft, including intermuscular septum. Next video shows the graft preparation. Usually the anterior part of the graft is thinner than posterior part. So I usually put the fiber of the intermuscular septum on the anterior part to reinforce the anterior part. And adding the stage sutures, then I fold the graft and the suture around the graft. And lastly, I usually add the horizontal mattress sutures to make the graft stiffer. This is really important to make the stiff graft. So this is the final view of my graft. So usually it's 8 millimeter thick. And this video is arthroscopic HCL that I performed. First, we measure the size of the superior capsule defect to determine the width and length of the graft. Then we place two suture anchors into the superior glenoid. The anterior one is through the anterior edge of the AC joint, and the posterior one is through the Nevisor portal. And next, we insert two no-trace anchors with tape materials on the medial lobe of the humeral head. After inserting all anchors, we usually insert the 10 cc syringe with longitudinal slit and retrieve the humeral side tapes and the sutures first, and then pass all sutures and tapes through the graft outside of the body. Then reinsert the syringe and retrieve the glenoidal anchors, tape and the sutures and pass through the graft, and insert the graft inside the SAB. After, then we tie the knot on the glenoidal side. So usually two horizontal mattress sutures for the glenoidal side. And then we fix the humeral side using the speed bridge technique. So one pair of the tapes are fixed by the 4.75 no-trace anchor for the anterior side, and another pair of tapes are retrieved and then fix another 4.75 no-trace anchor posteriorly, and then tying the knot of the medial lobe. And lastly, I add two side-to-side suture between the graft and infraspinatus tendon to make the continuity of the superior capsule and the graft and the capsule. This is the final view. And lastly, I'd like to introduce my histological study using the rabbit model. I think I performed the most cases of the rabbit SCL in the world. I used 24 Japanese wild rabbits. So first I created the irreversible rotator cuff theorem for both shoulders. And 4 weeks later, I performed the SCL for only right shoulder using the fascial ladder allograft. And the shoulders were harvested at 4, 8, 12, and 16 weeks after surgery for histological analysis. So this is a rabbit shoulder. For the initial surgery, I created the irreversible rotator cuff model by resecting the distal segment of the supraspinatus tendon and muscle to expose the superior glenoid and the greater tuberosity. And 4 weeks later, I harvested the fascial ladder from the ipsilateral side of the same rabbit and then made the double layer graft. It was 1 centimeter by 1 centimeter by 1 centimeter. And I performed the SCL using 2-0 nylon with bone tunnel techniques. This is a macroscopic findings. So after SCL, we can see the graft from the glenoid to the humeral head. And the untreated side shows only the scar tissue over the humeral head. And this slide shows the softening or staining of the fascial bone junction on humeral side. And 4 weeks after surgery, we cannot find any chondrocyte-like cell. But over time, we can see many chondrocyte-like cells. And 16 weeks after surgery, we could find the unmineralized fibro cartilage and tide mark and mineralized fibro cartilage. It's like a normal structure of the tendon to bone insertion. And immunohistochemically, we could find the expression of the type 2 collagen in the newly formed fibro cartilage. And this slide shows the granular site. 4 and 8 weeks after surgery, we cannot find any chondrocyte-like cell, but 12 and 16 weeks after surgery, we could find the fibro cartilage formation. And the type 2 collagen was also expressed on the fascial bone junction as well. And this slide shows the HE staining of the meat substance of the granite fascia of the grafted fascia ladder. 4 weeks after surgery, the fiber orientation and the cell arrangement were really disorganized. However, 16 weeks after surgery, both the cell arrangement and the collagen fiber orientation became parallel to the long axis, like a normal tendon ligament-like tissue. So this is the final slide. So SCL using fascial ladder autograft regenerated fibro cartilageous insertion in both the greater tuberosity and the superior glenoid. The mid-substance of the glenoid and the grafted fascial ladder gradually remodeled into tendon ligament-like tissue. And the fascial ladder autograft has the capacity for graft to bone healing and remodeling after SCL. Thank you for your attention.
Any questions or comments for our thing? Brett?
We've noticed different and positive healing characteristics with bone tunnels. And I know they don't make, rabbit-sized anchors, but any thoughts about perhaps the bone tunnels? And there's some evidence of increased fibrocartilaginous healing through bone tunnels, potting grafts and sockets in rabbits.
Yeah, for the preliminary study, I tried to use the anchor for the rabbit model, but the minimal anchor was still too big for the rabbit model, so that's why I used the bone tunnel procedure.
Yeah, the bone tunnels elaborate the bone marrow, directly into the site and have totiopone stem cells. So that might be a contributing factor to some of the biology of the graft.
Mm-hmm. Yeah, it might be one of the reasons, but I still believe that the cannulated anchor still has the same effect to introduce MSC from the bone marrow.
Yeah, Dr. Hasegawa. So did you change your rehab based off of the study you did? Because we changed our rehab off of your paper.
For human?
Yeah, we don't treat many rabbits, but yeah, for humans, yes.
For human. So we didn't change at all. So we still use the same protocol from the beginning.
Okay, thank you very much. Clara, you're up.
So good morning. I have the honor of introducing the next speaker, Dr. Anthony Romeo. Name speaks for itself. And he's going.
And so we have a lot of people that come to us who are not doing well and their cuff repair or their cuff we don't have a good way to repair them. And we wonder what's the best option. And in a person that does shoulders, we see this every single day in the office. It's not rare. And how do we define irreparable? I think it's really more about what is going to heal and what's not going to heal. I'm sure we could all put sutures into anything and say that we repaired it and it didn't work. We have some good prognostic tools. I think a lot of us are using this at least as a guide in terms of what we're doing. And we talk to our patients about this ahead of time. And Pat Denard and others wrote this up where if the Rohe score is more than a 7, then we're talking about some type of augmentation for our patients, even if we can repair it, because the healing rate seems to be so low. We're still worried about age. We know that after 70, the cuff doesn't heal very well, so that's a problem too. We want to make sure that we are not overstepping our boundaries. Here's a gentleman who has anterior superior escape and a soft tissue repair is not going to work. This lady had multiple rotator cuff surgeries and guess what? Didn't work. So soft tissue doesn't work for everything. So when we look at massive cuff tears, this is the way we can kind of separate things out. And we've been repairing and augmenting and then going to tendon transfers. But Dr. Mihata has taught us that there's an option that we can think about for many of our patients to reconstruct the anterior posterior force couple that will make a big difference. So you can turn the sound off on all my videos. I don't need any sound. Thank you. I actually put it on mute, but that's okay. So, we started talking about this many years ago, not as early as Ty and Dr. Mihata, but we were adding grafts. Steve Snyder talked about adding augmented grafts. And we actually had pretty decent results when we used allografts and autografts. Xenografts didn't work for us. And so we reported this years ago. But I think the one true innovation was fixing this tissue on the glenoid side. Everybody was trying to repair it to a sick muscle tendon unit. And Ty and Dr. Mahata came up with the idea of fixing it securely on the glenoid side and the humeral side so that it holds the head down. So that was really the most important revelation that we've all learned from this. We know that it makes a stable center of rotation. It is an interpositional spacer, and it creates that capsular continuity for anterior posterior. And we know, as you've heard, it's very important for the overall conduction of movement of the shoulder, and that's why we need both for this to work. And certainly Dr. Mahata's technique is the gold standard without any question, but I'll be honest with you, this is just not acceptable in most parts of the United States. To talk to your patient ahead of time about an incision this large that can have some complications, we just are not ready in the United States for the fact that I have to have this other operation to make my shoulder better. So maybe in some parts of the country that's happening, but it's not so easy to sell that in where I'm from. So I chose the dermal allograft, as many others have in the US. First of all, because there's no donor morbidity. We thought the outcomes were similar, but certainly there's some room for argument there. And again, it's patient friendly. So we can take this type of situation here and do a reconstruction. And our typical patients, very similar to yours, and we're trying to get them back. Here's a gentleman who had 2 prior cuff repairs. He's a worker. He couldn't even reach up to grab his mirror or his sunglasses in his car. And here he is just about 6 months after his SCR. So we do this in patients who don't have arthritis. I'm not a big fan of trying to stretch the boundaries and to go to even grade 3 Hamada scale. We know that drop off traumatic, and I'm not a big fan of thinking about that I can reduce or take away everyone's quote pseudo-paralysis. It's true pseudo-paralysis with anterior superior escape. This operation doesn't work in my hands. There's a lot of things you have to do. So when you say, well, I just have to add a graft on the leg, 2.5 hours is a good time. Added that also, which tells me that they've got a team of people that are involved. But if you're a surgeon in the United States and you're by yourself and maybe one other person, that is a big extension of your procedure because there's a lot of other things you're trying to do to solve this problem. I do this in the beach chair position, but certainly lots of other ways to do it. We're always going to address the biceps. There are some times now we actually use it as part of reinforcement, not a biceps SCR, but if it's not bad tissue, we can actually incorporate that into our repair and strengthen the anterior band. We do all these other operations as needed, and then sometimes we're left with this. And so for me, we've written up this technique just a few years ago, exactly how we do it, so I'm not going to go through all the steps. There's just a couple of key things I wanted to mention to you that we do. Let's try to get to advance. So obviously you need to prepare the glenoid and the tuberosity. We used to use these anchors. They were not that user-friendly. Most of us have switched over to the knotless anchors. It's like night and day. Basically, you put the knotless anchors in, you put it on your graft, and you just pull on the sutures, and it reduces it exactly where it needs to be. You don't even have to tie a knot. It's done. Really makes a huge difference, and that has really helped speed along the procedure. We usually use 2 or 3. I heard one through the advisor portal, one up by the coracoid, but a lot of times the infraspinatus is involved, so we're putting one just below the spine and the scapula into the back part of the shoulder. We have our measuring devices, as you've all seen. Get our graft ready. We'll pass it through. This is the medial border with the knotless anchors. Look how nice that looks. And literally, you can pull on like you're almost lifting the shoulder off the table, and that's how securely you can get it down. So that's really made a huge difference for the medial fixation. We also know there's some tension to tighten the graft, and I think this is one of the areas where the tensor fascia lata and allograft, you have to be careful about this, and that is learn from Gus's lab in particular. When we're doing this, you need to put the arm at about 45 degrees of abduction before you fix your dermal graft. This has too much elasticity to it. And if you do that, you can take away the superior migration when you move the shoulder in the lab. And so we are very purposeful. Before we fix it laterally, we've got the arm in abduction to make sure we put tension in that graft to help with our downward pressure on the humeral head. I think that's important. Not everybody does that. And then once everything looks nice and secure, we incorporate the rest of the patient's tissue, whatever that is. It will always do the back, but sometimes even the front. People used to worry that you would over tighten the shoulder if you tried to repair some of the rotator interval tissue. Just externally rotate the arm and sew it in. It really helps secure down everything. And then we extend it more. Here's a person who's had a couple of cuff repairs. Their tissue is very, very thin. There's not much of a superior capsule there. So we'll go ahead and put a superior capsule in, and then we'll put the patient's rotator cuff over the top of that, and that's going to work much better. So once we get it in, it's nice and secure. You can see it just sticking out the corner there. The rest over the top is the patient's very thin rotator cuff. And we published on this, and this is actually very useful to what, if I get the cuff that looks bad, it's a revision, it's very thin, we will do an SCR and put the remaining cuff over the top. I think that's definitely improved our results. I'm sure we're going to learn more about how to regenerate all these tissues. We're using scaffolds. There's probably places where cells and proteins and others, but we don't know the answer yet. It's pretty interesting. In the US, we see people who, I don't know why this just keeps stalling on me, who try to do everything. I saw a case this week where they did an SCR, they added PRP, and they put a balloon in. So, $10,000, $12,000 added onto the surgical procedure, that there's no additional reimbursement for that. So I don't know who's paying for that. And certainly there may be some combination that works, but we don't know what that is yet. But for me, this is the right answer for a patient that has this problem. And it seems to work pretty well. That's a classic example. We do it in revisions. I haven't done 1,000, take a zero off, almost 100. And I'm really happy with this operation with the right people. And so we continue to offer that. What we've been taught, how well this works. Steve Burkhart and his team went through this and early on had some concerns about things, and they had a few of these fail, and they failed on the humeral side. They did very poorly. When they failed on the glenoid side, they did okay. And so that's led to some new ideas, but he was very worried about this whole idea about graft healing. And especially a group of his patients had to go to the horrible reverse shoulder arthroplasty. In his mind, that was a failure, but it really is not a failure after this lady's had 3 rotator cuff repairs, to be able to do this is not a failure to get a reverse arthroplasty. It's just a salvage procedure. He published his own separate series away from his group, and out of the 63% he had come back, he had 85% healing. So he reported somewhat better results, but he really didn't have a full follow-up. Final thing I want to talk about outcomes in terms of patient perspective. This is work that we did with a lot of my patients. Workers' compensation claims, that's not a positive, but it was high in our group. Prior surgery, more than half of them. So this is not a primary procedure for us in many cases. Some of my partners were doing it for arthritic cases, which I don't do. And so I don't think that's a good idea. You can see some of them were doing them even when the subscapularis was torn, which I know definitely reduces our results. And we really looked at these anchor questions to try to find out from our outcomes. This is what we saw, is that it's a good operation. It's a good pain relieving operation, but don't fool yourself. You're not making their shoulders normal again, and don't sell the patient on that either. I mean, what we saw here, the minimally clinically important difference was, 60%, a little bit higher than that. And then the really substantial clinical benefit was about 50-50 for a lot of our patients. So they're better, their pain's better. But if you really ask them this question, considering all the activities you're doing in your life, your level of pain, your functional improvement, do you consider your current state satisfactory? 50%, all right? So we have work to do. Failure was significant with subscap tears. We all know that. Gender, sex, females did not do as well. Work comp status, particularly heavy physical demand, and age over 70. Remarkably, distal clavicle excision was a positive in our group, and then low scores preoperatively gave us a better amelioration rate and ability to get higher scores. So, this is important information to understand. And then we've also looked a little bit at the failures, and I just wanted to comment on the fact that there's this growing interest in our country that since if it fails on the glenoid side, but on the humeral side, it still works pretty well, well, maybe we'll just put it on the humeral side. And so there's a number of studies that come out and showed that healing didn't actually affect the outcomes, which of course would fly in the face of the work that's been done by Dr. Mahata and his team. But it's interesting here from this AOSSM meeting, if you look here, if the tuberosity was bare, they did poorly, but if they did covered, even if it failed, they did okay. And that's why some people are talking about just putting a piece of graft on the humeral side as a spacer and as a smoothing device. And I think that that probably works in some patients, but I do think that I'm not quite ready to add that onto my algorithm and consider that important. But there may be some patients who don't want to go through the rehab, who are older patients where we might consider that. So the USA experience is good. There's still experienced surgeons that are publishing on this. The clinical results are acceptable, but a survey went out, 260 respondents, and significant decrease in the use of this procedure over the last 5 years. So this room has some PR work to do to teach everybody why this is a great operation. Thank you.
Thank you. Please don't leave, Dr. Anthony Romeo, because we're going to take questions for you. There's been a slight change to the program order. So are there any questions from the audience? If not, I'm going to start with one about that survey from the American Association of North America. So 85% of those surgeons were using human dermal allograft. I think only 5% were using fascia lata, those that abandoned the technique. So what do you think are the critical aspects of their technique that are making them have this high failure rate and making them abandon this technique?
Yeah, so I can't speak about the technique. I can just tell you that when the surgeons were asked why they were changing, it's because the outcomes of their patients weren't what they expected and what's been published. And so you can then suggest that, well, they weren't doing the right operation. That's a possibility for sure, but I don't know, exactly what was different. If you really look at the operation, it's a bit tedious. It takes time. And even if you're dedicated to this, it's one of those operations. I can do a reverse shoulder arthroplasty half the time I can do this. So it ends up being, you have to have the mindset that this is really the right thing for your patient. You have to spend the time and effort and do it. And I think that there's a lot of shortcuts that happen in some ORs. The graft goes in, maybe there's only a couple of anchors of fixation. It's not sewed into the rest of the rotator cuff. These little tiny details are really important if you understand the principles behind it, but I'm not sure that that's what's done in the OR every time. And then if you don't do that and you don't have a good outcome, you say, well, I did the operation, didn't work.
Yeah, this is a surgery of details. I agree with
A surgery of
details, a lot of details combined, and it takes time.
I say that to the fellows, I say, you got to think more like a hand surgeon than a shoulder surgeon on this case. You got to be really dedicated to details, and not everybody has that personality.
Tony, real quick, and Claire over here, I want to ask a question. You asked me because you're smarter than me, but I think Tiro first did a series with allograft fascia lata. And what are your thoughts on using a thicker allogenic fascia lata?
I think one of the ways to go is that we're seeing some incredible results with synthetic augmented grafts, and I think that one possibility would use as you saw, all the sutures that went in for that very, very sophisticated tensor fascia lata preparation, you're really suture augmenting that graft. There's no way that graft is the same if it didn't have sutures in it. You've made it stiffer and stronger. And I think that there's a possibility in the future we'll be able to use allograft with augmentation of sutures or tapes or whatever. And I would be surprised if the results are any different than using autograft. Yep. We can hear you. Yeah, thanks, Ty.
Yeah, I think all of us here agree that concept is good, and we have a lot of work to do. And I think there's a lot of growth that can happen, and it's not just the SCR, but variations of it for expanding the indication and so forth. Why did orthopedic community stop talking about this?
About the SCR?
Yeah.
Because it doesn't have an upside market. It's driven by industry.
At the end of the day, it's all about money.
It is. No, I mean, if you want to understand behavior, understand the incentives. And what's the incentives here? The incentives are financial. The financial incentives for the company are not there. It's flattened out in terms of its use and even gone down. And in addition, the reimbursement for the physicians, the facilities has gone down. So the margin to do these cases has gotten worse. In many cases, you cannot do this in a surgery center. You have to do it at the hospital because they have ways of getting supplements and other things that they can actually pay for the cost of this. But if you do it in a surgery center, your margin on a rotator cuff repair surgery may only be $2,000 or $3,000, and you're already spent your margin using this. So if you understand behavior, understand the incentives are pretty clear.
But I think all of us in here are educators, so I don't think we should forget the concept.
No.
Because we should teach those, and then people can come up with better ways. Maybe it'll be very profitable when time's right.
Yeah, no, I totally agree with you. And in principle, I'm exactly like you. If it's the right thing for the patient, that's what I'm going to do. Even if I have to bring it to the hospital and I have to get somebody to bring in some new equipment because the hospital has three series old arthroscopic stuff and they haven't been doing that for a while in our country. If that's the right thing for the patient, that's the right thing to do. But the problem is that it's the incentives are really challenging. It's all uphill, and it's easier to put in a reverse and get reimbursed for it, to be honest with you. So
One last question.
Yeah, Tony, it's a very simple question. I'm very curious. You're a very renowned surgeon, and here in the United States, we've been in some meetings in which the final message regarding SCR is dead.
right.
So I'm curious about what's your answer and how do you explain that you're still doing this procedure and in home?
I mean, I go right in the middle of the hotbed of where they say that we're really not doing SCR anymore. It's all biological tuberoplasty. It's easier to do. We've already created a kit that we can get a margin on, and surgeons that are much less experienced can put these in right away in 30 minutes, and they feel like they're getting results that are better or equal to what they used to get SCR. But reality is they didn't know how to do the SCR very well. So, and it's a complicated procedure. So the answer is that, again, it's being driven by something other than science. And that's the reality behind it.
Thanks so much,
Sure,
Tony.
sure.
So we're going to move on with Erika Colline. She's going to talk to us about preparation of a thin graft. I'm looking forward to this talk.
Okay, I'm short, so I'm gonna move here. Yeah, good. No, I think I prefer this view. Okay. Thank you, Dr. Mihara and Dr. Roach for inviting me in this very exciting meeting. My name is Erika. I'm from Indonesia, Jakarta. I work with Professor In Ho Jon for 4 years as a sidekick. Yeah. Graph master. Okay. Sometimes I tie, sometimes I harvest, sometimes most of the time I prepare the graph for him. So the rationale of my talk background is during my study, one of my systematic review found that the failure rate of a graph is very highly variation. So 0 to 55% because people are doing their own modification or their own preparation. So let's go back to the OT. Surgery went well. Until the graph is thinner than it's expected or planned. So everybody know from Dr. Lee and Dr. Mihara presentation, the graph is physics. It creates a restraint. It's a check rein. If the graph is the patch, it's a cosmetic. So thickness is not cosmetics, but thickness is physics. So, so we think about the ideal condition. We need the right thickness to restore the mechanics of the intact position of the shoulder. So Dr. Mihara already did a very good biomechanics study. 8 mm is the answer for autograft fascia lata. And for the dermal allograft group is 6 mm. But in some of the country, at least in Indonesia, dermal allograft is not available. So it's not allowed from the government, the allograft itself. And for a very nervous young surgeon, I think thick graft is very, very hard to be shuttle in the joint and very emotional. Yeah. So I think this is not a good condition for my mental health. So some study from Korea also mentioned that the thick graft can be somehow overstuffing. So it can create subacromial erosion. So this is why the thick graft is good. I agree with Dr. Mihara, but it really equal to success outcome. But not everybody can get a thick graft like you. It's very good technique. Sometimes it sucks like this. Yeah, okay. So it's maybe common. So a thin graft is very insufficient to the load. There's no stiffness, so it's stretched. The height is lost. Sometimes you can get it's intact. This is a classification we describe in the middle. It's intact, but it's not functioning. It's just a cosmetic there. So I came with an idea after just a casual talk in the cafeteria with GS and some urologic fellow. So well, they use a mesh in the OT, which is ready to use, but this is an off-label use. It's only around $20 to $50, depending in which country you work. So I put a mesh inside and fold it, and then the rest is same as you and what Dr. Mihara described and Dr. Hasegawa described. And then this is what it will looks like in the MRI. So you can see a small dot like a rail track on the top. That is the mesh. So this is for a 77 years old grandma, 3 years post-op. So what about the outcome? Of course, I want to be accepted in AGSM at that time. So I did analysis, and the graph with mass augmentation gave me 83% healing rate, which is still inferior compared to Dr. Mihata works. I think because of learning curve or volume wise. And the survival rate we reported is 83% compared to those without mass augmentation, 58%. So who wins and who doesn't after this mesh SCR? So these are the predictor parameters in my paper. So we check the prompts for the patient. The patient achieved 1 year to pass for the pass MCID and SCB. So it takes 1 year to be better. So you can use this to counsel the patients. And between age and gender, we know yada yada yada, the RCR paper, everybody talk about the demographic factor, which patient will do better. So the age can predict better prompts in terms of MCID and pass. It's better than the gender. So if you are older, I think much better than being a female at 2 years after the SCR. So again, regarding the age, I know I agree that reverse shoulder is very straightforward. It's a better procedure for, again, my mental health than the SCR. But when you do SCR with the mesh augmentation, you will not see this big gap in terms of failure rate. You can see a comparable failure rate, and the graft healing rate will be similar with the younger group. And then again, about the body habitus, this is where I was stuck, I think, burnt out because of the research work. So I start to look at the small things and the BMI, body mass index. So the SCR with mesh improved pain in all BMI patients groups, but the constant score is less predictable in obese patients. And then who wins and who does not win? So those who have a severe fat infiltration in the infraspinatus, of course, has a bad result. At least they will have a risk of tear around 5 times compared to those who doesn't have the severe fat infiltration of the infraspinatus. So again, it's very important to check the MRI, not just the fat infiltration of the infraspinatus. You can also check the signal of the graft. This is actually I copied this technique methodology from ACL study. So if you have a lower signal, indicates a better graft healing. And I think everybody knows this. So this can be translated if we want the patient to be moved, or sorry, let me rephrase. I'm very sleepy now. It's 12 o'clock in Indonesia. Okay, sorry. So when we should move the patient, right, after the surgery? So my answer is 3 months, because in the MRI, it showed decreasing of the signal. And I think it represents the graft has been remodeled, and hence it allows a strengthening. So you can also predict like fortune teller. Yeah, okay. If you see the MRI this color, the yellow one is a smile emoticon. So it's a great case to be. But if you can see, the stump is very black compared to deltoid. And if you see the rotator cuff stump is gray, I think the tendon quality is not good. So it's a bad case to be given SCR. So failure. I think I'm very nervous when I see this kind of MRI when I do evaluation after the SCR or when I was a fellow. It gives me a goosebump. So because I prepared the graph. Okay. The SCR failure, the AHT is very important. So the tear itself is not very intimidating. When the AHT is narrowing, it indicates the force couple is failed. So if it fails, the SCR, will you do reverse or whatever you want to do, or you just observe the patient? So if the AHT is intact, I think the patient doesn't need further investigation. This is 1 year after the patient has failed. We follow the MRI and then make the analysis. Okay, here comes the very, very complicated one. And I don't think this is quite primitive compared to your lab, of course. If you have a thin graph, maybe other strategy, share the load, okay, do the LTT and make things more complicated than it is already are. And then with a very small volume number of patients, 15 patients, the professor did the SCR with lower trap transfer. Yeah, it improved the pain and range of motion with a bonus of more improvement of external rotation, of course. So final take-home message, I have 10 seconds to finish. Okay, if the graph is thin, take a deep breath. Don't improvise emotionally. Okay, check your data, what works for you, what really not works for your patient is maybe there's find small differences. And if I may give you some insight from my point of view, for our point of view, you can actually reinforce if possible or share the load. Thank you very much.
Thanks, Erica. So we'll listen to your talk and then we'll discuss. Okay. So now we'll listen to the graft experience in Portugal. Ana Catarina Angelo, my partner in crime, will show how we do it in Lisboa.
So let's move this. Can I have that here? Okay, perfect. Okay, so hello everyone. I'm very happy to be here. I must say that we've talked about SCR 300,000 times in many places in the world, in many different meetings. And it's so good to be in a meeting in which people are actually interested in this technique and are actually moving to move this technique forward. So I'm very, very happy to be here. So our experience in Portugal, and I hope that this can be also your experience around the world. SCR, what have we been doing here? Try to understand the rationale. From surgeon perspective, from engineering perspective, it's very, very important. And when we understand the rationale, we have to ask ourselves, how important is our graft? How important is the material that we work with? And this is the boogeyman, okay? So look at it, run away, hide under your bed. This is the very, very bad thing that you get when you harvest the fascia. So Carl Jung, super wise guy, he said, thinking is difficult. It is. This is why most people judge. And this is what happens in our field. So when we try to change something, when we try to improve, the first thing that we need to do is try to understand what we're adapting, to try to understand what we're doing to our patients. And sometimes this is not easy. And it takes time and it takes brain. And most people just go. So what we're going to do here is try to understand why SCR works. We've been doing this here already, and why the graft is so important for it's working perfectly. So we've heard much more clever talks than mine regarding the biomechanics of the shoulder. So my father is an engineer, my brother is an engineer. I degenerated to a doctor. So this is my very simple slides about how I understand the engineering behind SCR. So the shoulder, it's a force couple joint, okay? So we need our vertical and our horizontal force couple. And what I like to explain to my patients is that we need to keep the head of the humerus inside a box for it to function it. And this is super, super important It's super, super important for us to achieve this beautiful range of motion that the shoulder has, and it's unique for this joint, and we love to see it move like that. So when we abduct the shoulder in the scapular plane, it's super important to have a counteracting force to our deltoid, a fulcrum, okay? If we have a superior cuff and capsule tear, what happens is that our center of rotation in the vertical plane goes up due to the force that the deltoid exerts on the humerus. So by physics, what we know, and again, I'm sorry for my very simple slides, is that as close as the lever, as the fulcrum is to the origin of the force, the greater the resistance. So when we have a tear and the fulcrum becomes maybe the acromion, the origin of the force is the insertion of the deltoid fibers becomes very close to this fulcrum, and the resistance of the arm becomes very, very high. So this is one of the principles why reverse works. So you actually distalize the fulcrum. You make the fulcrum even more distal than the original shoulder, and this decreases a lot the resistance that the deltoid needs to do. So what we do with SCR, very simply, we try to restore this lever. We try to restore this fulcrum. Okay, and this is very important, and we talked here before, that this helps our patient to regain its scapulohumeral rhythm. This is why the patient keeps improving. We have teres data that after 2, 5, 10 years, the range of motion keeps improving, and sometimes the strength also keeps improving because we give it back the scapulohumeral rhythm. Okay, so let's talk about the graft finally. Why is the graft so important for this? So the graft is important because in order to accommodate this very complex range of motion that the shoulder has, the graft needs to be strong, yes. It needs to be resistant to all the forces and kinds of directions that the shoulder goes into. It needs to be elastic, and this means, correct me if I'm wrong, that it needs to deform and come back to its original form. So it cannot be plastic. It cannot deform and come back to an unoriginal form. That's what happens with a lot of grafts. And ultimately, it will need to heal. So to last, it will need to heal to recreate this capsule and the negative pressure inside the shoulder. So we know Teru. We've seen this paper several times today, but this is the iconic paper. So he brought us this amazing technique in 2013. For this, he harvests, as we've seen today, very well, the tensor fascia lata with the intermuscular septum to obtain a very thick graft. And since then, the orthopedic community became very, very interested in these clinical results, but maybe this graft was not the ideal graft. Maybe we could try to do this technique with other grafts. And don't be scared about this, this big table. It's just to show you that in the years that followed Teru's paper in 2013, there was a lot of papers regarding SCR with different grafts. Some of the authors are here amongst us. And when we see that clinical scores pre-op to post-op, they all actually improve. But if you ask a family that lives on the street, and if you give them a 2-bed apartment or a penthouse, and if you ask all of them if they improved, they will all say they improved. And you cannot conclude that a shack is the same as a penthouse, okay? This is why MCID is so important. Regarding range of motion, things are a little bit more sketchy. So you see that the fascia lata, the range of motion improves. In the other graphs, you see there's a lot of heterogeneity. There are some papers that actually don't mention evaluation of range of movement. And also in some papers, you have the range of movement evaluated by a telephone survey. I don't know exactly how you do that. Regarding graft tear rate, here, when I say that the shit hits the fan. So, yeah. So here we have the real numbers. So here we have a lot of heterogeneity, especially regarding the human allograft, where the patients were not completely assessed. Some of them were excluded from the MRI evaluation, so we don't really have reproducible results. And actually the graft tear rates were high very, very early, 6 months to 1 year after the procedure. And this also led to very high revision rates very early after the procedure. So this, I think, it's why in America today they say that SCR is that. But if we look at the up results, we see that SCR is not dead if you use the right graft. So Buddy, he was supposed to be here. I don't see him here. Yeah. So Buddy, he published this editorial commentary that I loved that actually says what we all know is that we have a lot of systematic reviews that conclude that there's no difference between this and that, but this doesn't mean that things are the same. So we need to be very criterious when we look at the literature. And actually, there are some systematic reviews that if you look into them, you realize that there's actually a difference. So in this one regarding constant score, you see that SCR with fascia lata completely tops all these procedures, way above the minimal clinical important difference for cuff repair in and reverse, And even in the AZ score, this is another systematic review, SCR with fascia lata completely tops all of the others, including SCR with human abdominal allograft and some transfers. So does the graft matter? I ask you, does the construction work matters when you're building your house? So do you want it to build to last forever? Do you want to spend an extra amount of money for your house to be very, very good? So this is the same about SCR. So this doesn't matter. This is crucial and it's central for the technique to work. So Tero brought us this amazing car. So 6.5, 800 horsepower, incredible. We loved it, but the orthopedic community said, okay, but maybe this engine is too noisy. So let's try the same car, beautiful, but with a less noisy engine. So this still looks great. It does. It still works. You can actually drive it everywhere. You can go grocery with it. It even has less fuel consumption, but guys, this is not the same car. Okay, so why fascia lata? Because it's the original graft used. It's brought us this groundbreaking clinical results with Tero. It's biocompatible. It has the ability to heal. It's the patient's tissue. It's a biomechanically versatile tissue, so that can accommodate all this biomechanically complex motion that the shoulder girdle has. It has been used as a graft and still is in almost every surgical field. This is not a new graft, guys. This has been used everywhere. It's always there, unless your patient was amputated bilaterally, which fortunately for us, it never happened. It's always there, so you can use it. You can harvest it anytime. So this is our experience. Again, we're here with Tony. So one less zero than Tero. So we have 100 cases, not many cases. The indication, it's crucial also, as Clara is going to explain to you later. We use 3-portal. We use no special devices. And we harvest the mid-thigh fascia lata. So this is how we position our patient. You're going to see it better in Clara's talk. I'm not going to take long with this. And this is the very, very complex instruments that we use for our harvesting that are available in every OR. So if your nurse says that she or he doesn't have a very long scissor, just ask them to open the urology case because they're usually there. So these are our references. This is how we harvest our mid-thigh fascia lata. And we didn't invent this. We adapted this from an ear, nose, and throat paper because they've been using fascia lata to do rhinoplasties for many, many years. So we adapted from them. So we aim to actually avoid the tensor fascia lata, and we aim to avoid the iliotibial band. And this is how we do it. So we start by incising the skin more or less 2 centimeters, and then we dissect over the fascia lata and beneath the skin all the fatty tissue. This was a relatively thin patient. We usually have patients that are a little bit more fat, but it's doable. It's doable. So you see that you use a cob regime very smoothly, and then you just incise the fascia lata. You have to be careful not to go too deep, not to incise the vastus like that. You grab it and you're going to release it underneath the fascia lata. And then it's very simple with this very, very big, this is Portuguese urology scissors. I don't know if in other countries it's like that, but you just unite your 2 transversal incisions and you retrieve the graft from one of the incision. Usually you get a 15 per 4 or 5 centimeter graft. This is the look of it. We fold it 1 time longitudinally, 2 times transversely, and since Erika's an in-hole paper, we have been interposing also this mesh that at least in Portugal costs 30 euros. So it's not expensive at all. And we feel like we have a very much robust graft after that. So of course we were very preoccupied about donor site morbidity when we started doing this technique. We published our preliminary study, which was only 15 patients very early after we started in 2018. And we concluded that after 1 year and a half, every patient was either satisfied or very satisfied about the thigh. And regarding the non-arthritic hip score, there was no difference between the harvested thigh and the contralateral thigh. A few years later, we did a little bit more scientifically robust paper in which we evaluated 39 patients with a 4-year of mean follow-up, and we concluded that 95% of the patients think that the symptoms that they have in the thigh are actually very much compensated by the outcome in the shoulder, and they even those who have some paresthesia on the thigh, they feel like it's not significant. Regarding clinical scores, they're very good and they're not significantly different from the control group without a harvested thigh. So one picture says more than 1,000 words, and I think that I surpassed my 1,000 words. These are some of our first patients. So you see they still have their legs, so they haven't fallen apart. And it's super nice, and I'm sure that a lot of you have experience with the SCR, are very fond of this technique because it's actually changed our lives. It changed our algorithm. We have this amazing option to offer our patients right now, and sometimes you can see patients that are in very much pain, so limited, and they have such good results very early, even at 3 months post-op, and then these results just keep on going year after year, and it's very, very gratifying for a surgeon that actually follows their patients for many, many years to see that they are super fine. Again, take a look at the boogeyman. We did a course a few years ago on SCR and tendon transfers. It's on BMed if you want to check it out. Everything is recorded. So we talk a lot about SCR there. And this year we're having also a small course in Lisbon on challenging rotator cuff tears, in which we're going obviously to approach this. If you want to join us in Lisbon in September, enjoy some sun, some surfing, you're very, very welcome. Thank you so much.
So we'll discuss after 4 presentations. Katarina, thanks so much. And now we'll listen to May from Thailand, who's going to tell us hybrid graft experience in Thailand.
Yep.
Hi, everyone. I feel really excited right now. I'm just a small guy from a small country in Southeast Asia. Maybe most of you maybe not never go to my country. It's a small country called Thailand. My slide, please. Today is my great pleasure to share the same stage with most of our mentor, Miyata Sensei, Dr. Bancha, Sugaya Sensei, and most of the great doctor right here. Okay, slide is ready. So I will talk about the hybrid graft experience. It's a combined fasciolata autograft and allograft. And I use the term sushi graft to explain it. Yeah, it's the optimization by the combination. I declare no financial disclosure. This picture I just take yesterday. And big thanks to Dr. Paul Roche to make this wonderful meeting today. My SCR in Thailand, SCR is one among the various options for the massive rotator cuff tear surgical treatment. I started in 2018 after I graduated from Miyata Sensei. At first, I used the fasciolata autograft as he did. Now, my indication for SCR is age under 70 years old with active lifestyle, massive irreparable posterior superior cuff tear, presenting with pain, weakness, and also pseudoparesis. For the patient positioning, at first, I originally the wheelchair surgeons. But after learning from Dr. Mihata, I changed. I did the SCR with the lateral decubitus with side arm traction because it has an advantage. Because if you make a thick graft, you have the a traction force to make the subacromial space more wider and easier to do the surgery. The graft choice for the SCR, at first, as I told you, I use the autologous tensor fascia lata. Then I moved to the alternative graft like the allograft tensor fascia lata or the cellular dermal matrix. And now I will present the combined graft. The autologous fascia lata graft has a pros that it has a good biologic properties, no cause, no graft rejections, but cons is the large harvesting site and the normal side, donor side morbidity, including painful hematoma and also seroma. I experienced that sometime after the surgery, the patient doesn't complain about the pain on the shoulder, but yeah, and allograft in the SCR, the pro is we can reduce the donor side morbidities and we can choose the thickness. And the cons is the cost of the allograft and also the less biologic properties for the healing. And the rationale for my combined graft is to maximize the advantage of both sides of the graft. The fascia lata allograft is more stiff and more tough because of the thickness. And the fascia lata allograft has a biological properties for the healing and minimize the disadvantage and donor side morbidity due to the smaller autograft size. Luckily, in my country, I have the Red Cross, Thai Red Cross soft tissue bank located in the center of the Bangkok. We can request for the tissue, like the soft tissue, like allograft tensor fascia lata, and they will harvest as long as you see in the picture. And I fold it up for several times to make it thicker. This is a graft preparation workshop for the Thai Red Cross harvesting surgeons. I and also Professor Bancha joined that. Most of the people know the sandwich technique, right? But I don't prefer the sandwich. I prefer the sushi graft because, yeah, we are Asian, right? Because that I have to use the advantage of the lower layer of the fascia lata autograft. It's like the sushi is like the rice below and the meat or the fish on the top, right? But when you eat it, you have to flip it down and go in with the soy sauce, and then eat it. And it's the same technique with me.
You eat your graft?
No. I mean the sushi. No, don't eat that. My patient need it. Okay, so this is the final picture of the sushi graft SCR and ready to serve. The lower layer is the fascia lata autograft, and the upper layer is the allograft. Sorry. And this is a picture where I did the sushi graft SCR implantation. Now I didn't use the syringe technique no more. And yeah, it's oishi. It's delicious. Yeah, and this is another side morbidity, the wound comparison between conventional autograft and also the sushi graft. You can see the reduce of the size or the length of the wound. Yeah, and this is the motion as 6-month follow-up. Okay, on the right side is the first time that she met me at the office, and this is a 6-month follow-up after I implant my sushi inside of her shoulder, inside of her right shoulder. She can also do the external rotation. For my case series, since the May of the 2024 to January of this year, I have 11 shoulders. In 11 patients, 3 I did the cellular dermal allograft with autograft and 8 sushi graft. The graft thickness is 9 to 12 millimeters thickness. And longest track record is about 18 months. The mean is 12 months. Statistic is 4 to 7 male to female with age of mean of 63. Dominant shoulder 9 from 11. All come with the painful shoulder and 3 come with pseudoparesis. The result, I have the radiologic failure for 2 cases with the 2 cases. One is the cellular dermal allograft, but fortunately the clinical pain relief and good motion. And I also have the failure of one of my sushi graft. and he have the revision reverse shoulder arthroplasty to relief. I would like to introduce the first SCR Southeast Asia Collaborative Workshop in Thailand. It's going to be maybe the later this year. I will introduce to you later. And another in Thailand this year, we also have the TOSSM meeting and also the ARCOS meeting that combined with the British OA. We're looking forward to see you, to meet you soon in Thailand. Thank you very much.
Well done, May. Yes, we'll discuss at the end. It's better. So next up will be Paul Roach, our pioneering president.
We're in the U.S.
Who's going to present the graft experience in the USA.
Let me share our experience in the USA. I thank my team members who have come up to support, my former co-surgeon as well. I have no conflicts to discuss. Late 2022, I went to Osaka to figure out why my dermal grafts were not getting the results that Taro had published, and learned his techniques. Immediately saw the difference in the graft. Organized a team because it does take a team. You do have to be organized. This is not a one-off. And to date, we've completed in 3 years 77 fascia lata autograft cases. 62 are full SCRs. I've become a big believer in the SCR reinforcement for ARCR. Done 15 of those with excellent results early. And so, trying to be the landing party in the U.S., we have a responsibility to report our results. And so, my research assistant and my folks who have worked with me, we started looking at our healing. That's the very first thing, because I think Taro's taught us that early healing is a predictor of long-term results. So per the protocol I learned in Osaka, we get MRIs at 3 and 6 months. And so we've started to see, as we've reviewed patients, some very good results. So we had 42 patients when we did this review. We had to exclude 6 who didn't meet the criteria. And we reviewed graft integrity, AHD, and improvement of AHD. What we saw was we had a very high healing rate, 38 of 42, so 90% were intact at 3 months with improvements of AHD. And we're fortunate this afternoon, David Stoller, who's my radiologist for this, will be reporting how he evaluates these, because we evaluate them independently and then discuss. But I don't know about most of the surgeons in the room. I have very few things that I can tell a patient are 90% successful at 3 months, particularly with rotator cuff surgery. It's notable that of the 42, 14 were revisions. I've become the workers' comp failed rotator cuff referral center. Most of my patients are workers' comp, and most of them do go back to work. So we have a very high healing rate, a much higher healing rate actually in the revision group. But this is also very early. We're only 3 years into our results. So let me move on to our next slide here. Next, we wanted to look at clinical outcomes, which we just finally got to the point where we could review clinical outcomes. We've submitted to the International Congress this abstract looking at 20 patients. We looked at, again, graft integrity, graft thickness, and acromial-humeral distance. We looked at patient-reported outcomes, and we evaluated range of motion. Once again, we saw very high integrity of the test group. 95% had intact grafts. AHD improved. We don't have really time to go through our table of all those results, but they improved substantially. And the reported outcomes by the patients, as well as the range of motion, were all significantly better. We saw a lot of functional improvement in these patients. And as I said, many are workers' comp, and many got back to labor jobs in the workers' comp environment. So this is strong evidence that the U.S. patients first can benefit from the Mahata SCR. I call it the Mahata SCR because you need to distinguish it from what has been diminished in the U.S., which is any other graft, especially dermal graft. My favorite term for now dermal graft is cadaver skin. Has a certain impact. I did get asked by somebody who's not in orthopedics how freshly we harvested the cadaver skin. I don't really know the answer to that. So the benefit from the Mahata SCR, I think, is established and accepted in U.S. patients. I have not had trouble with patient acceptance when I explain to them. And that's also because, as most of you know, This patient has this patient group, 50 years old, functional deficit. They need to work, especially in the workers' comp environment, especially in California, it's expensive, and have been told basically they're effed, to be honest. People want to offer them all sorts of things. I've revised failed balloons. I've revised failed repairs. And what happens is these are people who need to work. They want to get back to work. They need something that's going to make them more functional. And so in some levels, they're desperate. It is a long procedure. I did start to do this by myself when my co-surgeon abandoned me last year. But with a co-surgeon, it's under 3 hours. Right? So, I work out to stay in shape, but it's 4.5 hours does wear on you when you do this. As Erica says, there is some mental strain. Some of you who are with me on Thursday got to witness my mental strain. But we actually get through the procedure. We have not had anyone where we had not finished. And you see we have a very high success rate. So I just added this slide. So we just got these results. So it's not totally verified, but we're working on getting this paper ready. So we had 21 patients who we graduated, who we completed their, now I never use the word hip to the patient. I always call it thigh or upper thigh, less invasive, right? But we did use the hip outcome scoring system because we didn't have anything else. We don't use the sports medicine part of it because this is not the group that needs that. And so nearly half of these patients rated their thigh as normal, no deficit. And the scar is under the underwear line. And these are not patients who are wearing bikinis, right? So they're not really worried about that. So we had obviously some that were not 100%, and we looked at that, and so we can see that of the 11 who were not 100%, 8 were very satisfied. We had 6 that were, basically, my numbers aren't adding up here, Ian, by the way, but we have to look at that slide. But overall, I think this next slide is the important one. So of the 11 who were not 100%, when we asked them, does the result compensate for whatever your opinion is of the harvest site? 82% of the 11 thought it was right. I think that reflects the need that this patient group has. And it is bottomless because I am booked out now 6 months as people learn that this procedure works, as they know where to send me these patients, and I feel remiss that I have to make a patient who's in this situation wait 6 months, but I can only pace at a certain rate to do these procedures and do them correctly. So I just wanted to point out that in the U.S., apparently I'm the nihilist. It works, right? I don't think it's exclusive to San Francisco and California. I think you could do it in Philly. I think you could do it in Chicago. I think you could do it in Vermont. I think you can do it a lot of places. And that's what we're here, just to try and break through the mentality, whatever the biases were, whatever the perceptions are. And what I remember is, I've been in the field long enough. I remember when we were concerned about bone patella bone complications for ACL. I'm a big 49er fan, and most of you remember Jerry Rice's catch when he broke his patella after being back on the field, and his treating ortho said it was not a complication from the surgeon. We all went, bullshit, right? We know it's a complication. We know that 20% have knee pain. So we accept it in a well-accepted procedure. Now we accept quad weakness in a well-accepted procedure. But for some reason, with this procedure and all the myriad of modifications that have been excited by this idea and people have tried, and we need that innovation, harvest site suddenly is not accepted. So that's just my opinion. So thank you very much. I want to just show you future directions. So does this video play? So we've started to use suture patch, which is specifically for the SCR graft. It took 10 years for Taro to get this. Just started using it. I've done 10 of them. When I made the slide, I'd only done 8. And it's a significant improvement in the stiffness of the graft. It makes, I think, the graft more consistent. We're going to be talking now. So I don't want to mislead anyone and say we don't have any failures. I'm saving that for the afternoon. And then I'm going to have John Costaros talk about how he solved some of our failures. But we want to be transparent. As the landing group in the U.S., we have to be transparent about what we get. Can we get the slide to move? How about again? There we go. So in the beginning, when Taro wasn't sure that I actually understood what he had taught me, I wanted to show that we had learned the technique. And so we also recognized, as Taro was telling me, that I had now not a responsibility just to my patients, because that's why I went to learn it, was to treat my patients. But we also had a responsibility because at the time I didn't know there were other U.S. surgeons doing this. Terrell kept telling me I was the best U.S. SCR surgeon, and my response was, I am the only U.S. surgeon. So it's an easy to be in number one. That is not true. So I'm glad to hear that Pierce is here and Jay is here. We're going to talk about them later. I found them along the way, or they found me. And this is we're starting our regional program. Pierce and I were just talking about potential regional training centers. This is our current group. Dr. Dunbar is now in New Orleans. She's going to be establishing down there. And realistically, I think we are the start of getting the U.S. mentality, at least to revisit the topic, to look at it and go, can we do it better than the first time it was done? Arthrex, any anchor company, has skin in the game. No pun intended. Right? The issue is, a successful SCR, first and foremost, helps all these patients. That's why we're here. These patients need this. That's why I do it. That's why I spend 4.5 hours doing it. It's because I have nothing else in my hands that gives a 50-year-old this result, right? Gives them their life back, right? It's why at least for me, why I'm in orthopedics is I like the technical, I like the engineering. We got a bioengineer right here. We've got engineering over here, but I like to have success and have an impact with my patients. Thank you very much.
Thank you, Paul, for your passion and leadership. And now we'll listen to Teresa Mihata talk about the suture patch.
Yeah, next my talk is suture patch. Then actually Paul introduced a little bit, but I show more detail. Yeah, so always I say the graft for SCR must be thick and stiff, but it's not easy to make a thick and stiff graft in all patients because sometimes the fasciolata very thin, even intermuscular septum very thin. That case, it's hard to make a thick and stiff graft. So to make stiff, thick and strong graft consistently, we developed a suture patch with Arthrex company. We sandwich the suture patch between the layer to layer of fasciolata. Then we can make a very strong and stiff and thick graft. So I want to show more detail. And this is a caliber. In fasciolata, we cover the suture patch like this. Then we did a show. Then it's a big guy, it's a Mark Ferguson, it's a big guy in Arthrex company. He tried to push the femur head to the acromion, but no contact. It means that the tension effect, not spacer effect after SCR using the suture patch with thin fasciolata. It's 10 years ago in Singapore Arthrex lab. Yeah, actually I'm very young. It's 10 years ago. Then we take out this graph to check the stiff shoulder or not. If the specimen is very stiff, of course, no contact. But after take out the suture patch and the fasciolata, it's hit very easily, so no stiff shoulder. And also we did a biomechanical study. It's a tensor testing of suture patch augmentation by comparing thin fasciolata with suture patch and thick fasciolata. So thin fasciolata only 435 Newton, but thin fasciolata with suture patch almost triple and almost same as thick fasciolata group. And this is the stiffness. The thin fasciolata 51 and thin fasciolata is suture patch. It's 1.6 times and much higher than thick fasciolata graft. And also we did biomechanical testing using the shoulder custom testing system in Tyrese lab. And we compare the intact and rotator tendon tear model and SCR using thin fasciolata and SCR using thin fasciolata and suture patch. And here's a result of super translation. Of course, after the rotator cuff tear model created, significantly increased the translation. And same as the previous studies, thin fasciolata SCR decreased the translation, but still higher than intact. But suture patch with the thin fasciolata SCR is almost same as intact. And also we check the range of motion to see the stiff shoulder or not after surgery, because suture patch very stiff material. So this is the result. The even SCL using thin fasciolata or suture patch augmentation, actually no change in the range of motion. It means the suture patch does not cause stiff shoulder after surgery. Again, we sandwich the suture patch between layer to layer. Then already we have done the 92 cases because in Japan we could use the suture patch 2 years ago. So already 2 years passed. Then graft tear rate only 2%, very high healing rate. So yeah, I really recommend this the suture patch to if you want to if you do the SCR using fasciolata or other graft, I think. And then I want to show this picture. It's a very interesting picture. I used the suture patch for the total shoulder, the total shoulder, and actually we covered the subscapularis to augment subscapularis when I finished when I did the total shoulder. Then 6 months later, some pain in the patient, so we converted the reverse. At that time, we checked the suture patch. Then this is a photo at that time, 6 months after surgery. Then we cannot see the suture patch anymore because the new tissue covers entirely suture patch. Actually, suture patch just attached to on top of the subcapularis. So just after surgery, we can see the suture patch in this view, but now we cannot see because maybe the scar tissue, but very many new tissue cover the suture patch. So it means if you use the suture patch on top of the tendon, maybe like augmentation of the supraspinous tendon repair, maybe you don't worry about any abrasion or maybe the subcutaneous impingement because the new tissue covered completely. Maybe like a scaffold. So anyway, the suture patch consistently produced a thick and stiff and strong fasciolata graft. Thank you very much.
Thank you, Teru. And now we'll listen to Akihio Azegawa to tell us about your harvest site outcomes. Also looking forward to your talk.
Okay, now I'm going to talk about the donor site mobility. So please, easy on me. Please go easy on me. So this is the recent study. So now still under review. So the purpose of this study was to evaluate donor site mobility and patient satisfaction after SCL using fasciolata autograft using the conventional open technique harvest. And so this process study included consecutive irreparable rotator cuff tears who underwent SCL using fasciolata autograft, including intermuscular septum, between 2020 and 2023, and completed 2 years follow-up. And exclusion criteria were as follows: less than 2 years of follow-up, irreparable subscap tear, surgical site infection after SCL, comorbidities that influence lower extremity function, such as osteoarthritis, and SCR as a revision surgery, and cervical radiculopathy or achelinopathy. We evaluated ACS score, active shoulder range of motion, post-operative graft integrity. And patient satisfaction and donor site mobility were assessed by standardized subjective satisfaction questionnaires. And in addition, BUS score for site pain and JHEC patient reported outcome measures in Japan were used to assess hip function. And this is a summary of our procedure. So after harvesting the graft, we repaired the insertion of the gluteus maximus by suturing between the intermuscular septum and the posterior sleeve of the fasciolata. So initially, we performed SCL for 57 patients, and 3 patients didn't want to participate in this study, and 15 patients were excluded, and consequently, 39 patients were included. FES score significantly improved after SCR, and the shoulder range of motion significantly increased after SCR. And in this study, 4 patients developed graft tear asophageally, so graft tear rate was 10.2%. This is a summary of the donor site complication. 53.8 patients had some donor site morbidity. The most common one was deformity of the thigh, and the second most one was muscle weakness. But no patient complained about the daily activity limitation. And there were no significant difference in JHEC score between donor site and the healthy site. And the VAS hip score for the donor site was significantly higher than healthy site, but still the value was 0.0, indicating the very mild pain. Regarding the cosmetic satisfaction, 87% patients reported that they were either very satisfied, or moderately satisfied. However, regarding the overall satisfaction, 95% reported that they were either very satisfied or moderately satisfied. And interestingly, the same 95%, 37 patients answered yes to the question, and that their shoulder surgeries and results compensate for the changes in the thigh. So Professor Mihata have reported fascial ladder autograft is a gold standard for SCR. And because SCR using fascial ladder autograft showed lower graft tear rates compared to that using human dermal allograft or xenograft. And this study also showed that arthroscopic SCR using fascial ladder autograft achieved functional improvement and low graft tear rate. So as you know, so the 2 different techniques are reported regarding the graft harvesting, so minimally invasive technique and our open technique. And this is a summary of the donor site symptoms. So both studies showed about 20% of patients had side pain, but the value of the BAS for side pain was 0.6. This indicates the fascial ladder autograft harvesting for SCR did not produce significant impact on donor site. And about the patient satisfaction, the cosmetic satisfaction was a little bit lower in our open technique compared to the minimally invasive technique. However, the overall satisfaction were comparable. And also, both studies shows 95% of patients answered yes to the question that their shoulder surgeries and results compensate for the changes in the thigh. And this suggests that SCR using fascial ladder autograft achieves a high patient satisfaction, regardless of the harvesting technique used. In conclusion, SCR using fascial ladder autograft harvested with the open technique, it's originally described by Mihata, achieved a favorable clinical outcome and high patient satisfaction. And harvesting the fascial ladder autograft did not significantly affect daily activities after gluteal maximus insertion repair. And most patients accepted minor donor site morbidity given the improvement in shoulder functions. Thank you.
Well done. Great job, Akihiko. So last but not least, we're going to listen to Bancha tell us about his comparative study of allograft and autograft SCR. Thank you so much.
Thank you so much. Good morning. I'm not 100% conscious because it's now 1 a.m. in Thailand. So I'm from Thailand, like May, yeah. So I'm good friends of Teru. I visited him in 2016. That's my first SCR in 2016. Yeah. So thank you all my 4 fellows for preparing the document. So this is a nice picture yesterday in the lab, and this is a picture of today. Yeah. This is the group of We Love SCR. Okay. So this is my first visit. We had that 2016. So the key success of SCR is the thickness. Everyone agree, right? So also Mihata proposed the autologous because you have better healing. This is native tissue, and also the healing will have good outcome. So there's many graft choice. Of course, autograft is the best because you have the contain the viable tissue, perfect, compatible to our tissues. And also donor side morbidity is the concern. I think everyone say that donor side morbidity is the problem. But actually, I think the shoulder surgeon, we are active, we are high attention deficit sometimes. So we cannot like 3 hours surgery is too long. So that's why many surgeons skip harvesting the graft, not just the donor side morbidities, because they are too lazy. Yeah. So if you want to have a good graft choice, this is my first ACR after I come back from Mihata. So I follow all the steps, but I'm a big chair guy. I cannot do decupitors because I have shoulder and back pain when I do decupitors. We have the totally 24 sutures. Yeah. We have triple loaded because I need compression. I need more sutures. And this is the outcome of the first patient. It's quite good. And I'm very happy. So I proved his concept is true. So I follow his step. So I first doing this because I do beach chair, but the problem is 2 teams on the same side is not easy. So I changed my position to be beach chair, but opposite side. It's like you put the patient in the hip dislocation position, adduction, internal rotation. So it's easier to harvest the graft. Okay. So this is the incision. We are keyhole doctor. Actually, I don't like this big incision like hip arthroplasty. So I enjoy your talk and I will follow your step, right? I will make a mini incision next time. So for the graft, we have 2 choices of the allograft. So the concern of allograft is the healing, right? Because it's not our native tissue. But anyway, the knee doctor, they did very good study about the ligament reconstruction, multi-ligament, they use allograft. And the healing of allograft is pretty good. Yeah, so this is a long track record of the knee ligament surgeon. But why not for the shoulder? So the allograft, I think the healing should not be too bad because we have good outcome in the knee doctors and sufficient thickness. We don't need worry about the thickness and the length of the graft because you can make it big. So allograft, this is the ADF, the acellular dermomatrix. So the concern is too thin, and also we need the creeping substitution, so that take long time, and many studies found that the outcome is not so good. Okay, so this is the long track record of the tensor fascia lata. The outcome is good, and the 10-year for survival is nearly 90%. I think it's quite good. About the mechanical study, they found that the outcome is good to improve the gynohumeral translation and also the contact pressure. Okay, and the outcome, the short-term systemic outcome is good in short term, but in long term, if the gap not healed, the outcome will not so good. Yeah. So the failure rate is mixed between autograft. You see the percentage, right? The autograft is better than the cellular, the dermal matrix. Yeah. So the study shows same failure rate, but worse outcome if the tear is at the glenoid side. Yeah. Sometimes we see incomplete healing, but outcome is good if the still intact graft on the tuberosity. Yeah. So however the outcome of the ADM, the failure, yeah, is about 59%, but it's not correlated with the outcome. So there's limited study about the acellular dermal matrix. Yeah. So this is showing the recellularization. Recellularization sometimes fail at 5 years, so the outcome is not so good. And this is the study, yeah, of the tensor fascia lata Achilles allograft. So they found that the outcome is still not too bad. It's about 80%. Yeah. So my experience in the SCR, so this is my position. And now I develop, because we have 24 sutures in the joint. And yeah, we have triple loaded. That's for triple load, 24 sutures. And adding another 4 for side to side. So that's 28 sutures. So it's not easy to manage these 28 sutures. So I developed the triple syringe technique. So this is the way I show you. We have 1 syringe, and also we have the lumen, 3 double slip of the spinal needle. Yeah, like that. And I put my finger in like that. And this is my suture management. So that makes the surgery easier. And I do pulling in. The Miyata like to push, but I like to pull and push. Okay. So we have less problem with the suture management, right? So, and this is the our Achilles tendon allograft. Right now, I do more Achilles tendon allograft. We are comparing the study. We have very thick graft. Mostly we have about 10 millimeter, because over time, I think 10 become 8. Yeah, after So and sometimes I put the bicep. Right now instead of I put the bicep in the middle. So that will add the original tissue and make the gap thicker, right? And very happy if the patient have very thick bicep, right? Hypertrophy bicep. So this is my series, right? This is my second patient. They have even they have posteroid superior. Most of the time I don't need lower trapezius because you can repair your infraspinatus to your graft, okay? And the outcome meta show that the outcome, even you have torn infraspinatus, the outcome external rotation is good, okay? So I think very important, you need to have side to side because I need to spread the graft. But Mihata don't repair the anterior part to the interval, but I do different. I repair to the front because I can stretch my graft like rectangular shape, right? So the outcome after surgery, the patient getting better, okay? This is 2 years, and there's another patient, 60, he's very active. He lost of external rotation, and also the job test is positive, proximal migration. So this is the way we do. This is a graft. So after surgery, we have the very good healing. So my overall outcome, I follow the patient right now about 5 years. So my outcome is not comparable to Mihata. I have about 88% of the success of my graft healing using autograft, right? This is the outcome of the patient. So they did not complain the hip problem. So about the autograft, we started doing autograft since 2022, okay? So using the Achilles tendon autograft. Yeah, because we have the Red Cross Society in Thailand, like May mentioned, right? This patient, if you have incomplete healing on the glenoid side, the outcome is good. Yeah, as I told you, you have good healing on the tuberosity, that's good enough. This patient, we also have the autograft. At 2 years follow-up, the healing is good and gap is really thick. Yeah. So about the ADM, the cellular dermomatrix, my outcome is not so good. I'm not so happy with the outcome. But anyway, this patient have good healing on the tuberosity side and the glenoid side not healing, but outcome is okay. Yeah. So most of my patient, the healing is good on the glenoid side, but on the tuberosity side, the glenoid have some problem. So right now, I try to repair the rest of my cuff on the top, okay, on the top. So I improve my healing after I repair. Instead of you leave the rest of the cuff, you put it on the top. So it's like this. You have like healing on the glenoid, also healing on the top with the rest of the rotator cuff. Yeah. So in summary, so I think the Ferrari is still Mihata. So we have the best outcome, autologous, okay, tendon allograft, but I think the human tendon allograft is not too bad. In my series, the healing is about 80%, but I think we can improve the outcome if we do better biologic augmentation, right? But the worst outcome is the cellular dermomatrix in my practice. The success only 25%. So thank you so much. And this is my YouTube channel, who maybe you can follow. And this is my WhatsApp and my name card. Thank you so much.
Thanks. So, we can go ahead with discussion. Thank you, Bancha. Well done. So we'll move on to discussing all these presentations. Who wants to ask questions about the preparation of the thin graft that was brilliantly presented by Erica Colline? So if no one has questions, I have a question for Erica. So how long do you put your patients in a sling, considering that you told us that your thin graft will heal after 3 months only? Okay. And you told us that you only begin strengthening after that. So, but how long do you actually immobilize them, or if you even immobilize them?
The abduction brace is there for 6 weeks. The strengthening exercise roughly started at 11 weeks or 12 weeks, so 3 months. Okay. So in the first 3 months, nobody smile. No, everybody's angry. Yeah. Nobody can see the result. We just believe. Okay. And then after 3 months, It's very stiff because no exercise was actually officially given, just a simple shoulder exercise. And then after 3 months, it is time when we believe that the graft has been remodeled, and I think the bone tendon interface maybe has taken its place. I think it's a safe time to give strengthening training.
So don't you all think that this is an important aspect, post-operative rehabilitation? So
Yes.
maybe the graft thickness and how it behaves and how long it takes to heal, it affects how you, if you even do immobilize your patient. So I would
Yes.
ask all the speakers if they need to use an abduction sling.
Do you use?
Yeah, I follow Mihata's protocol. So I usually put abduction sling for 4 weeks, and for the revision case for 6 weeks.
How big is the abduction? What's the angle?
So I think it's around 45-degree abduction.
You, Paul, you also
We
use
don't.
an abduction
We
sling?
use more of a gunslinger. It's no more than 15 to 20 degrees, and it's mostly to stabilize the arm for comfort. Patients, when I came back in '99 from Christian Gerber, I tried the abduction sling. Patients hated it and they wouldn't wear it. And so non-compliance is worse than just a regular sling. So I put them in something they could accept.
Katarina?
Yeah, we don't use an abduction sling. We use a regular sling, and we usually incentivize our patients to start moving in some specific exercises that we give them from week 3. So from 3rd week, they start moving, and usually they start physio between 4 and 6 weeks. But I think that you will talk about this, right?
Yes.
Yeah, and 6 weeks, it's a big landmark for us because it's the healing time. This is usually the time that we protect our shoulders. And it's very important also because we were talking about grafts and donor side morbidity, that our patients, they use a compression stocking for also 6 weeks. So they can remove it for hygiene, but then put it again. But we don't limit them regarding activity. So they can walk around, they can do whatever they want, but they use this stocking for 1.5 months.
What about the sushi graft? Does this give an advantage?
I also share the Mihata procedure after the surgery. Normally I use the abduction pillow for first 4 weeks. Then after that, discontinue the pillows and continue the only sling for another 2 weeks. So 6 week immobilization. After that, I will let the patient move, do the RM exercise, starting with the passive exercise first and then active assisted exercise.
We do something similar to what you do. We actually don't let them do more than pendulum for the first 2 weeks. Noman's going to talk on this later. We found that your rabbit study guided us to match what we saw with patients. So we'll start very gentle table stretch and gentle pulley after 3 weeks. We don't let the therapists see them until week 7 or 8, and we only let the therapists who have been discussed about SCR see them because it's different than the rotator cuff in the early stages. Once we get to 3 months and see the MRI and see that we have incorporation, again, informed by the rabbit study, we feel more confident that we can load the graft and load the patient and start to push the patient. In terms of the harvest site, unfortunately, we've had one harvest site infection. And what I learned from that was that the fascia, because we repair the fascia, we close it, and we pull the intermuscular septum to the posterior limb. I learned that the fascia heals very quickly. Certainly by 3 weeks, we saw that the fascial repair had held. So for the first 2 weeks, what we do for patients is we tell them, don't resume your exercise program, because many want to get back and do something. We asked them to not take, I had one guy who has 20-acre property, decided he needed to walk his property and came in with fluid under the harvest site. I think that's avoided if for 2 weeks they can just chill out and do basic ADL activity. So.
Okay, does any of the other speakers want to chip in?
John's got
For the group.
Okay.
So we talk about the thickness of all of these different grafts we have except sandwich, sushi, we have this. Ty, maybe you can answer this. Is it the thickness? Is it the stiffness of the graft that makes the difference?
John, your mic's on.
All right, he doesn't need a mic.
No.
Yeah, you can just turn the mic on.
Well,
But we want to capture you for the digital audience.
hello? Okay, it's on. Okay. No, you got to think thickness is doing something different than the material itself. So there's a material part, which is a graft type, whether it be dermal, fasciolata, or synthetic, or whatever you have. It has material characteristics. And material characteristic defines how that material is going to behave. So in this case, with all these different ideas, the structural adaptation or structural fit makes a whole lot of difference. What thickness does, in my opinion, is, I guess, assuming everything was done right, I think the good thing about the thickness is that it has a barrier effect, and also just by having that barrier effect, that it helps to keep the humeral head down, and the graft itself, it decreases the demands on the graft. So just taking the same material, changing the shape or the thickness, it can make a huge difference.
Can I ask a question, Ty? Do you think the thickness is more important in a human dermal allograft than in a fasciolata, because the human dermal allograft is more plastic and risks tearing if it's thinner?
Well, it's totally apples and oranges, because most of the tendinous tissue or ligamentous tissues, they relatively have parallel fibers. And dermal allografts, they have random fibers. So Poisson effect is really greater with the dermal allografts. So in some ways, surgically, it may be easier. Functionally, it's more challenging, because if you pull it, it gets narrower. It changes the shape. And then you are no longer achieving what you intended to achieve. So I think that's one of the research topics I'm going to talk about, is understanding what the graft material is, how it's shaped, where it's going to be, and what it's going to be able to accomplish just by using the system that I was describing earlier. So I think there's, in the whole orthopedic community, I think you guys are all busy, but I think it's really important to develop a systematic way of thinking to evaluate the material you're using, shape and the size, tension or the length, all those things, because every one of those things play a role. And if something is lacking, we can actually compensate it with those other features. And I don't think there's too much of that going on in the community, especially with complex procedures. And I think if we educate properly, I think it's going to find its place. Somebody may even come up with better graft than autografts. But there's a lot of freedom, or a lot of things you can do to adjust for it. I talk about this all the time. I have tons of residents and fellows. You usually don't have to worry about top half of the bell curve, because good surgeons, I always see them, whether you have the right stuff or not, they make it work somehow. Mm-hmm. And then bottom half of the curve, a lot of times you give them all the perfect thing and they'll change some things and screw it up. And then it gives the procedure a bad name. So I definitely see the industry's challenges trying to serve all the population and all the surgeons. But I think if we improve their understanding that they can actually manipulate what you have to customize it for a patient and just do it better. But again, I'm not a surgeon, so I'm talking about
that's a great extended answer. And until you prove it in the lab, please keep looking. Terry, do you use this suture patch all the time now? Is this?
Thank you. Yeah, now all the time. Yes.
And have you seen better results because of?
Yeah, better results. Actually, the MRI shows a very nice finding, and also graft tear rate decrease more.
Can I pitch in? Do you think that adding the suture patch may allow you to avoid to harvest the intermuscular septum?
Yes. So right now, actually, that case which I showed, that we included the intermuscular septum with suture patch, but now we started to decrease the harvesting the intermuscular septum. So now maybe 80%, 90%, they're just fasciolata plus suture patch. Then so far so good. Yeah.
We are going to take the coffee break. If there's more questions, go ahead and let's keep the discussion going. But we'll expect to start the next section somewhere around 10:50. We do have a few cancellations, so we have time. So
10:50.
Yeah, yeah. So absolutely.
Everyone is already on the call.
So let's go. Coffee break.
Yeah.
And to pee.
Yeah.
Did you like?
Okay, everyone, it's time to get started on our last section for the morning. If you can bring your coffees back to the table. Where's David Hook? I might need him. Is David Hook still here? No, I'll call you later. But is David Hook still here? I haven't seen him. I like to use him as like.
He said he was going to leave at 1
Oh,
because he
yeah.
had to go somewhere.
He has an airport.
So he
there.
must be here still.
Yeah, it's all right. It's okay. Okay, here we go. Here we go. You are up first.
Do you want me to go there?
Yes, I do. You please teach us. Where's Taro? He is the moderator. He's got his thing. You can turn my mic off.
Okay, so now let's start the next session. It's a surgical technique and outcome. So we actually the in-hold is not coming, so and the show is recorded. So now fourth speaker here. So first speaker, Clara, surgical technique and outcome program.
Thank you so much, Terry. It's an honor to participate in this meeting and to be a founding member of this International SCR Association. I'm going to defend the case of our type of SCR surgical technique and tell you about our outcomes in Portugal using the fascia lata autograft, of course, the original one, but with some modifications. So, of course, we were fascinated by your outcomes, Teru. I've first learned about your work in 2015 in an ISACOS meeting. I hadn't read your papers and I was completely amazed with the outcome. So I brought it to Portugal with Catarina. But like the Americans in the USA, we were concerned about the impact of the donor site morbidity, which was relatively not well explained, of doing the open harvest, particularly proximally in the thigh. We were concerned about harvesting the intermuscular septum and what this could imply to the hip abduction. And as Katerina mentioned, we also were concerned of alternative techniques that existed to harvest the fascia lata distally because we could damage the iliotibial band, which is an important anterolateral knee stabilizer. But we didn't want to use this cadaver skin like Paul mentioned because we know that in the preparation of cadaver grafts implies that you destroy their mechanical properties while you do it. And so this is why it has more trouble healing if it ever heals. And the biomechanical properties and behavior of this graft is different. And this doesn't give you guarantees that it will behave like the original SCR with the fascia lata. So we weren't convinced, and we looked for the experience of other surgeons, and we found, as Katarina mentioned, that many of the ear, throat and nose surgeons and plastic surgeons were using the fascia lata, but they didn't do this incisions, open approaches. They used small incisions. So we adapted it with the instruments that Katarina showed you to do a minimally invasively harvest technique to try to use the original graft. And we published extensively on the donor site morbidity aspect of this type of harvest, and Katarina showed you, and also the landmarks for our harvest. So our principles are that we want to avoid the proximal thigh and the distal thigh for the reasons I explained, and we go anterior, 4 centimeters anterior to intramuscular septum, also to avoid damaging it. But on the other hand, we end up with a thinner fascia lata because the mid-thigh fascia lata anterior to the septum is slightly thinner. So we harvest a little more and then we fold it 3 times as Katarina showed. We have in my image it's a little different, so I look there. We looked at our outcomes at 3 years of follow-up using the MRI to assess the impact of the healing in our patients, each patient assessed at 3 years follow-up to see if this had an impact in the healing using the autograft, the fascial lata autograft. And we had already in our protocol controlled our patient at 6 months with MRI. So we knew that, and we had published that in 2018 in the OJSM. We have a graft tear rate of 9% at 6 months, and at 3 years, a 21% graft tear rate. So we have a slightly lower performance of our graft compared to Teru's results, but nonetheless, much better than any other type of graft, as Katarina shown in her highly complex tables. And when we looked at this series of patients, we found that our patients improved significantly in all the scores that we assessed, the consent score, the simple shoulder test, the SSV, and highly above the minimal clinical important difference for these scores. And also, and this supports the idea of how this graft works, we looked at how they behaved at 2 years and compared with the 3 years follow-up, and we saw that these patients, they continued to improve in all their outcomes and significantly improving in their abduction, which supports the theory that fascial lata autograft works by stabilizing the glenohumeral joint in these supraspinatus deficient shoulders by restoring the native glenohumeral center of rotation. And this is why patients, they keep improving, because they get the chance by rehabilitation to recover their physiological scapulohumeral rhythm. We also worked with biomechanical engineers to perform computational analysis to understand better how our graft behaved. We had done a biomechanical study comparing the mechanical properties of this graft that we harvest from the mid thigh and we fold 3 times, compared with Teru's type of graft harvest from the proximal thigh. So we went to the lab and we harvest like Teru, we harvest like we do compared, and we came up with mechanical properties of our graft. And we use this for a computational analysis, and we found that that SCR with the fascial lata autograft significantly improves shoulder stability in patients who have no supraspinatus tendon tear. And this supports the theory that the graft works as a stabilizer of the shoulder. Moreover, we found it, or we think that when the graft deforms, it produces forces that assist in stabilizing the glenohumeral joint by compressing and centering the humeral head in the glenohumeral joint. And we think that this works better with the fascial lata because it's elastic. So it deforms and then it resumes its original form after deformation. And this leads to lower tear rates than plastic grafts like the xenograft or the human dermal allograft, that they deform, elongate, and then they don't resume their previous shape. So this is our theory supported by these studies. Also, we found in this computational analysis that when you do a tenotomy concomitantly with the SCR, you lose glenohumeral stability when compared with an SCR with the intact long head of the biceps. And this changed our practice, because in our previous publications, we were doing tenotomies in all of our patients, and then we did the SCR. And nowadays, every time there's still a long head of the biceps, because in our first series, half of the patients, when they went into surgery, they didn't have a long head of the biceps, which is part of the natural history of a massive rotator cuff tear. They tear their biceps, so they didn't have the biceps. The ones they have, now we tenodese it, because we believe it works like an internal splint protecting the SCR. Like we'll talk about it. Katarina already showed you this study, which compares normal thighs with the harvested thigh with no significant complaints of these patients. Because if you think that the visual analog score for pain, the minimal clinical important difference is 3, these patients had 0.57 VAS in their harvested thigh. So this is why patients are so happy with this technique, and this is why we have 95% of satisfaction, like our colleague Azergawa showed in their harvest. And in our study with 39 patients at a minimum follow-up of 2 years, these patients said they would do this procedure again because they don't mind if they have some difference in their thigh. It's not significant, really. So again, we did a computational analysis to try to understand better what are the best candidates for the SCR. So we modeled different types of combinations of tears. So when you have an irreparable supraspinatus tendon tear and all the other tendons are either repairable or intact, or when you have a supraspinatus plus an infraspinatus that's irreparable, supraspinatus, infraspinatus, and subscapularis tendon tear irreparable. How does the SCR behave? Again, using the biomechanical or the mechanical properties that came from our biomechanical study on our type of mid-thigh harvested graft. And what we found was that indeed the SCR with this fascia lata autograft significantly improves the granulohumeral joint stability in irreparable rotator cuff tears when only the supraspinatus is irreparable. So what does this mean? As I said, is if the supraspinatus is irreparable and the other tendons either are irreparable or you replace their function. So we conclude or we assume that if any other of the tendon tears is irreparably torn and you cannot repair them, you have to do something to restore their function, either with repairing or replacing their function with a tendon transfer, because as Katerina so well explained, we need to close the box. It's not enough to restore the vertical force couples that you achieve when you do the SCR. You restore and replace the job of the supraspinatus, but you don't restore the infraspinatus or the subscapularis tendons work as an horizontal force couple. So these need to be addressed. Otherwise, this will not work. So we've been doing this since 2015. So after I witnessed the brilliant talk by Mihata at ISACOS, I brought this technique to Portugal and we started doing it. And we've done this in 100 patients, and these are our averages. Of course, the follow-up is not less than 2 years in the last patients, but we have a 16.4% of total graft tear, which is usually on the humeral side. We have no tears on the glenoid side, and we have 3% of partial tears. And our typical indication, and this stems from our biomechanical studies, our computational analysis as shown, is a patient with an isolated irreparable supraspinatus tendon tear. All other tendons need to be either repairable or they need to be addressed, like in this example here, where you have a positive Zanetti tendon sign with severe atrophy of the supraspinatus with a Guttali grade 4 fatty degenerated muscle, and a PAT3 in some of the acquisitions of the coronal MRI of the retracted tear of the supraspinatus. And so regarding our technique, finally, so we put the patient in the beach chair position, as you see here, and we harvest from the same side, and we are fortunate enough to work together, Katerina and I, so we don't get in each other's way because one of us harvests and the other goes to prepare the graft in the side table while the other continues to do the arthroscopic procedure on the shoulder, and this way you get to do this procedure in less than 2 hours, 90 minutes. So we have to surgically drape the shoulder, and we have to prepare with disinfect all the thigh of the patient, and then we cut this hole in the drapes to mark the placement, mark the references, the anatomical references of the harvest, as I explained to you before. And Katerina already showed how we do the harvest, so we'll move forward with this part. And as I said, we do this in the beach chair position, and we use a mechanical arm holder because it makes it easier to change the position of the shoulder without the need of another assistant during the procedure. But in the beginning, we used a simple traction with 3 kilograms, and it works as well. It's cheap, so it's very easy to achieve this. And we only use 3 portals, as Katerina mentioned. Here, there are some technical differences from Professor Teru's amazing technique because of the way we implant the graft. So we placed the arthroscope. I don't know if this has a pointer. Ooh, it works. No, but it works there. Okay, but you don't see it, so it doesn't work. So you but for me it's exciting. So you place the arthroscope, so it's 4 millimeter 30 degrees arthroscope, 2 centimeters medial to the posterolateral corner of the acromion. This is because we're going to check all the procedure through this portal posteriorly, so we need to be able to look laterally, and we need 2 centimeters medial, but we don't place the arthroscope on the soft spot. We place it immediately under the acromion because we need to have this stadium view when you go to subacromial to do all the procedure. So 2 centimeters medial immediately under the acromion, and you place the cannula in the rotator interval, so using a spinal needle from outside in, standard cannula. 5 millimeters is enough. And then we need another portal, again placed from outside in. You see there on the right image, you see the spinal needle, and we're going to check where we place it to be sure that we are able to place the anchors through this portal, because this is a difference from Mehata's technique, is we don't use any other portal. So we're going to do all the procedure and place all the anchors through this portal. So here we go, you see the spinal needle, and we're going to check that if you place the portal there, we can reach the superior glenoid rim and place 2 anchors, one more anterior and one more posterior. Another difference is we are going to place this under the superior labrum, like we are going to do a slap repair. So then, again, as I explained, we changed our technique to start tenodizing all the patients that still have elongated biceps. So this is the case of this patient. The rationale is that it will work as an internal splint, protect the healing of the SCR. And even if it's completely frayed, our South Korean colleagues did a wonderful study showing that even when the biceps is in poor condition, if you fix it and it's there, even if it stays there only for 2 months before it tears, it will protect the healing of your rotator cuff repair, your SCR, whatever. So it's a very good, cheap internal splint meanwhile. And as you can see, we use an all suture anchor, double loaded with number 2 sutures, and we do a hemi loop to fix it. So we're not going to cut the biceps. We're going to leave it like it is. Just we fix it in tenodesis. And then we move on to the SCR itself. In this case, patient didn't have a subscapularis tendon tear, otherwise we would have repaired it. So we prepared underneath the labrum. We place one, in this case it's a 1.9 double loaded suture anchor, all suture anchor with number 1 sutures. And of course you have to check that it's armed against the cortical bone. Otherwise you'll have the unfortunate surprise that it can pull out when you're shuttling the graft inside. So always pull on it. Pull on the patient, hang the patient by the sutures. So if it doesn't pull out, it will never pull out, and check that the mechanism of the sliding works, because you're going to do a double pulley technique. Then you move on to the all suture anchors of the medial row of the humerus. You can extend the shoulder and flex the elbow to get a nicer angle of attack. And you place a 2.8 double loaded suture in the same direction of the glenoid anchors. And here we're checking the distance between the anchors, the glenoid anchors, and between the glenoid anchors and the humeral medial row anchors. And so this is slightly different again. So you use these measurements to mark these measurements on the graft that was prepared on the side table. And this way you are going to know where you're going to place these sutures. So in this case, it's not going to be 24, it's going to be less sutures. You have 16 sutures going through the graft. So you pass 8 suture limbs of sutures from the 2 glenoid anchors through the markings you placed on your graft construct. So you have 1 anterior glenoid anchor, 1 posterior glenoid anchor. You grab 1 suture from the anterior glenoid anchor and another suture from the posterior glenoid anchor, and you tie the double pulley knot that you see there. I'm holding with my right hand. And all the other sutures are passed. The 8 sutures in the marked placements of the humeral medial row anchors that you see on your left. And you're going to use the opposing limb of the this double pulley knot of the glenoid anchors to shuttle all the graft inside. So what you're seeing here is we keep tensioning the sutures so they don't entangle or twist inside. You see, you don't need a cannula on the lateral portal. The incision is very small, but why is this possible? Because this graft is very elastic. It's fascia lata and it's very flexible. So we just give it a nudge with the back of this forceps to help it go inside the small hole, to go inside the joint. And then you keep pulling on the opposing limbs of the double pulley knot of the glenoid anchors until it fully reaches the superior glenoid rim under the labrum, the superior glenoid labrum. So this is what you're seeing. You just have to be patient. You see on the monitor, we help with the back of the forceps. We keep pulling. You see, if you don't pull on the sutures, they get a little bit entangled. You don't want that, so you keep pulling until it uneventfully goes in towards the superior glenoid rim. And there it is. It reached the glenoid rim. So now we're happy, and now we can tie all the other knots. So you end up with 4 mattress sutures on the glenoid rim, and maybe this is why we don't have any glenoid tears, and we know this because we control all our patients with the MRIs, and the tears that we have don't happen here. So then we move the scope over the fascia lata, and we tie the knots of the humeral anchors. Of course, you have to cut the knots of the glenoid anchors. This is tying the knots. And then you move to tie the knots. We tie all the knots of the medial humeral row anchors, as you can see here. We tie them all. And then we use the suture limbs to pass them through the remaining cuff, in this case, the infraspinatus. So you see here, you grab it and you go with, in this case, an automatic suture passer. And we load each of these sutures from the knots of the medial humeral row anchor, and you pass them through this tendon. So it's slightly different from the original technique described by Professor Mihata, where you do a side-by-side suture. In this case, we do over-the-top or onlay repair. And we also do this when we have repairs that are like the classification that Professor Teresa Mihata showed, when you have some irreparability criteria, but it's not enough to justify an SCR. And then you load all these suture limbs. We choose, in this case, the ones with the blue stripes go anterior for a peak, in this case, 5.5 anchor to place to prepare the transosseous repair laterally, and the black ones with the black stripes on the posterior anchor. And we believe from the studies that are published that this is another important detail from SCR. It's different to have an SCR where you do the humeral row is only a single row. Then if you have a transosseous repair, it's more robust, and the outcomes show this. And then we go check inside. You see the fascia lata, and we check the range of motion. You see the long head of the biceps still there. Doesn't annoy the patient. And it's like a reinforcement of the SCR, so it's a very strong SCR. And this guy here that you see on the right, actually, he had it's not this case, he had a very severely frayed biceps, and we left it, and he didn't have any stiffness like all the cases that we have, so we don't see a reason to tenatomize it anymore. Regarding the rehabilitation, our difference from the other techniques, as we discussed, is that we just put the patient in a sling, no abduction pillows, and we have to protect their biceps healing for 6 weeks, so they cannot flex against gravity, but they start range of motion immediately. And another tip is that we learned from our computational analysis that most of the risk of tearing of our type of SCR is in internal rotation in the beginning. So for the first 6 weeks, we don't allow our patients to internally rotate. All the rest is possible. And of course, strengthening only after 3 months, and active resisted strengthening at 6 months. This is to show some of the controls, some of these with partial tears. You see a tear there down. It's one of the patients that had a tear at 3 years. And in conclusion, so we have some differences in the way we perform this procedure. And what we learned with our experience is what I just told you is if we have an irreparable supraspinatus in a patient with preserved glenohumeral articular cartilage, this is a good indication for the SCR, just as long as they have either an intact or a repairable subscapularis or a partially repairable infraspinatus. Otherwise, you need to restore the horizontal forescapus. Whatever you do, you cannot do an isolated SCR and expect a good result in these patients. We know that this graft is elastic, has the longest term follow-up, lowest tear rates in the publicated series. Save the long head of the biceps, fix it in situ on the groove, do not anatomize it because it works as an internal splint to protect the repair or the SCR. And thank you so much for paying attention. Join us in Lisbon in September. Thank you.
Thank you, Clara. Clara, can I ask you a question? So
Okay.
do you attach the long biceps to the graft, or do you see that it's healed?
No.
to the graft?
The only circumstance where we attach the biceps to anything is when we're repairing the supraspinatus. If we cannot achieve a complete repair of the supraspinatus, not in the context of the SCR. In the context of the SCR, the role of the remaining intact intra-articular component of the long head of the SCR is only to work as an internal splint for the SCR. We don't want to risk having stiffness by suturing this to the graft. And our experience is that this is kind of a paradox, and probably is all of your experiences. When we have large supraspinatus repairable tears that we can achieve a mechanical repair, these patients, they are in a lot of pain. These patients with SCR, even if you fix long head of biceps, they almost have no pain after surgery. And I have a lot of, and Katarina, experience with revising failed arthroscopic rotator cuff repairs. And the patients themselves, they are afraid of undergoing a third surgery. But they then tell us, I was impressed because I was expecting a lot of pain like the other surgeries. I had no, it's not anything like the pain that I had. So
Clara, can I ask? There's a awesome technique. Thank you for showing that. What is healing medially? Fascia lata to the labrum? We need a bony bed for a tendon to something to heal. How is that healing? What is it healing to?
It's healing, of course, it's healing to where you place the anchors, because there's a lot of stem cells coming from it. And I'm sure it's healing also because it's under the labrum, it's healing to the labrum. So I think this is why it's maybe theoretically more robust. And the fact is, we look at the MRIs and it's healed. It doesn't fail, and we don't need 3 anchors and more points of fixation because it heals like this.
Great, it shows on MRI. I just tried to figure that out myself.
It's almost like when you do a labral repair. So when you do a labral repair, you detach the labrum, you place the anchors, and then you repair the labrum, and the labrum heals, right? So this is the same. We detach the superior labrum, we place the graft under the labrum.
You detach the superior labrum.
Yeah, we detach we detach a little bit the superior labrum.
Thank you.
Yeah, we place it, and then it heals directly to the bone and underneath the labrum.
And it's technically much easier. You don't need to use an visor portal and shuttle sutures back and forth. You're always doing everything from the lateral portal. You place the anchors through the lateral portal, you pass the sutures through the lateral portal, the graft goes into the lateral portal. So it's very comfortable.
So what type of suture anchor you use in the glenoid?
Sorry?
What type of it? And which size of
the anchors?
Anchor?
Yeah, it's either 1.8. It depends on the industry that's supplying the anchors. 1.8 double-loaded sutures number 2, or 1.9 double-loaded sutures number 1. So I'm not going to say the brands. All suture anchors, yeah. I think the trick here, this is cortical bone. Glenoid bone is very, very, very strong. And so the trick here is the devil is in the details, like we were talking with Anthony Romeo. We need to, after you drill and you place the anchor, you need to really pull until it's really armed. It does that ball effect under the cortical bone to be sure that it will not pull out. This does not pull out, but you have to really pull on it and arm it. And we see this even in cadavers. It doesn't pull out. The trickier part could be on the humeral side, and sometimes this happens. You pull, and then it pulls out. That's why you have to choose on the humeral side. The bone, the best quality bone, is really immediately after the articular cartilage. And as you see, it's all suture anchors again, but there it's 2.8 because of this aspect, because it's more frail.
Okay, thank you, Clara. So next
Thank you.
speaker, Pablo from Latin America. Yeah, he's a shield surgeon in Latin America, Argentina.
Okay, good morning. First of all, I want to thank to Paul and Teru to carry on this great project. I think it's very important, great idea to create an international ACR association, and I'm really proud to be founder of this association. So what about ACR in Latin America? I will present my own technique that is an ACR, knotless internal brace construction. We create this technique with my friend Dr. Fernando Barclay in 2015 with the idea to simplify the introduction of the graft inside the cerebral space and to be easy to improve the fixation and to do it simple on the gleno side, because for me to manage a lot of sutures that the original technique is not reproducible for many of the surgeons, especially the young surgeons. What was the idea at that time? We mixed the concepts of the very young Teru surgeons in 2015. At that time, we've been following with Dr. Barclay his works, his great papers that began to be improving over years. And we mixed with the internal brace concept described by Dr. McKay from Scotland. And we introduced the knotless technology at that time to create the internal brace construction. So we use fasciolateral autograft because we really believe that this gold standard right now for the ACR. I think the properties are great, the thickness is better. So we always use the fasciolateral, but we create a different suture configuration to have the internal brace construction. How we do? We use 3 fiber tape, 1 medial on the gleno side. We are going to do inverted matrix sutures, and then 1 anterior and 1 posterior fiber tape is going to run in from medial to laterals just to create the internal brace construction. And we modify the fixation of the lateral on the humeral side with the modified split bridge technique with just 1 swivel anchor on the medial row, and then we support with the internal brace to create the double row fixation. We created the prototype in 2015. We did our caloric test on the lab to understand how we work the ACR construction, the internal brace on the cadaver. And we proposed to fix at that time on the medial side, on the gleno side, 5 millimeter medial to the border or maybe 1 centimeter medially. I believe that if we go medially, we have better possibility to heal in tissue on the gleno side. We do the fixation on the gleno. We, at that time, the very beginning, with 2 swivel 3.5 millimeter. Right now, I'm using 4.75 millimeter on the gleno side too, 1 anterior and 1 posterior. The fiber tape running from medial to lateral, we do the internal brace and we fix with the modified split bridge technique with 1 swivel anchor on the medial row, and then on the lateral row we are going to use 1 fiber tape from the medial anchor and 1 fiber tape from the internal brace construction to do the anterior and the posterior lateral row fixation with swivel. This is the way how we prepare the graft to pass the running suture from medial to lateral or lateral to medial. It doesn't matter. We're going to pass under, over, under between 3 or 4 times every centimeter of the graft, depending on how long it's going to be the graft, and then we create the sutures. We did a biomechanical testing. We had 540 newtons, and this is a case with 64 years old man with a cerebroparetic shoulder, doesn't have external rotation and internal rotations. This is the pre-op MRI with a repairable or very good subscap and massive retracted super and infraspinatum tendon tears. This is the technique of one of the patients. We do the graft harvesting that Terry showed us and teach us, just very small incisions between 6 to 10 centimeter. We take the graft, we harvest the fascia lata. We always go quite posterior on the fascia lata to have the septum and to have the very thick fascia lata. We always close the defect on the fascia lata. Then we are going to prepare the graft. First, when we mark where we are going to do the mattress stitch, we are going to pass 2 sutures, the tiger sutures. We are going to create the inverted mattress stitch for the glenoid fixation. And then with the other sutures, with the other fiber tape, one anterior and one posterior, that is the blue sutures, we are going to run from medial to lateral, under, over, and over, under every 1 centimeter. So we pass the running suture to create the internal brace construction. And we are going to mark the tendon that is going to cover the footprint. I would like to be very thick and very long, at least 1.5 centimeter. We complete the running suture for the internal brace. This is the way, I think the secret on this technique is the way to prepare the graft. Then we are going to mark the center in between the 2 sutures just to pass the medial anchor suture of the fiber tape. Then we are going inside the joint. We prepare the bone bed on the humeral head and on the glenoid side. I always put an anchor, a posterior or anterior anchor, to repair the remaining tissue on the infraspinator, teres minor or subscap. I always repair the cable. And then I will prepare with the guide the swivel insertion of the glenoid side. The anterior is going to be through the anterior clavicle portal, the posterior through the navicular portal. I leave that red plastic to don't lose the anchor. Then they put the swivel medially. I pass the suture of the swivel through the mark that I did on graft, and I introduce the graft just pulling the internal brace sutures, putting the internal brace suture on the swivel. I will pull down the graft on the glenoid side, so the graft is always going very smooth on the suracromial space. Fix first posterior, then anterior, and then do the standard speed bridge, just 1 anchor, 1 sutures with of the medial anchor, with 1 suture of the internal brace to do the anterior and lateral fixation. I always do the double pulley technique, join the remaining tissue with the graft, and then the side-to-side sutures. And this is interesting for the side-to-side sutures. You see it here that the internal brace you can use as a ripsaw configuration to have better to protect the graft on the side-to-side suture. That's the final result. I always do the side-to-side suture to reestablish the capsuling continuity that Teru teaches us in the papers, and this is the result. I have a very good integration. If you see the picture in the under the corner, that's the area that the graft is covering. You can see it's a big graft, have covered all the humeral head to prevent the arthropathy. This is pre-op and post-op clinical and MRI results. We can see how descend the humeral head in the post-op X-ray and the integration and the healing of the evolution of our technique. We incorporate in the last 5 years the polypropylene patch just to have better structure on the graft and to be easy to go inside. And in the last month, we incorporate the suture patch to add to our configuration to have a better soft tissue and to have a better structure of the graft, and it's going to be stronger, I think. Our results, all the patients improve in between the pre-op and post-op, the flexion and abduction. The pain relief was significantly better between the pre- and post-operative times. And the acromial distance improved from 3.7 millimeter to 9.3 millimeters. This is our first case from 2015. The first 26 patients have the first year follow-up. We have 85% clinical success, improvement on the acromial distance, and healing of 78% on the MRI at that time. So the recommendation, use a very thick graft. Is easy to fight with the space, with traction, with acromoplasty to work very easy and to have a better graft for better integration. I love the internal brace technique to protect the graft like in internal fixations. And we have to think that arthroscopy supercapsular reconstruction is an effective and biological alternative to a reverse shoulder arthroplasty with a minimal or no glenohumeral arthritis. This technique will provide stable fulcrum, optimized for scalpels. We have a pain relief in our patient with a low complication rate that is Teru show us in all his papers. So right now, for me, the supercapsular reconstruction should be the gold standard for joint preservation in patients with massive rotator cuff tears, as Steve Burkhardt called the biological reverse.
Thank you, Pablo. Any question to Pablo now?
So how do I integrate the internal brace on the construction? At the length, I measure that the standard measurement between the anchors and the from medial to lateral, and I would say the measures with the measurement tools.
But where you're not going to do what it's supposed to. It's not going to do what it's supposed to do, because at least in the lab, it makes a huge difference if you get the length wrong. And what I'm asking is, what's your anatomic landmarks that you put the anchors in? And as far as, for example, you can measure the distance with the arm side, arm up, or rotated. You get
all the positions have different measurements.
Yeah.
So I usually use 40-degree abduction, between 30 to 40, more than 40 than 30, because I think that the trampoline effect is going to be better if we do it in abduction, and then in 10-degree or 20-degree forward flexion. And the landmark inside, I always go from the medial, the super border of the glenoid. I go very medial as far as I can. In the anterior part, I will go to the base of the coracoid. For me, that is the best bone, and allow me to have a lot of graft over the glenoid side. I don't like the border fixation. It's easy, but I can't believe how the graft is going to healing just in the border. I prefer to have at least half centimeter.
Pablo, I have a question. Your technique, you're showing the graft, the suture patch on top of the graft. How did you come about that? Have you seen any changes, any stiffness, any subacromial problems from this?
Right now, I'm adding the suture patch to my technique. I'm using over the patch because I think that the friction with the acromial is better. It's going to be supported better with the suture patch than the graft. So that's the reason, because I put the suture patch over the graft. I still do the internal brace because for me it's really easy to put inside the shoulder the graft. I use a very thick graft between 8 to 10 millimeter. So after I put both sutures on the medial inside the joint, I pull out from the anterior and the navasir portal. I load the swivel. That was one of the reasons, because I moved to the 4.75 swivel, because it's strong, so I can manipulate the sutures and introduce the graft while I traction the sutures and pull down the swivel. So it's going to be easy to go down and to the glenoid side.
So how is the suture patch fixed to your fascia lata?
I suture in arm. Yeah, I just suturing the Terry show us.
Pablo, I saw that you make double row for the glenoid side, right? Yeah, you have room for 2 anchors on the glenoid.
No, on the glenoid I just use 2 anchors. It's not double row. Double rows is on the humeral side.
Okay, and all is autograft, right?
Sorry?
Autograft, not allograft.
Autograft. In the last year, I begin to do some experiment with allograft, with Achilles tendon and fascia lata allograft to compare the results. Because of the time consuming in the operating room, I think it's really easy the procedure if I had the graft and the other team is preparing the graft and preparing the shoulder.
You found any difference now about auto and allograft?
Not yet. Clinical, there's no difference, but the difference in between the allograft and the autograft is the preparation. I have thicker graft with the allograft because when I ask for the fascia lata to my tissue bank, they give me like a piece of the fascia lata, all the fascia lata. So I turn on and fold the fascia lata in maybe in 5 or 6 times. Or the Achilles tendon, it is very thick too.
Thank you, Ted. I'm Nobu Yamamoto from Token University, Sendai, Japan. I'd like to talk about the recovery of the muscle strength after SCR and the mechanism of the SCR. I came from the Sendai, which is located north to Tokyo. It takes 1.5 hours by bullet train. The Sendai city has a 1 million population. My university hospital is built in the 1915. There are 1,300 beds. So my surgical indication for SCR are large to massive irreparable cuff tear, relatively young patient, less than 65 years, who need a greater muscle strength, and no CTA or mild CTA. I performed the SCR in the beach chair position, so the fascial lata harvest from the opposite side. And to make the graft thicker, we need to harvest the fascial lata with septum. But these days, the suture patch is available in Japan, so suture patch is sandwiches between fascial lata. Then always I try to make the graft thickness 8 to 10 millimeter. So here, clinical result of my SCR. Among 88 patients who follow up at least 2 years and took MRI at 6 months, 1 year, 2 years, finally 35 the patients are enrolled in this study. ASES score significantly improved after surgery. According to the MRI Hasegawa classification, the stage 4, which means the repair, was 15%. So the clinical results are very good, but my question is why the muscle strength recover after SCR? First, we measure the muscle strength by using the isobex, scaption, and the internal and the external rotation. Muscle strength of the scaption and the external rotation, the repair group, less recovery compared to non-repair group. And this is the data of the scaption muscle strength. The muscle strength recovered until 1 year and recovered to the 61% compared to contralateral side. There is the same trend in the external rotation. It recovered to until 1 year and recovered to 63%. Internal rotation, almost no change. So muscle strength 2 years after SCR, the 61% scaption, 63% external rotation, and recovery was observed until 1 year. So rehabilitation should be performed until 1 year. In SCR, calf muscle are not reconstructed, and the subjects had severe muscle atrophy and fatigue generation. So why the muscle strength improved after SCR? We need to evaluate muscle activity. If we use EMG examination, we can evaluate only one muscle, only one point at a time. We need a new evaluation too. Therefore, we focus on the PET, positron emission tomography. It is well known by using PET, we detect cancer. But it was already demonstrated muscle activity can be assessed by the PET. By using the PET, we are able to evaluate many muscles at the same time, also quantitatively. Fortunately, in my institute, there's a special institute, and the PET device only for basic research is available. We have already published some paper studies by using this PET examination. In this study, the subject 20 shoulder divided into 3 groups, SCR, livers, and control group. Scaption exercise with 0.25 kilogram, 200 repetitions in 10 minutes. It is difficult to detect a precise anatomical location in the PET image, so PET image was fused to the CT image. By this, we are able to detect a precise anatomical location. For quantitative assessment, SUV, standard uptake value were calculated. This is representative CT and PET image of the SCR group. you can see middle deltoid portion shows a higher uptake. This is the mean SUV of the deltoid muscles of the control group. Middle portion of the deltoid shows a higher uptake, and the SCR group anterior and the middle portion show the higher uptake. Reverse group is also the same. And interestingly, there are no significant difference between reverse and SCR group. So deltoid muscle, during the elevation, middle portion show the higher uptake compared to anterior portion, and deltoid muscle uptake, SCR group show the higher uptake compared to control group. And very similar between SCR and the reverse group. And the periscapular muscle are also investigated in this study. Upper trapezius, and levatoscapulae, and the serratus muscle, serratus anterior, those muscles show the higher uptake. So which means the scapular upward rotation activated. And there's other reason which we can think of it. One is a pain decrease, and also humeral head is centered in the glenoid socket. Then the fourth couple functioned well. The mechanism of elevation, the improvement, middle deltoid in both reverse and SCR group. So how about external rotation? In this study, and we investigate the 29 shoulder who performed the SCR divided into two, good external rotation and poor external rotation group. Then cross-sectional area were measured of anterior and posterior deltoid and teres minor. The here result, posterior deltoid, good external rotation group shows a greater muscle area compared to poor external rotation group. So this study shows external rotation strength was correlated with posterior deltoid muscle. Next, we measure the muscle volume. The subject the same, and by using the image processing software 3D slicer, the 3D volume of the deltoid and teres minor were measured. Then here result. The muscle volume of the teres minor increased 1 year after SCR, and good external rotation group shows a larger volume compared to poor external rotation group. So this study shows the external rotation strength was correlated with the teres minor muscles. If you measure the cross-sectional area, the posterior deltoid is related to the external rotation strength, but if we measure the volume, teres minor is related to the external rotation strength. So there are the difference between two studies, but in our study, there are some limitation. First, the muscle strength was measured manually, not quantitatively, and the number of the subject is small, so we may have a type 2 error. In summary, the muscle strength of the scaption and the external rotation returned to 60% of the uninvolved side, and the middle deltoid muscle showed increased activity during elevation in the SCR group. The elevation mechanism is similar between SCR and the reverse. The posterior deltoid and teres minor are the external rotation compensator. Thank you for your attention.
Excellent study, actually, always. Yeah, so muscle strength, in your study, the graft tear and healed patient is different?
Yeah, different. The intact group showed higher compared to the retail group.
Really nice study. So Nobu, we also have the same outcome. The external rotation is getting better after ACR, even have torn. So, but I cannot explain why they have good external rotation. So someone do lower trapezius, but I think only SCR with big graph, you can cover the top and the back. So in your study, you found that external rotation is better. So that means we don't need lower trapezius transfer, right?
In my indication, the external rotation is positive, so it's excluded. So if you include the external rotation lung sign patient, maybe the result change.
So you're including you have weakness of external rotation and job test pre-op, right?
Yeah.
In your study.
Yeah.
Okay.
Any question? Okay, thank you, Nobu.
Thank you.
And next year, Dean Shaw is not here, but video live. Yeah, please.
Padiwala from Mumbai, India, and in this presentation on supracapsular reconstruction for massive irreparable rotator cuff tears, I'm going to discuss the modifications I've incorporated to improve shoulder strength. Supracapsular reconstruction is a useful procedure in any shoulder surgeon's armamentarium for treating irreparable massive rotator cuff tears. My indications for an SCR are irreparable postural superior rotator cuff tears in young patients. These patients necessarily need to be symptomatic, usually large or massive supra with infraspinatus tears. They need to have no significant cuff tear arthropathy. At the end of the procedure, you certainly should have a balanced transverse plane force couple. It means that your subscap and your teres minor need to be normal or repairable. The patient should have a normal deltoid muscle strength with no significant bone loss and no significant joint stiffness. One clinical situation where I prefer a tendon transfer over an SCR is a patient with external rotation lag sign being positive. In these patients, there's an obligatory internal rotation, and I think that a tendon transfer is more appropriate to restore muscle strength than an SCR in this situation. Teru's landmark paper on the clinical outcomes of SCR, patients did have improved shoulder strength. However, these increases in shoulder strength, why does shoulder strength improve in your standard SCR? I think this typically happens because of the tenodesis effect of the graft. It restores the center of rotation for the humeral head. It restores the acromial distance, and by doing so, it enables the transverse plane force couple to function effectively. This also enables the deltoid to function effectively. So this indirect effect really restores your shoulder strength. Unlike a bridging graft, in a bridging graft, you've got a direct motor action coming through the graft because your motor, which is the supraspinatus and the infraspinatus, is attached to the graft. And when we consider the modifications to improve strength, we thought that this would be something that we can incorporate. We'd like to do an SCR, but we would also like to incorporate the remnant supraspinatus onto the graft. So repair this onto the graft and thereby get some amount of a bridging graft effect. We have always got some amount of an infraspinatus repair, a partial repair of the infraspinatus. We're also going to repair the infraspinatus to the graft, but in the classical and conventional technique, the supraspinatus is not fixed onto the graft. Thought that by doing so, we can improve muscle strength. Show you the surgical technique in this patient, who's a 58-year-old female. She's a right pseudoparalytic shoulder with pain and weakness since the past 2 years. Repairable posterosuperior rotator cuff tear with a repairable subscapularis tear and no cuff tear arthropathy. I typically perform these procedures in the lateral position. As my first step, I'm always trying to see if I can do an adequate release and achieve a repair. And typically, if after the release I can't, then I proceed with the SCR. I'm going to freshen the superior aspect of the glenoid and put in 2 double-loaded anchors, superior aspect of the glenoid. Similarly, I'm going to freshen the greater tuberosity and put in 2 double-loaded anchors at the junction of the articular cartilage and the greater tuberosity. I then expose the fascia lata, and typically I'm going to take about a 12 by 5 centimeter long graft, and I will triple this to make it at least 8 millimeters thick. This triple graft is then introduced into the joint. Once I've fixed it onto the glenoid, this is the additional step that I perform. I suture the supraspinatus onto the graft, and by doing this, I'm hoping not just to improve the vascularity of the graft and improve healing on the medial aspect of the graft, hopefully also add some motor effect to it. Once I fix it, you can see that I've got the supraspinatus attached onto the graft, and I've got the remnant infraspinatus attached onto the graft. Now looking at it from the lateral portal, you'll see that that's the supraspinatus that's repaired onto the SCR graft, and posteriorly, we've got the infraspinatus repaired onto the SCR graft. We were to see the MRI at 1 year following surgery. You'll note that this patient has the interposition effect. That's the graft that's increased the acromial distance. We've got the tenodesis effect, which restores the center of the humeral head, and by this, your transverse phase force couple is more effective. But most importantly, you've got this bridging graft effect. So that's your SCR graft 1 year down the line that healed to the glenoid, but it's also healed to the remnant supraspinatus. I think that this probably gives it the bridging graft effect. These patients 3 months down the line will have significant pain relief and a good restoration of their function. But you'll note that their strength is not that good. That's because the interposition effect and the tenodesis effect have started acting by 3 months, but I don't think that the bridging graft effect has happened as yet because the graft hasn't. If you were to see this patient 1 year down the line, you'll note that there's significant improvement of strength. So of course, this acromial-humeral distance is still maintained. 5 years down the line, by 1 year, this patient has improved range. See, her external rotation strength is not as good, but it's at least functional. Now, what we saw in that previous patient is us repairing the supraspinatus directly onto the graft at this area, at this medial aspect of the graft. But in some patients, you'll find that although you can't do a rotator cuff repair and bring this tendon onto the greater tuberosity, you almost bring that tendon up to this aspect. So you should probably not repair the graft or repair the tendon onto the medial aspect of the graft. You should repair that tendon onto the lateral aspect of the graft. And that's something that we've started doing since many years now. I'm going to show you a case for this. In this young male, you can see that this rotator cuff tear, which is large, which is irreparable, when I'm trying to do a trial reduction, you can see that despite all of the relief that I've done, I can't bring this tendon onto the footprint of the greater tuberosity. I can't even do a medialized single row type of repair, bring this tendon without tension onto the tuberosity. I don't want to sacrifice and waste this tendon and muscle. I'm going to do an STR, but I'm going to do a rotator cuff repair onto the STR. So how will you do this? You do this exactly like an STR. I'm going to pressure my superior part of the glenoid, put in 2 double-loaded anchors on the superior aspect of the glenoid. Similarly, I'm going to put 2 double-loaded anchors onto the greater tuberosity. And in these patients, I often use all suture anchor for this. I will then take my graft, but instead of it being a triple graft, it's going to be a double graft. So this is about 6 millimeters thick. I take my sutures through the graft and then introduce the graft. Once the graft is well reduced, I'm going to tie the glenoid part first. So I do my glenoid fixation of the graft. Once the secure fixation is done, I'm going to cut these sutures. I then proceed to the medial aspect of the graft where I fix it down onto the greater tuberosity with the medial row anchors. The same sutures are then passed the remnant rotator cuff. That's the remnant supraspinatus. I pass the same sutures into that. I'm giving traction to bring it to its maximum, and then with the footprint anchor, I'm going to fix the lateral row. See what we've done. We've got our STR graft, which is covering the greater tuberosity, and we've got our supraspinatus not coming over the greater tuberosity, but given some amount of tension. This is now covering the STR graft to the maximum that it can. I've also done a partial infraspinatus repair, because you always want to repair whatever you can as far as that rotator cuff is concerned. The 1 year MRI, you'll note that this is true anatomical restoration of the cuff and the superior capsule. You'll see that that's your SCR graft out there that's healed to the superior aspect of the glenoid. This is the rotator cuff that's healed onto the SCR. You've got a nice transition there. You've got your rotator cuff with the superior capsule as it should be anatomically. And I think that this, besides the interposition effect and the tenodesis effect, is giving you the bridging graft effect. Look at this clinically. That's him pre-op in his right shoulder with pain and decreased range and loss of strength. But within 3 months, he's got the ability to perform his forward elevation quite effectively. And similarly, he's got a fair amount of abduction and external rotation too. And this will certainly improve. And by 1 year, it's going to be much stronger because the bridging graft effect comes in by then. Do these patients have these effects of clinical improvement beyond a year, beyond 2 years? That's something that we wanted to study. And so we analyzed all of our 10-year follow-ups following an arthroscopic superior capsule reconstruction with this modified technique of repairing the remnant cuff. And you can see that these patients do restore their range, their strength. Yes, there are some radiographic changes of osteoarthritis that start developing 8 and 10 years after the surgery. On the MRI, you'll note that that graft of the SCR with that healed rotator cuff is still effective. And on MRIs too, we can see that 10 years down the line, the anatomical restoration is good. We've been analyzing the strength returns with the handheld dynamometer, and hopefully by the next meeting, I should have these results out, and I'd love to be there in person to present these to you. Thank you.
Thank you very much. Actually, Dinsho is a very nice SGR surgeon in India, so maybe next time he can come. And Professor John Kelly, he showed the key release for SGR.
Thank you very much. In the words of Elizabeth Taylor to her 8th husband, I won't keep you very long. But I just wanted to thank you for having me here. I've been a gracious host. And Debbie's done everything for me but tuck me in. I'm just like, gosh, I mean, you know, I want to thank the audience just for teaching me. I'm looking around the room. Tony Romeo taught me how to do an arthroscopic bank heart repair. Dr. Sagai taught me more about bony bank hearts than I ever wish to know. And Hero, you know, you're a hero. So, but this is my guy, Ty Lee. And as we say in Ireland, no blarney. When you talk to Ty Lee, you get a straight answer. And Tiru showed a lot of character yesterday. He was in the lab. The cadaver was frozen. There was no fluid. The thermal was working. We had Paul Roach banging things. You know, and John Macy over here is like, tell him how to use a lasso or, you know, whatever it was, scorpion. And he's like, thank you, thank you, thank you. Well, what a great guy, character. And Irish Paul, I mean, look what he's doing. You guys know how Irish is Paul? His first breath was a 0.3. So why does SCR work? I'm going to give you a little paradigm shift, and I'm glad Dr. Yamamoto gave this talk because it kind of confirms what I held to believe. I think the spacer effect that Ty has shown, I think is a good part of it, more so than the compressive. And we have Maxwell Park here, whose IQ is higher than my malpractice premiums. And, you know, I work in Philadelphia and I get sued BID. So why does it work? We know, we heard this morning that it resists humeral head elevation, and that is a big part of it. But what we don't, and also, as Ty showed earlier this morning, it also depresses the head. And this is also going to give you, as we just heard, deltoid mechanical advantage. I think it's all about the middle deltoid. I really do believe that. It is a bioreverse. And unfortunately, I don't want to insult my Portuguese dear friends, but, you know, in Philadelphia, if you harvest a fascia lata, that's a subpoena waiting to happen. When people come to Philadelphia in the office, they have their lawyer, their massage therapist, their chiropractor, their agent. So I do think it reduces humeral elevation. We know that. It increases the tension in the middle deltoid. It increases joint congruency, so we get the effect of the labrum. And this is a work done by Gagey many years ago. And he said, basically the middle head may confer some humeral head depression if it is reduced. The R vector, think of especially when you have a low critical shoulder angle, the R vector is really analogous to a pulley. So the middle deltoid in adduction, there's a compressive and downward pull according to Gagey's model. And I think Tony showed that with Gus Mazaka's work. He also went on to show that it's legitimate to attribute the deltoidus a role in recentering the glenohumeral head during abduction. This is in adduction. Remember, you have that fulcrum effect of the humerus. Of the deltoid. 1867, du Boulogne. Any French in the audience here? My partner say, after electrostimulation of the deltoid alone, I observed that during elevation of the arm caused by the contraction of the muscle, the humeral head subluxated downward and tended to leave the cavitas glenoideus. Did I say that right? So Dr. Yamamoto, this is proven concept of what you've just been showing us through PET scans. He went on to say that the middle deltoid pushed the head downward through electrostimulation. This is 1867. That's because that 90-degree curve of the deltoid envelops the head, confers some compression, and acts like a cable on a pulley. Compressed head prevents upward migration. This was also further developed. He took a kind of analogous to what Tony did with the Gus Mazaka. He basically put pulleys on the acromion and the distal clavicle. And he showed for amplitudes don't exceed 40 degrees of abduction. In other words, just early abduction, 3 elements can appear to satisfactorily stabilize the head and the glenoid: the deltoid, the labrum, and the positioning of the glenoid. Why is this important? Well, if you start with the humeral head that's high and don't get it down, I think you're going to be doomed to failure. So it allows, this is I got from Katerina, this term, we were in Korea last year, and kickstart abduction. If we can kickstart abduction, then as we've shown, the scapular rotators, Yamamoto showed that in the PET scan, take over. And that's why it's so important, I think, to do these releases, to get the head down. These are my Portuguese friends, and this is my daughter, Mary. This is after 3 Soshus in Korea. You guys know what Soshu is? If you don't, you better find out. So what we can do is we can actually kickstart abduction, and the scapula can take over with that middle deltoid. Get the head down, keep it down with the SCR, and I'm going to talk about coracohumeral ligament release, panlabral release, inferior capsular release, and subacromial release. I do all these releases in every large cuff tear. This is why I get around, fixing many cuff tears that don't need an ICR. And this is how I do it. So I can get, actually, for my cuffs, a margin conversion. So I'm a big believer in this. That's kind of fallen out of favor. We all go on double row. We don't need double row. So I look from the front, work from the front. I'm a lateral cube guy. I use 15 pounds of traction in lower abduction. I get that head down and a little bit of forward flexion so I don't get under apraxia. And these are the portals I use. And then I look from the front and I do whatever it takes to get that down. Now, a little anatomy, the coracohumeral ligament originates from the lateral and inferior portion of the coracoid neck. So if you expose the coracoid during surgery, you think, oh, I got that. Coracohumeral ligament. No, you don't. You don't. You need more than exposing. This isn't exposure. This is the interval. Oh, I release interval. I'm fine. No, the coracohumeral ligament origin is still intact. So you have to really do your best to skeletonize it and release the lateral base until you get to the glenoid. This is very important work. And then I get all the way down here and I look at, sometimes you get a 7-degree scope, release that coracohumeral ligament so there's nothing's going to hold that humerus up. And then I look from the front, work from the front. There's still some remnants here in that neck that I can get. Buddy Savo believes you have to go subacromial. I don't think so. I think you can do it from the inside the joint. But if you want to finish in subacromial space and maybe some vestiges right there, that's the origin of the CHL right there. Those of you who do total shoulders know that it really starts at the base of the coracoid. And then I do my inferior capsular release. And here's where I pray to Santa Maria because, you're near the nerve. That's why I use thermal. So I'll hug the glenoid. And I went from scissors to thermal because the scissors work great, but I'm not really know where I am. And you do some pre-op planning. Where are those vessels with respect to the inferior capsule? So I had no before the surgery, how careful I got to be. And I'm very cautious. So now I use a thermal pointing up until I get lower. And you guys, you'd be surprised how much this really helps getting that head down. And it makes the rest of your surgery even easier. Whether it's a massive cuff tear or SCR, it's going to make it easier. Then I release the cuff off the labrum here. And this applies to cuff tears as well. You made a few millimeters of excursion. And then this is what Buddy taught me. I release this subacromial adhesions. I start in the lateral gutter, get all those adhesions. Then I come up, subacromial adhesions. And then I look from the side and I work from the back until I get to the scapula spine. And I do whatever it takes to get the head down. And then once the head is down, this is my dermis. I'm sorry, Katerina and Clara, but I use the dermis. But this is my bioreverse. And thanks to Ty Lee's work and Tiro, suturing it to the front and back is very, very important. It's very important. And you may get a result that looks like this. This is a dermis. So I would propose to you that these releases are very, very important. And I think what Dr. Mahata is doing is wonderful work because I have a lovely wife, 2 lovely daughters. And what would you want for a loved one? Would you want this? Would you want, this is my glenosphere prep. So thank you and God bless you all.
Thank you, John. Any question to John? Yeah.
Yes, I'm sober. Yes, that's fine.
So, Ty, how do you think the biomechanical? Do you think the inferior capsular release makes their head down?
If it's tight, you got to release it because it has to have room to go down. But I don't think that's needed in everybody. But if you do get it down, I totally agree with them that it'll be a lot easier because you have more space at the top.
If you want to know the answer, look at his work. He's, no nonsense. And he and Michelle McGarry did a great study showing that if you load the latin pec, you also bring the head down. So rehab, therapist in the office, the pectoralis major, and you also showed that the teres minor, or teres minor also helps.
So John, I got one more question. Looks like you used to be good looking. What happened?
That thing called age. I won't tell you my exact age, but my social security number is 4. And Tony, I was a waiter at the Last Supper, but besides that, I get my looks from my dad. He was a plastic surgeon. You like that, Ian? I forgot to ask Ian for working all this. And Ashley, where's Ashley? Ashley Judd. But Debbie's going to tuck me in tonight at 8 o'clock. Okay. Any other questions here?
Any other question?
I think it's lunchtime.
Okay, I think it's
lunchtime.
lunchtime.
Thank you very much.
You're welcome.
Thank you, John, very much. The lunch line is forming out Salon 3. I think they're setting up outside. Is that right? Yep. So follow Debbie over there and lunch will be available.
Outside in the street.
Not in the street. It's just outside the door. Oh, okay. We're gonna start getting ready to start again. There is plenty of food, and they're bringing the sandwiches into the coffee stations that are left over. So please help yourselves. A testament to everybody here. We're actually running on time. So I didn't think that was possible, given what's going on. Buddy Savoy couldn't be with us today, sends his regrets. So just an announcement before we bring up the famous hero Sagaya. So come on up. Just to remember, we have a reception. We have dinner at 7 o'clock tonight. There is a board meeting at 5:45 in the boardroom. Dr. Sagaya.
Okay, it's a great meeting. Thank you for organizing everything, Paul.
Yeah, thank you for coming. You were the first one to RSVP.
Yeah, of course. Okay, so I will speak about I have changed my talk title a little bit. I will speak about arthroscopic solutions for massive elliptical rotary cuff tears in Japan. Actually, SCR was born in Japan, so that's why I will speak about a little bit about the history of Japan. So these are my disclosures. So elliptical massive rotary cuff tear, I will speak about this. And the introduction of reverse is very late in Japan, back in 2014. And in the early 90s in most European countries, and mostly by early 2000 in other continents. So no reverse for a long time. So that's why the unique procedures for massive elliptical rotary cuff tears, arthroscopic patch replacement, of course, superior capsule reconstruction, arthroscopic debia pate, and also the extreme medialization. So actually, this is my, can you run my video? The center. Okay, this is my arthroscopic patch. I started the arthroscopic patch replacement using Teflon felt. Oh, okay.
There we go.
So actually, I started the Teflon using arthroscopic patch replacement using Teflon felt. I changed my technique to fascial ladder since 2009, and we have published the papers. And they're not this outcome is not excellent, but acceptable outcomes. So in the meantime, because Terry Mihara studied the very important paper, published paper, superior capsule reconstruction, and also the Dr. Kurokawa started the modified debia pate procedures. So this is an open technique, and his young guy started the mini open from 2003 and published in the English Journal, and also from 2018, the young guy. Dr. Furukawa said the all arthroscopic technique. So I'm following this technique a little bit. Okay, all arthroscopic rotary cuff advancement is like this. Okay, another unique procedure is extreme medialization. This is started by Dr. Mizuki. So this technique is to remove the bony tissue at the top of the humerus, leaving the tip of the greater tuberosity intact. And he published an outcome of this procedure recently in a journal of arthroscopy, and she had 64 large and massive rotary cuff tears, and interestingly, the tear rate is only 3.1%. That's amazing. And also this one is easier than muscular advancement. Okay, so the arthroscopic options for massive rotary cuff tear is the patch, SCR, and the muscular advancement and extramedialization. So when we look at these three procedures, superior capsule reconstructions works well in patients with Guttarius stage 4, very bad muscle patient. On the other hand, the muscle advancement, extramedialization, for these procedures, we need to utilize the remaining rotary cuff. That's why stage 4 is not a good candidate. So according to the muscle advancement paper, the ideal indication of rotary cuff advancement is the tendon retraction up to the granular level, Boyle 3, and also Guttaria grade 2 and 3, and Hammer 3 without arthritis, and the good and reparable subscap. So the options for elliptical massive rotary cuff tears, reverse is very good for elderly and poor function with pain. And SCR using fascial ladder is young and active patient, very bad bad calf muscles, criteria stage 3 and 4. And repair with muscle advancement and extreme medialization is a young or same young and active patient, but muscle quality is better than the SCR patient. Okay, so let's speak about the SCR. So the SCR is a surgery to restore the super stability in the shoulders with the liberal muscle rotator cuff tears using thick fascia. The tail and the thigh, they contribute a lot about the concept. And the use of the thick fascia rata, the graft choice fascia rata is the better than the human, much better than human dermal arrow. And also graft thickness to be very important, around 8 millimeter or more, even more. So the harvesting graft is we need to make a big skin incision like this. Also, for the graft harvesting, one surgeon and a plus assistant, and the requires 30-40 minutes for graft harvesting and shaping. And the preparation, we're going to have a joint operator plus assistant, so that's why grafting requires 1 hour, so that's why it's a total of 2 hours for skilled surgeons. So this is the picture from the obtained from the Dr. Hasegawa, Mr. Harvester, and yeah, like this, and include the pedicle. That's very important to create a thick graft like this, like that. So we normally use in the 10 cc syringe to introduce the graft to the joint. And a biomechanical study, according to the biomechanical study done Teru and Tyree, this is very interesting. Fascia rata is very stiff, but dermal arrow is a 15% of elongation. So that's why the fascia rata is very important for the successful SCR. So to restore the stability, the fascia rata is much better than dermal arrow, and the dermal arrow is, I don't think it's ideal graft material. And also the long-term outcome study, according to the long-term outcome study, graft tear in the SCR using dermal arrow is much higher than the fascia rata SCR. Okay, and this is the interesting center study in Japan. We did from April 2013 to March 2020 in 4 centers, and 211 underwent arthroscopic SCR, including 190 males and 92 females. And this is graft integrity was assessed by my classification, and type 4 and 5, the total graft tear was 11%, including type 4 and 5. ASA score is better, but type 5, only type 5 had a deteriorated ASA score. And also the active port fraction doesn't change. To summarize the SCR study, our center study, possible graft integrity affected clinical outcomes, and graft healing with sufficient thickness restored glenohumeral stability and improved the shoulder function. And the shoulders with large re-tear, graft tear type 5 demonstrated significantly inferior clinical outcomes. So the concerns about SCR is the fascia rata SCR is the donor side mobility. Everybody understands this. So skilled, experienced harvesting surgeon like Dr. Hasegawa is also necessary. So if otherwise, time-consuming surgery. So currently, we are seeking the potential of using a sick graft from animal. This is not the xenograft. This is the, I call this graft as a super graft. Professor Iwasaki in Waseda University invented this. This is, what is this? This is development technology. He developed the technology of a novel decellularized tissue with mechanical integrity and biocompatibility. This is a decellularized xenograft. So he created the more than a 10 millimeter thickness and the mechanical integrity like this. So we already started the clinical test for the knee ACL reconstruction. And also we're going to start the, the seat-like graft, using seat graft for the SCR. We're going to start the clinical test maybe hopefully during this year or early next year. So why supergraft? This is not autograft, no allograft, and no xenograft. And this is graft incorporation process. Autograft, in case of autograft, the decellularizing process takes about 1 to 3 months. And then after that, cell infiltration occurs and the maturations finished the 2 years after the surgery. But this one, new graft, super graft, we can expect immediate cell infiltration and also the non-immune reaction. So that's why they were really expecting the super graft coming out to the market. So from now, the Professor Iwasaki, going to speak about the background and also what's happening in the super graft. Thank you for your attention.
Thank you, Hiro. Always a pleasure. Dr. Iwasaki is going to discuss the new graft.
Thank you very much. It's my great honor to show our recent research activity in this inaugural SCR Association meeting. I would like to express my sincere gratitude to Dr. Roshi and Dr. Mihata and also Dr. Sugaya for this opportunity. So today I'd like to share our development of decelerated tendon graft for SCR. So tendon, the highly hierarchical structures that actually functions to translate different.
It's correct here. There.
How can you do?
Yeah.
Go back to?
Yeah, I think so.
Maybe.
Nick, you want
Okay. So tendon and this. Okay, I'll see this one.
Yeah. Just look at that one.
Ligament has a highly hierarchical structure that actually stabilize.
We need a different slide, Nick.
Oh, it's okay now. Now it's
All right.
okay. So the idea is the use of the natural structure of the tendon ligament. So preserving the native tendon-specific extracellular matrix through decellularization make it an attractive graft material for SCR. So this is our proprietary decellularization technology that removes immunogenic cellular components from biological tissue, but preserve mechanical integrity of the tissue. That is quite difficult. So our issue is treat tissue under pulsary circulation of detergent or pressure and flow in parallel with microwave irradiation in a room temperature. So here you can see the very clean white decellularized tendon with the diameter is 7 millimeter and the length is 16 centimeters. So we already started the first in human clinical trial from primate ACL reconstruction from December 2024. You can see here that the diameter is around 10 millimeters for ACL. So it's actually, this is the first case, and actually the 18-year-old male, the right side shows a MRI image after 1 year, so it looks very nice. So this patient actually returned to recreational soccer 9 months post-operatively. In the development of the decellularized tendon for ACL reconstruction, I fortunately have an opportunity to discuss unmet clinical needs in shoulder reconstruction with Dr. Sugaya. And Dr. Sugaya pointed out the actually critical challenge that is the development of ideal graft for SCR. He suggested that our technology might provide a solution. Motivated by the clinical needs, we started the development of the decellularized tendon for SCR. Dr. Mihata already says that the graft for SCR needs more thickness, like 8 millimeter, and also higher mechanical stiffness. So actually both our decellularized tissues both meet the criteria. So you can see here that left side shows a native tendon and the right side shows a decellularized tendon. So you can see the HE staining shows a complete absence of cell nuclei, while the crimped collagen architecture is highly preserved. That is very important to maintain tissue structural integrity. So here shows the residual DNA contents after decellularization. So you are using some animal driver, for example, dermal xenograft or SIS, the small intestinal submucosa for plastic surgery. And the immunogenic reaction study already shows that the safety threshold for the residual DNA content is 90 nanogram per milligram. But our technology actually reduced the residual DNA level well below the safety threshold, even the thick tissues, not the 3 millimeter or 1 millimeter, so 10 millimeter even. So this data showing the actually biological safety. So another important issue is how to sterilize tissue without damaging. It's another critical challenge. So we also have the proprietary method to freeze dry tissues prior to sterilization. And after that, after sterilization, the tissues can be rehydrated with room temperature saline. That's important for handling. After the desterilisation and sterilization, mechanical strength preserved. So here shows the ultimate stress compared with the human tendon. As shown here, it's reference data. Our tendon exhibits superior mechanical strength compared to the human tendon. So it's actually showing the potential advantage of our tendon graft for SCR. So we started SCR animal study using SIP model. So we use a thickness of 7 millimeters and width is 18 millimeters and length is 7 centimeters, as shown here, and did a SCR by open surgery using anchor and also fiber wires. And we actually present a proof of concept data in SIP model of massive rotator cuff tears. Unlike human patients, the actually SIP bear weights on the operated shoulder immediately after the surgery. So it's represent more than worst case scenario. Even under these demanding conditions, the decelerated tendon-based SCR functions successfully for 3 months. So here shows the gross appearance at 3 months post-SCR. So you can see very nice neovascularization of the tissues. So here is a HE staining at 3 months post-SCR. So the tissue is infiltrated with autologous cells in vivo. And you can see the excellent bone graft integration. And you can see also Sharpie fiber-like structure at the interface between bone and graft. And also micro vessels are formed as shown here. So also, we evaluated mechanical robustness and SCR configuration using tensile tests. Just study, but you can see here that failure occurred at the suture, not the graft. And the tendon is mechanically robust enough to withstand suture loading without teeth cutting. Our decelerated tendon may provide novel therapeutic value. These grafts offer a ready-to-use 8 millimeter thick high stiffness graft for SCR, which may contribute to reducing graft failure rate. And also it eliminates the need for autologous harvest and promote autologous cell infiltration, tissue regeneration, and functional remodeling. It's also proven in ACL study in SIP more than 1 year study. And also it shortened operative time. So this is the last slide of decelerated tendon holds a strong potential to transform the treatment of massive rotator cuff tears, building on the Dr. Mihata's original concept of SCR. Thank you very much.
Very interesting innovation and development that may be helpful if it can meet the gold standard of what we've seen with fascia lata autograft. What stage of clinical testing are you at this point for SCR?
SCR, we actually included 9 patients. 3 patients actually post-operative 1 year. So very good situation now. The second return to recreational basketball also.
Okay.
Yeah.
So very nice presentation. I'm asking, is that the tendon from the pig?
No, bovine, but calf.
Okay, which part of the tendon you took it from?
It's the lower part of it.
Oh, lower.
Okay.
But the important thing
Achilles, right? Not Achilles of the cow.
We can use, but the Achilles tendon of cow is huge.
Huge, too big.
It's
right?
too big to human, I suppose.
Okay.
You can cut, slice the tendon or Achilles tendon.
Interesting. Thank you.
Thank you very much.
I have a quick question. So it came from bovine. You're looking at collagen structures. Obviously, this immunologic response, obviously we don't understand it completely. Have you tried this process with human allografts or taken from cadaver, or is there a certain part about that it needs to be a living tissue or something? So my question is, have you tried this in human allograft tissue.
So,
That's number
but-
one. And I forgot the second question.
We can do the
Basically,
deceleration
how did you
Oh.
choose your species and make this selection for this graph?
in terms of actually size. It's applicable to human.
Yeah. One thing about these animal healing studies, especially with rotator cuff, my experience, I know there are papers describing differences. It seems like anything you do to these sheep, they heal.
Rabbits too.
So, it'd be great to see you do this in human tissue and see how that works.
But the important thing, it can be remodeled, and the cell migrate into tissues, and the cell produce patient, for example, the own tissues, and it turns into the patient tissues. We have confidence because we did a lot of study in sheep. Actually, the collagen fiber turn into the recipient tissues. So that means
Well tolerated, adopted, and integrated.
yeah. So the important thing is that if the tissue is damaged, then implanted, it will be damaged. So some early adsorption something or high immunoreaction or inflammatory reaction occur. So how to preserve the extracellular matrix of collagen or tendon structure is key and crucial.
Thank you very much. At a game-changing meeting, we're seeing potential game-changing innovation. I turn this over to Clara, who will take us to the next section.
Thank you.
Thank you, Paul. So we'll move on.
Subbacrum spur. So on the MRI, you can see we got some subscap tear, supra and infra tear. And you can also see this on the sagittal image. So muscle is not that bad, but moderate degeneration. So this diagnosis would be massive. I wouldn't call this irreparable, but hard to repair with tear. You can see that subscap and infra quite repairable, but supra may be repairable, but only with high tension. So like Clara said, I think this is a perfect case for the SCR. You can repair what you can and then do the tensor fascia lata SCR. So in 2016, I was lucky to visit Professor Miyata's clinic. I was Professor Inho John's fellow then, and I learned the tricks from the master himself. So those who have seen his setting, this is Dr. Mihara. Simultaneously, the Dr. Hasegawa is taking the draft. But unfortunately for me, I don't have this kind of great team. So I only work with one resident. So I first start by harvesting graft. So on the X-ray and MRI, I measure the size and determine the how much graft size. I work on the back table while my resident set up the arthroscope. And then finally the SCR. And then the worst nightmare has happened to me. So just for you know, it wasn't me, it was the scrub nurse, but I didn't scream. But I was like this man for a few seconds until I grabbed myself and thought about the next step. Obviously, easiest one would be just throw away the graft and use the allodum, which was available. But I've already taken the graft, and what about this extra cost? And I didn't get the consent of the patient. Maybe I can take the graft from the other side, but there would be too much time and effort, and I would be causing unnecessary damage. Can I still use the graft? Then it hit me, because I remember that the knee surgeons talked about the dropped ACL graft management. I remember hearing from conference, and then I stopped and called my fellow knee surgeon and said, "Oh, this happened to me." He says, "Do this and that," and then fingers crossed. So this was right after I took the graft, and then after all the decontamination, this is how it looks. So, and then I started the scope. Obviously, the joint looks okay. Got some problem with the biceps, so I did tenotomy and subscap here, subscap. So I did a repair from inside. So I always do acromioplasty, like Miyata says. And this is the main tear. Looks repair, but after release, it was not reducible. So I go ahead with the glenoid side and then put the anchor and then repair the infra, and you've seen the rest, yes. So this is immediately after the surgery. You can see the graft is sitting nicely. But I was very worried what might happen to her. So in 2 weeks, luckily the wound was well healed. She was out of the pain. And 4 weeks, still the clean wound. So started the passive range of motion. At 8 weeks, the lab test was normal, thank God, and the pain was getting better. So I removed the sling and started the active range of motion. At 4 months, I did not find any sign of inflammation. She was free of pain. The range of motion was much better. Then at 6 months, she was doing great, already back at work, no pain. So I took an MRI at the 6 months. You can see that healed okay. So the last follow-up was 2 years. So she has no pain, full activity, full range of motion, complete recovery of muscle strength, and she was very satisfied with the outcome. So currently, there's no guideline for accidentally dropped SCR graft, but there is some evidence from ACL graft contamination that we can learn from. So how often does this happen? So according to this study, 25% of these expert surgeons reported at least once in their career they drop this. So this can happen to anyone. So it's not a matter of if, but when it happens to you. So I think you need to know this established evidence-based management protocols. So is it safe to reuse it? So in vitro study, there's a high contamination rate, meaning if you dropped it, it's infected. But luckily, if you use 4% chlorhexidine, you can achieve almost 100% bactericidal efficacy and without losing any structural integrity. But in reality, I looked up everywhere, but there's really no clinical evidence. It's very limited, I guess, due to this ethical issue and the reporting bias. So it's actually up to us, the surgeon's judgmental call. So is autograft less vulnerable to infection? I guess that's what everyone's asking. So theoretically, it has an advantage of higher revascularization potential, and it's robust even after washing. So, and luckily there's some clinical evidence that shows that the superior infection resistance of autograft in the ACL study. So allograft associated with almost 7-fold increased odds of infection in this study compared to the autograft. So my suggested protocol would be just don't panic, pick up ASAP. And then, yes, just do a lot of washing with the saline first, and then soak it up in the 4% chlorhexidine for 20 minutes. And then the knee guys like to do the vancomycin pre-soaking. So do it for 10 minutes, then final implantation. All right. In summary, SCR is a reliable surgery for irreparable RCT. It has helped me a lot, and I think it's a very powerful tool in my practice. If you accidentally dropped SCR graft, I think adopting this established ACL rescue protocols is a viable option. And I think the autografts exhibit superior resistance to infection compared to the allograft, so facilitating successful graft salvage. Right. Thank you.
Thank you so much. We'll do this discussion in the end. Yes. Okay. So now it's Noya Hirosawa who's going to talk about the pitfalls of real SCR in the beach chair position.
Good afternoon. My name is Naoya Hirosawa from Chiba, Japan. Thank you for giving me the opportunity to present here. Today, I will share practical pitfalls performing real SCR in the beach chair position. My presentation is not intended for the experienced surgeon here. Rather, it is designed for those who are about to start performing a Mihata-style SCR in the beach chair position. I apologize if the contents seem too basic or limited. Please take a nap or restroom. It's okay. Okay, let's start. In December 2023, I met Dr. Mihata and Dr. Hasegawa for the first time. Their lateral decubitus SCR was extremely efficient and reproducible with a flawless workflow and a high-quality thick fascia lateral graft. After observing them, I was determined to replicate their technique as faithfully as possible. I'm from Chiba, so we performed the all-shoulder arthroscopy in the beach chair position. So I needed to adapt Mihata's lateral decubitus SCL to the beach chair position. Since December 2023, I have performed 14 Mihata-style SCL cases in the beach chair position. 5 cases had fascia lata harvested in the beach chair, and the remaining 9 were harvested in the lateral decubitus. We encountered 4 intraoperative issues, and all were suture entanglement during graft insertion, including 1 graft malrotation during anchor suture passage and 3 leading suture-related tangles. So these are 2 major pitfalls when we translate Mihata's SCL to the beach chair position. First, suboptimal graft preparation in beach chair. Second, graft rotation and suture tangling during insertion in the beach chair position. Pitfall number 1 is suboptimal graft preparation in the beach chair setup. Beach chair, fascia lata harvest is challenging. It requires non-obese patient and adequate hip mobility, and the intermuscular septum may be incompletely included. My solution is to harvest the fascia lata in the lateral position first to secure reliable thickness, then convert it to beach chair for arthroscopy. I harvested the general's graft about 5 to 6 centimeter wide and around 18 centimeter long. Even though we cannot precisely measure the defect size arthroscopically, the downside is only a slightly larger incision, and harvesting a bit more rarely becomes a problem. Now, pitfall number 2, graft rotation and suture tangling during insertion in the beach chair position. When we teach as an assistant from behind the shoulder, it's easy to place the Mayo stand posturally. The key point is to place the Mayo stand in line with the graft insertion direction, so the graft can be staged and advanced without unintended rotation. Second, I switch the viewing portal from posterolateral to posteral during graft insertion. This prevents the Mayo stand from interfering with the arthroscope, and it gives a better global view of the graft while advancing it into the joint. So during a graft insertion, I prefer postural viewing. Third, how we handle the leading suture matters. I retrieve the glenoid side leading suture through the interval between the 2 glenoid anchors, between the anterior and the posterior anchors. This is a minor details, but it's crucial. It helps prevent suture entanglement during graft insertion. One more practical pitfall is reinforcement knots where anchor suture will pass. If reinforcement suture are tied along the plant suture passing line, the knots can fray or loosening during insertion. My solution is simple. Mark the plant suture passing point first and avoid tying reinforcement knots on those lines. For reinforcement, I prefer black ones surgeon, which also help the graft arthroscopically. In conclusion, by keeping these pitfalls in mind, graft quality first, controlled graft staging, posterior viewing, deliberate leading suture routing, and smart reinforcement placement, we can achieve a smooth and reproducible beach chair SCL, approaching the precision of the Mihata technique. Thank you very much for your attention.
Thank you, Noya. I expect we'll be discussing a lot at the end. So now we'll listen to Noman Naki talk about rehabilitation guide in the USA. Sorry about misspelling your...
No, you're okay.
Thank you.
Yeah, I think Dr. Roach initially had my name like Noman Nagui or something like that. Yeah, that's okay. So I wanted to talk briefly about the rehab that we've done, and it differs a lot from regular arthroscopic rotator cuff repair protocol. And so in order to be effective, we need to make sure that we're, of course, restoring function, range of motion, strength. And so specifically in our patients, we're working with a lot of workers' comp. So it's really important that they get enough strength back. And we've actually found a lot of success with this surgery. And so, yes, of course, pain management and restoring range of motion is important. But for us, for this focus, I really want to put an emphasis on protecting the repair, because that's where I think a lot of like protocols have room for error. And we've seen this, of course, with, sometimes we've sent patients over to a physical therapist who was not quite sure, and they maybe were too aggressive, and therefore we found that the graft was torn. So it's really important for your rehab protocol to ensure that the graft is actually intact. So again, going into why SCR rehab fails, and it's because early loading of the graft, if it's treated similar to a rotator cuff repair, of course falls, and overall in conclusion, it's really correlated with biological overload from what we found so far. So again, it's not a rotator cuff repair, and this is more so, of course, for your physical therapist that you're educating on. Tell them that, of course, it's non-contractile fascial lata graft, and it's just restoring your superior constraint. It does not replace the cuff contractility. So going over here, of course, the biomechanics, which many before me explained this much more detail than I have. So next here. This study over here, sorry for my slides being a little off. They explained this to me before. I changed it from PDF into a PowerPoint, so that's okay. So look, we actually use a study by Takayama, and we use it kind of as a basis for what we're looking for in terms of strength. And this was a follow-up study done 2 years after an SCR, and they used the hand dynamometer to actually measure the strength. And they found that the abduction recovery was about 48%, elevation and scaption was about 60%, internal and external rotation was about 80%. And that's kind of the basis that we use going forward. And I think also explaining to your patients of what the expectation may be. So of course, another key note is, pain-free does not mean that the graft is healed, because your patients, especially if they're non-compliant or if they get too excited, they can overload it. Just because they have full motion does not mean they need to, again, overload it. And just because they feel strong doesn't mean that there's actually structural integrity. So over here, the way that we've done our rehab and we've had success with is we do a approach that's really guided by the MRIs. And so, of course, pre-op, what we do is we have them just do gentle pulleys and very, very passive exercises. They actually don't see the therapist, as Dr. Roach mentioned earlier, about 7 to 8 weeks out. And when we do start, it's very, very gentle, which we'll get into details. But basically at 3 months, that's when we start controlled activation. It's very, very, very gentle strengthening exercises. It's not until the 6-month mark where we really start to strengthen. And we're not proceeding at all until we get the clearance from the MRI that the graft is healed properly. So of course, phase 1, 0 to 12 weeks, we actually don't see them until 7 to 8 weeks out. Biggest thing is just keeping everything nice and passive, not to overload the graft at all. This is where, when they do see the therapist, the difference is we actually implement some manual therapy, going into flexion and gentle abduction, external rotation, internal rotation, not past any pain levels and not really pushing through any stiffness at all. Phase 2, this is where we get that first 3-month MRI clearance. And so once this happens, we could start to go into active assisted, wall slides. We start isometrics right now, have the patients going into only about 10% of their strength, because otherwise they really want to break the wall in front of them, and that's not going to do any good. And of course, controlled forward elevation, light banded rows, and things of this nature. Again, after 6 months, this is where we start to do functional strengthening. And again, our patient population is majority workers' comp. And so the focus is to get them to go back to all of the things that they need to do, whether it's pushing, pulling heavy, lifting heavy, carrying, etc. These are just kind of the progression of the exercises that we do after the 6-month mark. And so these are the results that we found so far. We did this one early on back, and we do understand the limitation is a limited number of patients, but what we found was the SANE score improved by about 42%. The mean VAS decrease was 3.67 points, and the mean range of motion increase was about 41 degrees. This was early on. So we did have 2 patients when we were rehabbing who were non-compliant. And although that's unfortunate, but it did teach us something. And these 2 patients specifically were non-compliant after the 3-month mark. So the 3-month MRI showed that it was intact. And what happened was they were overdoing it. And both of these patients were just, I guess, now understanding that just because they have the range of motion, they feel good, that their graft still is not totally healed. And so they really, really loaded themselves up and did whatever they wanted to do. At 6 months, we found out that the graft was torn. So therefore, it just reinforces the importance of doing an MRI-guided rehab and waiting until 6 months before you actually start to really strengthen the patients. And so when it comes to the fascia lata, majority of patients don't really complain about having pain or issues after about 90 days. We just follow kind of general protocol of like avoiding deep hip flexion before 90 days. We tell them to expect, lateral thigh or upper thigh stiffness. But when they do have these issues, we did find there's a correlation of patients who had atrophy or significant weakness of that hip, or they're a little bit thinner or smaller. And so for those patients, we've implemented some PT. And that PT usually consists of strengthening and gaining a range of motion. We found success with that as well. After only about 6 to 12 sessions, they were very, very functional. So What we're trying to implement is a prehab approach we're going to be doing soon of kind of screening out patients that we can expect having issues with their fascia lata incision. And so maybe strengthening them and getting more mobile before the surgery as well.
Thanks so much. So now we'll listen about MRI evaluation post-SCR. David Stoller.
Thank you, Paul, for the invitation and the opportunity to collaborate for the past 10 years. We're going to do this without a pointer, so we'll do the best we can. All right, so let's talk about some of the concepts we have with MRI. There's a concept of the anterior superior corner, the posterior superior corner, and also understanding the relationship of the superior joint capsule of the shoulder to the footprint relative to the supraspinatus at the greater tuberosity. This is a review of the histologic layers of the cuff. Note the coracohumeral ligament contributes to layers 1 and 4. So often when we look at the posterior extension of the biceps pulley, when we look at the roof of the pulley, that's made by the coracohumeral ligament. The posterior extension of the coracohumeral ligament, in essence, becomes the superior joint capsule. The thickened portion of the superior joint capsule is our cable. Here's a sagittal view on MRI, and you can identify the large structure as a biceps tendon. That's the interarticular biceps tendon. The roof of the biceps tendon is always the coracohumeral ligament. If you follow the coracohumeral ligament posteriorly, it becomes cable tissue. It becomes a superior joint capsule. Thickened portion of the capsule is the cable, and that's directly inferior to the supraspinatus tendon, and that will continue posterior on the articular side of the infraspinatus tendon as well. Now, let's go back historically. This is how, like, Paul Roach and I got involved with a lot of the concepts that were going from the superior joint capsule, the cable, to where we are today on the surgical course. When you looked at the Posta lesion originally discussed by Steve Snyder, we all thought the articular side of the Posta lesion was retracted cuff. It's not really supraspinatus tendon. The tissue that is on the articular side of the supraspinatus is a high-grade partial tear, is really retracted superior joint capsule and cable. And so you can't treat that as if it were cuff tissue. The supraspinatus tendon is basically sliding superior to the retracted cable. So you can actually have a differential retraction between torn cuff and torn cable. They're almost independent of each other. So when we look at MR criteria, we look at integrity versus failure. Anything that is visualized as hyperintense fluid signal intensity is going to indicate failure. We use T2 and fat suppressed proton density, which a lot of people call fat suppressed T2 weighted sequences, to examine the SCR construct. Plus, I'm going to introduce this concept of a specialized view called a coronal oblique sequence that's perpendicular to the infraspinatus. It's going to be very useful in evaluation of superior joint capsule reconstructions. And also the concept of the acromiohumeral distance. We want to restore the preoperative measurement in a torn cuff of 4 to 5 millimeters to post-op measurements of 8 to 9 millimeters when we restore the capsule. These are the pulse sequences we typically use. In other words, we'll use an anatomic sequence, and we'll use a T2, a fluid-sensitive weighted sequence. In the case of the coronal, we actually have 3 sequences. We have a fat-suppressed, let me bring that back. We have a fat-suppressed sequence, a T2 sequence, and then this coronal oblique sequence as well, perpendicular to the infraspinatus, because the infraspinatus has a different curvature relative to the supraspinatus and the greater tuberosity. Axial, sagittal, both types of sequences. MR assessment, we're going to look at the graft measurement, medial to lateral. We'll look at the long axis measurement in the sagittal plane. We'll use a posterior oblique image perpendicular to the infraspinatus to evaluate the relationship of the posterior graft to the anterior infraspinatus, and also appreciate the integrity of the infraspinatus itself. Graft integrity could be assessed as whether it's attenuated, partial tear, or there's discontinuity. We'll look at graft thickness as well as look at graft signal, but we'll look at graft thickness on the humeral side, mid-graft, and on the glenoid side. In terms of MR assessment, we'll look at the graft fixation to the humeral head and the superior glenoid, maturation, which is signal and morphology, the acromiohumeral distance based on the anterior acromion in both the coronal and the sagittal plane, the relationship of the graft to the supraspinatus, and as I've referred to, the posterior edge of the graft to the anterior infraspinatus, an important relationship, and of course the status of the subscapularis tendon as well. So the acromiohumeral distance in review, it'll vary based on the imaging modality and positioning and arm elevation. It's the shortest distance between the acromion and the proximal humerus. It's used to assess superior migration of the humeral head. Typically on upright radiographs, it's 9 to 10 millimeters, but MRI is not done upright. So in MRI, the acromiohumeral distance is about 1.2 millimeters or 13% less in shoulders with an intact rotator cuff because it's the effect of being supine, right? So the range on MRI is about 5.9 to 9.2 millimeters. But remember, MRI is not accurate as a primary assessment for subacromial space done in a supine position. So it's just one variable that you're going to use to assess the superior joint capsule reconstruction. So typically an acromiohumeral distance is, if it's less than 7 millimeters in upright radiographs, it's diagnostic of a full thickness tear, high specificity, but low sensitivity. Correlates with the tear severity and muscle degeneration, which includes fatty atrophy, correlates with tear location, such as posterior superior, anterior superior, because these are functions of what causes the humeral head to migrate superiorly. So here's an example of measurement of the acromiohumeral distance here. We're picking the shortest point. Notice I'll look at the anterior acromion, both in the coronal and the sagittal plane to make my measurements. Here's a case where there's a massive tear, supraspinatus, infraspinatus tendons. This is preoperatively. So you see the superior migration of the humeral head relative to the acromion, retracted supraspinatus. Post-op, you've got the length of your graft measured here. You've got good thickness and uniformity. This is what actually I think the first case that Paul did. So he didn't have an intramuscular septum on this case. Showing you the location, there's on the left, you can see the torn infraspinatus tendon. I'm showing that in the sagittal image. And then we use the oblique sequence. So we're perpendicular in the sagittal plane to the infraspinatus, and I can actually appreciate the continuity of the infraspinatus with scar tissue extending toward the greater tuberosity. I would not be able to appreciate that on these straight orthogonal images. Here's another case. This is an autographs at 6 months. So we're seeing the graft thickness, relatively uniform thickness on the coronal images, good anchor fixation, humeral head, superior pole glenoid. That's the orientation of my posterior oblique sequence. Notice the scar tissue forming there between the infraspinatus and the supraspinatus where the graft is, or the graft tissue. 3 months, again, on case 3, let's take a look at this. Uniform thickness, hypointense graft tissue. And on the sagittal image, we can see that continuity of the infraspinatus going toward the supraspinatus and the graft. Here's a graft at 10 weeks. There is laxity. If you see on your graft have this lax appearance in the coronal plane, that's abnormal. It shouldn't look like that. So when you look at the corresponding sagittal images, you see a gap. So this shows you the complete disruption of the posterior graft on sagittal images, because you should never have a graft that has that kind of laxity on a coronal sequence. Here's a reinforcement single layer, now fascial autograft with transosseous fixation. So you can see the graft is thinner. With MRI, especially with the fat suppressed sequence, we can actually differentiate the layers that we might not be able to see on the more conventional T2 weighted sequence or with this T2 without fat suppressed. So we can see the supraspinatus, what is basically supraspinatus tissue. We can see capsular tissue, and we can see the single layer autograft all labeled out there with those arrows. Okay, in the sagittal plane, we can also differentiate the layers between what is autograft, what is the supraspinatus with the autograft, the scar tissue, and capsular tissue. And here's a case of a retracted subscapularis and infraspinatus. This is what causes our superior instability. So far anteriorly, we see the graft, but you have a retracted subscapularis on axial. You have retracted infraspinatus, and we've lost our subacromial space. So you basically have a reduction of the acromiohumeral distance in this case. All right, thank you. That was a quick tour on MRI. Appreciate it.
Thank you. So now back to Paul to talk about graft failure cases.
Just got to see that it takes a village, because that's my team that's been helping us implement this. So thank you. Could I get the presenter's view, Nick? Okay, so this morning we talked about what clinical success we've been having, but you don't develop a new procedure or take on a procedure that's established that's new to you without having to honestly look at your failures. The failures are very instructive for us, and so this morning, I think our count was somewhere around 77. We've had 16 patients that I designated as procedure failures. They fall into 5 categories. We have fall and non-compliance as the largest category. We had graft tears that were without any history of trauma. Those are most concerning, and those were early. Late graft tears after 12 months after procedure, still concerning, but maybe a little less worrisome now that we have suture patch. And then there were healed grafts that had other structural failures, subscaps that didn't heal, so they did not get the check rein effect and had superior instability. And then we've had one patient who had a very well-healed graft, but lost the articular surface flattened in the humeral head, so there must have been some OA that we had not determined. So almost half, the take-home message I thought on this was almost half of our failures looked like they were preventable in the fact that they were patient failures, as Taro has taught me. And they were related, because any failure in the beginning, I, of course, like Erica, would be stressed over. And so I looked at him and I'm like, well, some of this is maybe the education of our patients. We need to assess what their living situations are, things I normally didn't get involved in regular rotator cuff surgery. We now get involved in what's their support at home. We check their ambulation status. Like Noman mentioned, we're starting to look at patients. Maybe we should get ahead of the problem, start some rehab or prehab to assess, their gait stability. Do they have gluteal function? We're going to look at deltoid strength as part of our program. Things that we thought we might be able to improve on, particularly for that group. And if you looked at our failures, they really fell into two categories was the majority of our failures. Those related to the patient in some way. It's easy for the doctor to blame the patient, but in this case, I think it's actually they contributed to their failure. And then failures that were related to the graft or something to do with technique. And of course, I look at both of these, but I'm mostly concerned with which things I might improve on as I'm operating here. So the atraumatic and early late grafts are the most concerning to me. And I think this change it did. We've addressed these with more detailed assessment of education for group one. We have quite a waiting list for this procedure, so we now have time to have Ashley, my physician assistant, is doing detailed medical assessments and home assessments to see what their support is, what their ambulatory status. If there's any question about their ability to withstand the graft harvest, we bring them in and we do some testing in the office, and soon we'll be sending to Noman for evaluation. And then the atraumatic graft failures, for me, were very concerning in the beginning, especially since maybe the biggest setup for failure is early success, right? We got a home run on our first case. Harold told me it was going to take 8 to 10 cases. It was not our best graft, but his pseudoparalysis corrected at 4.5 months. Went back to his labor job. He's a very happy patient. So we thought, hey, maybe we've got this. We don't really, it's in development. And so later on, as we started to see some of the failures related to falls, started thinking about sort of like what Pablo was doing, is we thought we would need to do some sort of internal protection for the graft. So we started weaving sutures through. I added additional fixation. And I think that helped. There was a couple patients who fell and did not tear their graft. So, it's not conclusive, but we think that helped us in that. And recently now we have suture patch, which I'm gaining great confidence in because I have seen that it seems to give time zero strength to the construct, holds the sutures better. I don't see any graft failure with that. So because of suture patch, some of my late failures, I waited till I had something I thought I could give them, which would be better than what we initially did. And so we've started to do some revision SCRs since this morning. I think I pointed out that we were not successful at repairing any of the graft tears. So let's see, let me make sure I'm caught up here. So 4 of the 16 patients really have been indicated for revision, and we've actually completed 1. It was my very first suture patch. So this is a 57-year-old male laborer. He's probably 95 kilograms. He's a big man. And initially, David and I thought the MRIs were intact at 3 months and 6 months, but he developed impingement symptoms. I did the normal. I didn't know exactly what we should do, but I treated him for impingement. I gave him an injection. We rehabbed him some more. Got temporarily better, but he continued to have pain. And so I took him back to surgery thinking that it was probably adhesions and that maybe I didn't do an adequate acromioplasty. But when I got in there and released the adhesions, what I found was a mid-substance tear through half of the graft, which I tried to repair. And as you can see on the right, it failed, right? It failed. So very unhappy patient, needs to get back to work, didn't know what to do. And then suture patch came along, and so decided we'd revise him. So I actually took the graft from the other side, took it before we scoped the shoulder, and then positioned him. And this is his 3-month MRI, which we think looks very good. Patient feels very good. He has no complaint about the harvest site. Here's a man who's had harvest sites on both right and left thigh. And what he told me the second time, he goes, this was a breeze compared to the first time. Right? I'm not sure what we did different, but he definitely feels better and he's progressing well. So we consider this a sign that revision SCR, at least in this group of patients, can be effective, although it is work intensive. Taro thought we could do it from the same side, but I didn't believe that I was going to, it's like, what do I do if I open that side and I don't have enough fascia, right? Where do I go? So it's like, it's just easier. We just do it in steps. And it actually only added about 25. So we've learned some important lessons. First and foremost, prevent the falls. Go slowly in rehab like Noman talked about. Be sure that I've assessed the subscap correctly, that it's repairable, because I think our one failure was an incorrect assessment, and I thought it was repairable and it was not, and it didn't heal. Those of us who were with us on Thursday know that this beware of poor bone is an issue, right? Depending on the age of the patient, the chronicity of the tear, have a solution for that. My solution was to use Brett's system, which works very well for us. But we also talked about whether we should have some augmentation for the bone available in the OR. We evaluate now more strictly for OA. Repairing torn grafts, at least in my experience, doesn't work. So we don't try anymore. Reinforcing the graft with suture patch. So far we've done 10. Looks really very promising. I really like the strength. I'm gaining confidence in it. And just that revision SCR is possible. So thank you.
Thank you, Paul. Now we'll
John's
listen.
going to talk about some of my failures now.
John Costoro is going to talk about the end of the line. So RSA to revise failed fascia lata SCR.
Good afternoon, everyone. It's a pleasure to be here. Thank you, Paul. Thank you, Teru, for this wonderful invitation. It's nice to see many old friends and to make some new acquaintances. So I've been tasked to change gears a little bit. We're going to talk about arthroplasty, which is, I guess, the black sheep of this room, but let's dive a little bit deeper. So why are we here today? We have been speaking all day about the management of massive irreparable rotator cuff tears. It can be a clinical challenge. What's interesting about these patients is, as we all know, they have a variable clinical presentation. Some patients have minimal to no pain. They're well compensated. They function well despite sometimes horrific radiographic findings. If surgery is to be undertaken, at least with arthroscopic debridement, for example, what we know is that pain relief is more predictable than functional improvement. And when is reconstruction, be it arthroplasty, a preferred next step versus the various arthroscopic techniques that are available? And we've all been here with the arthroscope, despite releases, unable to get reduction of the leading edge to the footprint. Now, what's interesting again with patients of variable clinical presentations, these two patients have nearly equivalent MRI findings. One is well compensated to your left. One has what I call true pseudoparalysis. So pseudoparalysis even after an injection with an anesthetic agent to reduce pain. On the left, we see advanced fatty infiltration, the superinfraspinatus, grade 4, with no real evidence of static instability or proximal migration. And on the other side, we see proximal migration in the setting of similar MRI findings. So I think these are key features to think about. And Dr. Stoll earlier touched upon acromiohumeral distance. The management of massive irreparable tears, we've covered many of them today. There's a broad spectrum of options, including debridement, biceps treatment, partial repair, a variety of tendon transfers, beginning with Christian Gerber's latissimus transfer, which I learned about firsthand 20 plus years ago during my time as a fellow with him, lower trapezius transfers and many other variants, a variety of patches and augmentation, options which have evolved over many years now. Dr. Mahata's pioneering work in arthroscopic superior capsular reconstruction, be it fascia lata or utilizing other graft choices, as we see here. Subacromial balloon placement, which has been FDA approved in the United States for the past 2 years. I've had relatively good early experience with this device. It's seamless, it's easy, but it's absorbable, and the question remains as far as durability over time. And then finally, reverse shoulder arthroplasty, which I'm going to speak to primarily here. So when is reverse arthroplasty ideal for a massive irreparable rotator cuff tear, and when would we go right to reverse before considering some of the other soft tissue options that we've been focused on today? I think certainly in patients such as this with advanced glenohumeral arthrosis, with static instability, I think these are good candidates for reverse arthroplasty. For me, at least, pseudoparalysis and some of the literature that I'll speak to in a little bit is a driver to consider reverse arthroplasty, although Paul just earlier spoke to a patient after 6 months where pseudoparalysis was reversible after a Mahata fasciolata SCR. Love to learn more about that. And there's some debate about what is the definition of pseudoparalysis, and maybe that is the key differentiator. What are we comparing apples and oranges or apples and apples? Patients with a irreparable or concomitant subscapularis tear, in my experience in the literature will speak to that, do better with reverse arthroplasty. Patients with low activity demands, so we're not going to consider reverse arthroplasty in patients who may be older but have higher activity demands, as we see here. Older patients with less concern for implant longevity or prosthetic failure, although I will say the average age of patients that I would consider reverse arthroplasty in my career has started to drop down, as it has in many people, because some of the earlier concerns that we had about glenosphere failure, implant failure, have not shown to be is valid. And the benefit of reverse arthroplasty is it provides durable pain relief and functional improvement. So here's a patient early in my career who I saw with who had multiple prior arthroscopic and open rotator cuff repairs, clear advanced rotator cuff tear arthropathy with proximal migration, and was fortunate enough to see this patient nearly 20 years following surgery. This was the DePuy Delta device, which at the time, all prostheses were cemented, and we had not all the options that we have today with prosthetics with reverse arthroplasty, but this has stood the test of time, and he continues to do. Reverse arthroplasty today has changed. We've had many advances with implant design, both on the humeral and glenoid side. We have preoperative planning software. Most of the vendors and implant companies have their own preoperative planning software. Some are implant agnostic. We have robotic assistance. I've been fortunate for 6 months ago to be one of the first in the United States to use the Mako robot for shoulder arthroplasty, and I'll touch on that in a few moments. And what's the ultimate goal? Preservation of glenoid bone. We want to avoid aggressive corrective reaming. We want to utilize augmented glenoid components when possible and to restore normal kinematics. And then the goal is ultimately to execute our plan precisely at the time of surgery. On the humeral side, we have short stem and stemless devices today. Here's a device that is available in the U.S. for stemless humeral reverse implantation. And many of arthroplasties today, for most of us, are performed in an outpatient setting. And this is a combination of better anesthetic techniques, multimodal anesthesia, and implant advancements and surgeon experience, ultimately leading to better clinical outcomes. So here's a patient who underwent a Mako-assisted reverse shoulder arthroplasty, significant glenoid retroversion of about 30 degrees on axial CT. We have static posterior humeral head subluxation, rotator cuff pathology, and so this was a good candidate for me to consider planning for a reverse arthroplasty. And then this is an intraoperative photo demonstrating the tracking device, which clamps onto the coracoid and communicates with an external camera. And after proper configuration, the robot can move forward, and it basically provides haptic assistance, so it will stop you if you're over-reaming or over-correcting, but it will not actually do the preparation of bone for you. And this is the, in this case, I was going to use a post for the base plate. That shows the completed product, and here is the the base plate, the augmented base plate itself after impaction, postoperative radiographs. So what does the literature show us? This is a nice study retrospective by Mark Frankel's group. They looked at a series of patients who underwent reverse arthroplasty for massive irreparable rotator cuff tears. These were patients without arthritis, and they wanted to assess what were risk factors for poor outcomes. These included younger patient age, less than 60, patients with neurological dysfunction, or with high preoperative functional scores. This is another study by Savivas and coworkers coming from Europe, meta-analysis of 6 studies, 266 patients, again looking at reverse arthroplasty for irreparable rotator cuff tears without arthritis, follow-up of 24 to 61 months, and they concluded that patients with massive irreparable rotator cuff tears without arthritis have a high likelihood of achieving a painless shoulder and functional improvement after reverse. What about Christian Gerber? This was a meta-analysis of reverse for massive irreparable cuff tears, 365 shoulders, mean follow-up of nearly 10 years, as high as 20 years. And he reported statistically significant improvement with reverse durable up to 20 years following surgery. What about comparing reverse to SCR? And so this is Peter Millett's work, a case control study comparing SCR with reverse in patients without arthritis, massive irreparable rotator cuff tears. 22 patients underwent SCR. This was with Arthroflex, a dermal allograft, no fascia lata here. 33 patients underwent reverse, mean age 57 years, slightly older of 63 for the reverse patients. Really didn't find any difference between groups at 2 years follow-up. I'm curious to see his longer-term results. And then most recently, Dr. Takayama and Ito are reporting in Journal of Shoulder Elbow a similar lack of a clinically relevant difference between reverse and SCR at their institution. What about the near circle? This is a group of 72 shoulder experts in the United States, and they conducted a Delphi approach to review all available treatments for massive irreparable rotator cuff tear. 60 patient clinical scenarios. What the Delphi group concluded was that reverse is a preferred treatment strategy in older patients, irreparable subscapularis, dynamic instability. So what about the failed fascia lata SCR? I will say, as someone who's a referral person for many failures of rotator cuff tears, I'm seeing much more failed dermal allografts and fascia lata. That's number one. It may be a product of a higher volume of SCRs are performed with allograft than fascia lata, but nonetheless, these have occurred. So this is a 56-year-old female who presented to me with left shoulder pain and weakness. She had limited motion with weakness, supraspinatus and infraspinatus, had undergone a prior arthroscopic rotator cuff repair in 2015 with subacromial decompression, distal clavicle resection, did relatively well for many years, but then required a revision, arthroscopic repair with a fascia lata SCR, not by Dr. Roach, in 2024. And unfortunately went on to have a recurrence with failure of the graft, as we see here, on the kind of mid-substance / glenoid side. Again, advanced fatty infiltration. So here are some intraoperative photos that I took demonstrating that the graft is well secured on the humeral side, ruptured on the kind of mid-substance towards the glenoid side. And so I proceeded with reverse implantation, as we see here, and she did well. So in conclusion, massive irreparable rotator cuff tears are associated with variable degrees of pain and dysfunction. A variety of arthroscopic and open methods are available to surgeons today that do not include prosthetic reconstruction. And I think, as with anything, patient selection is really critical, and also gauging your own technical experience as a surgeon. Some of these treatments are less predictable in the setting of glenohumeral arthrosis, pseudoparalysis, subscapularis insufficiency. However, reverse arthroplasty provides predictable pain relief and durable functional improvement in these patients, especially in those with arthritis and lower.
John, I have a question for you. Yeah. So, you've revised, I think, 4 of my fascia latas. Have you noticed any difficulty from the fascia lata when it fails at surgery for a revision to a reverse?
So that's a good point. So I found early on when I was playing with SCR, again, more of the Arthroflex variant, because it was, in my experience, Tony Romeo mentioned this earlier, it was hard for me to convince patients to get the auto. And so allograft was readily available. I found that revising an SCR allograft to reverse, there was some disparity with clinical improvement after reverse that I did not see as much with people who had undergone 1 or 2 or 3 just prior standard arthroscopic rotator cuff repairs. And so I'm seeing the same thing down the road. I think that there is something about choice of graft or graft preparation or reaction to graft in some patients that may impact an undiagnosed infection perhaps or something else in the mix that we're not picking up on that may impact that. But that's my experience.
But the autographs have not been especially troublesome?
No, they have not.
Do you have any protocol for excluding an infection prior to revising to a reverse?
I don't have, so I will, obviously my clinical evaluation will be a driver. If they have, I don't routinely get biopsies unless my clinical suspicion is raised for whatever reason, pain at rest, pain out of proportion, or certain features on x-rays that may drive me to that, elevated labs. But that is not something that I do routinely. I know that Russ Huffman had a paper that if we routinely obtain biopsies with any revision arthroscopy, a third of them will grow some positive C. acnes cultures. So what do you do with those is the dilemma. So what about you? Do you have a protocol for revision arthroscopy or considering?
When we have to revise, we usually send the samples of the sutures that we remove and of the capsule tissue.
Yeah, I mean, that's something that I think need to study a little bit further and develop better criteria of how to work up patients that undergo revision.
And we always send information to the lab to ask them to keep the culture going for at least 21 days to detect Cutibacterium infection.
So I have a question. If the patient 65, sometimes it's difficult to judge. You do reverse or you do SCR. Because sometimes patients said, I want one surgery, promising, no revision. What do you choose? That my patient, I explain to my patient and let them choose. Sometimes they are in the middle, like 65.
Right.
Yeah, but still active.
Well, I think in a shared decision-making model, many patients by the time they get to me have already had multiple failed surgeries, and the concept of undergoing a third SCR with the potential for failure is not ideal.
Revision not the problem. I mean primary.
Oh, for primary. I think for me, the parameters that I outline here, for me at least, if there's arthritis advanced, static instability, subscapularis involvement, my concern about compliance, things like that, I would probably go right to reverse personally.
No arthritic change. No arthritis.
If there's no arthritic change, then if the other things are non-existent and they're 65, I will tell patients you can be one and done with reverse, or if you want to try an anatomic restoration with more physiologic motion, but a risk of maybe needing a reverse later, we can go this route.
Okay. You let the patient choose.
I will sometimes, yes.
Okay.
It's just a comment. John, just a comment that Gus Mazaka had a paper that said exactly what you did, that after the SCR, the patients did okay, but not quite as good as the virginal ones.
Yeah, that's why I asked you that question. I wondered if you'd seen anything with the fascia lata.
Yeah, I think they're performing better. I think as the purpose of this meeting is to hopefully drive the benefits of that form of SCR.
Yeah, so currently no downside for the fascia lata autograft.
Right.
Question for John, you could help. For the reverses that did not do as well after SCR, did you notice any compromise of the greater tuberosity bone, from the anchor burden? There's been some evidence coming out on that.
No, I didn't really see that to be a primary issue with that. But I think that there is likely, someone on infection, someone on persistent pain, et cetera, et cetera. But no, I did not see that. But that's where your concept, I think, has a valuable place moving forward in the setting. You mentioned this after multiple anchors, not a lot of real estate. I think the bone tunnels are a stable option for revision for sure. And the cost benefit is tremendous as well.
So I have a question, but it's not for you, John. So I think you can sit.
Okay. Thank you, everyone.
Thank you. So before we finish, because we had many different and very interesting presentations, I want to have a question for Norman. I'm very passionate about rehabilitation. I think that it's actually central in anything that we do. What we surgeons do, it's just a small detail. And if we don't have a good rehab, then we might have might as well stay at home. But for me, in the majority of my patients, regardless if it's instability, if it's cuff tear, if it's SCR, if it's even a reverse, I focus, or I usually tend to ask my physios to focus a lot more on the scapula than on the glenohumeral joint. So my question for you is that in your presentation, I didn't see any mentioning to scapular retractor, scapulohumeral reeducation. And I feel that in these cases, if we do this relatively early after an SCR, we're not putting anything into danger, because you're actually, what you're doing is you're re-educating their scapula and you're taking advantage of this new, restored vertical stability of the joint, allowing the patient to recover a little bit early. And I would like to hear your thoughts on that.
Yeah, of course. No, you bring up a really excellent point. And although it wasn't in detail in the presentation, we do actually start now, even with just right when they see us, we start some scapular retractions. We are starting to get some shoulder shrugs in, et cetera. And then essentially when we start to go into strengthening, that is one of our primary focuses, is going to be on the scapula. And that's, like you said, you made up a really good point, is that's one of the few things that we can control. We find that, especially when we start to strengthen, I find, if a patient is not progressing as well as I want them to, we really hone in on scapular retraction, protraction, et cetera, especially with the push-ups, push-up plus. And we find that then all of a sudden their strength starts to really come back and really kick in. So really, just to your point, the scapulohumeral rhythm is very, very, very important in the rehab process.
I have a question to Dr. David Stoller. Okay. So you do an MRI at 3 months to all the SCR patients. Well, I had learned that it was complicated to interpret postoperative MRIs before 6 months. What do you think about that? And the other question maybe is for you. How do you get all your patients to do MRIs at 3 months? I have a lot of patients who are claustrophobic. And yes, and sometimes we have to use anesthesia for the. Yes, so okay.
I think in terms of looking at graft maturation and looking at signal in the graft, clearly, the goal of trying to get a hypo-intense graft is going to take longer than 3 months. With a good fat suppressed type sequence, you can still assess the morphology of the graft, independent of its signal intensity. So we're able to tell if the patient's not doing well, if the graft is retorn, if there's discontinuity of the graft, regardless of the fact it's 3 months. It makes no difference for us. If we were looking at a non-fat suppressed sequence, it might be more difficult to interpret, but I think with both sequences together, we can always differentiate the morphology. I don't think we have a good handle in general, or the literature doesn't either, on the various signals that we see within the cuff. I'd still use graft maturation or hypo. The goal is a hypo-intense FCR, but we don't always get a hypo-intense FCR, and the patients still do well. Mm-hmm. So I think the signal of the graft is a function of many different things, including the surgical technique, the degree of compression, and even the suture technique. And compressing that graft will all affect the signal intensity. So I discuss signal intensity, but I don't think Paul and I have a good handle on the signal intensity as we do on the morphology of the graft, which is 3 months is fine.
Yeah, and David, correct me if I'm wrong, we haven't seen any fall off from the 3-month transition when we checked the 6-month MRI, except on the patients who were torn. Yeah. So that usually at 3 months, it's been a good predictor that 6 months will be intact.
So don't sit down. It's just a curiosity, because we also control our patients with MRI. And what we see is that sometimes even in the 2-year follow-up MRI, you still see, like we saw in your images, a lot of fluid around the joint, and it's not a normal joint. You can actually see that this was. And how far would you say it is normal for us to see this amount of fluid inside and around this subdeltoid acromial space that we get to see sometimes?
It's a good question. I think the fluid that you see in the shoulder is also a function of the glenohumeral arthritis that may exist in some of the patients. So the arthritis itself and the degradation of the articular cartilage will invoke synovitis. There are some patients earlier on that, I've seen the SCRs associated with a greater degree of subacromial bursitis, And so I'm gonna look for is intermediate or gray tissue in the fluid as opposed to just looking at homogeneous fluid. I'm more concerned if I see a lot of granulation tissue because that indicates to me there's some sort of granulomatous reaction or some reaction to the graft. If I just see subacromial fluid, that may just be, immediately we're imaging too early or we're seeing again, fluid with synovitis is going to pick up areas of some gray tissue within the fluid, a function of the underlying integrity of the joint itself.
So in answer to your question about
Thank
MRIs
you.
for the patients, well, so sometimes we have to sedate them, right? And we have a protocol for that. David had, up until recently, David had the only 3 Tesla magnet with a 70 centimeter opening in the area. UC finally got one. So it's a little less claustrophobic. Do you have a big problem with claustrophobia with patients?
Now, but it's easier with the 70 centimeter.
Yeah. I mean, even our big patients. But where's Ashley? We do write medications periodically, but not that common, right? That common. Yeah. I mean, the other question I got the other day was how do you get it approved? That hasn't really been a big issue, but Ashley now handles all of the peer reviews for that. And so we're getting those approved pretty regularly.
And they have pulse sequences now that when patients move or can't hold still, they compensate for that and give you a decreased amount of motion on the MRI.
Yeah.
Those are called propeller sequences, like for instance, if you're using a GE magnet.
And it's noticeable when they don't go to you for the MRI. Once in a while, somebody goes somewhere else.
Can I have one last question?
Of course.
We have to just get coffee.
What's your personal opinion on using ultrasound to control graft healing?
I don't personally have experience with ultrasound. Obviously, with ultrasound, you have the ability to do dynamic assessment of your graft. In the comparisons of ultrasound versus MRI I've seen in the past and the ones that we've done with cadaver studies, ultrasound is still, I find, short with regards to picking up some of the partial tears. So if it's a complete disruption, you're going to see it on ultrasound. If it's a partial tear of the graft, or let's say your anchor, your glenoid fixation is off, your humeral, you might miss it. So, but in terms of a full thickness tear, ultrasound would do well. I would sort of view ultrasound as a supplement to an MRI, but not a replacement, in my own opinion.
Maybe you know, have you looked at your failures and the modifiable risk factors? Any change?
Yeah, so we really just started that review, partly driven by the fact that this course was coming. So we haven't quite got into those kind of factors about, health issues that might have led to the mostly you're talking about early graft failures, which were unexplained by falls. And then more concerning to me were the late graft failures. We only had 2 early failures. One was probably a bad choice by the surgeon to operate on. It turned out he was unstable at home, didn't have a good home environment. But the late failures there's no real explanation. We are going to look and see. So the short answer is no, haven't looked at that yet.
Did you look at infection?
So we've never had knock on wood, a graft infection. But we have, not in the shoulder, but we have had one harvest site infection. It was difficult to eradicate. He had no underlying issue. The only thing we think was the cause was once upon a time, just to make the view better, we used to do a wider clearance of the fascia beyond what you needed for the harvest. And so this patient particularly accumulated what we thought was a seroma, but it just never went away. And then ultimately when I tapped it, it grew something and we took him back and it took multiple debridements. That's how I know at 3 weeks that the fascia, when we close it, heals. Because the fascia was healed. It was in the area above the fascia. The wound vac actually was what saved that patient and got him. No, but nothing no graft, again, don't set me up, okay? No graft infections in the shoulder as of yet.
So my second question is about your rehab. It seems like very conservative, very prolonged. I cannot hold my patients to 6 months, so I seem to do well, all these things, they do well. So my question is, now that you're using this
suture patch, suture patch.
Will you speed that up at all? Do you think that will have any effect?
I'm going to refer that to Taro. Did you change your rehab with suture patch at all?
Yeah, no, actually same. Yeah, same protocol now so far. You're
faster than we are though. Is that correct?
Yeah, a little bit. Yeah.
he's better than I am. So I just account for the fact that I need to see that the graft has incorporated. Again, in this situation, we view graft incorporation and integrity at 3 months as predictive. That's what we're expecting. That's what Tero's publications and Akil's publications have taught us, is that the procedure should hold up. If it starts well, it should continue to be well. And for patients to not sit still for 90 days and not be aggressive, it's not that much. I mean, maybe in Vermont, they're much more active.
What about driving? When do you let them drive?
So when they come out of the sling, so legally they can drive as soon as they're off narcotics, right? We know response times are down once you're in a sling. That's been documented. It's common sense. But we let them drive as soon as they come out of the sling. Most people have automatic cars. It is the city environment, so it's going to be a risk. That's apparently true. Yes. I'm surrounded by them daily, the Waymos. Yeah.
I think now it's
Might
coffee
be
break.
coffee time.
Yeah.
So we'll fit. You guys we're doing great on time. We're going to pick up the next session at 3 o'clock. Good. Thank you very much. Nice having professional moderator here.
All right, so Ty, can I just tell jokes for the next 20 minutes, or should we? After Jeff's talk. Yeah, Jeff.
Are you
I'm
playing
sorry.
Is it going to be on, or are we just playing a video?
Dr. Abrams is going to be doing
on here.
Yes.
No, he's not live.
Oh, okay.
Is it Memorex? Okay, so we'll do our video.
I was going to razz him.
They didn't get that joke. Can you explain that, Max, to the audience? Okay.
Jeff, I hope you're listening.
I'd like to thank the organizers for the opportunity to speak at the first East-Square meeting. My topic today, arthroscopic rotator cuff augmentation using biceps and patches. I work for several companies as well as societies that may impact content of what we're talking about. When we are dealing with the need for augmenting rotator cuff, we look at the patient's characteristics, the tear anatomy, and the treatment considerations. Age of the patient, clearly an issue, whether or not they had prior treatment. When we look at MRIs, we look at muscular changes in terms of short-term and long-term deficits to the shoulder, and the opportunity to compare the biologic opportunity and look at some of the Far East experience with what shoulders may be problematic. We look at failed surgery, which we try to avoid by capsular releases to improve motion, look at the muscular potentials of the shoulder before we do surgery, and try to identify all of the painful lesions that may lead to success or failure in patients' expectations. The superior migration on an upright x-ray can be helpful in determining the duration of the symptoms. We look at biceps. We look at an autograft that can either be left intact and used as a superior capsular graft to connect the posterior and anterior vectors of the cuff tear, or detach the biceps and use it as an onlay augmentation. More recently, people have looked at morselizing the biceps to create a cellular graft. There are other opportunities to thicken the tissue, and in this case, we would consider the bovine xenografts that can be an onlay on top of an intact rotator cuff repair or a partially thinned rotator cuff tear. Who is at risk? Well, here is an example of a nurse 9 years prior having an injury, 8 to 9 years, with an overhead tennis move and injuring her biceps. She still had maintained her elevation. Her strength testing was deficit, and what became a greater problem was her cervical radiculopathy associated on the same side as her rotator cuff tears. She had some delays in treatment and had been on non-operative treatment. Her MRI, however, showing a large retracted tear, however, good muscular quality in terms of the supraspinatus, infraspinatus, with a dislocated biceps tendon. As we look at the shoulder operatively, we see the large superior tear, the biceps tendon damage, as well as the subscapularis and rotator integral displacement. The dorsal view showing significant damage to the superior aspect of the cuff. 16 adhesives just below the level of the groove to stabilize the damaged biceps before we detach the biceps. We've closed down the rotator cuff tear in multiple ways, including in this case some margin convergence as well as lateral anchors. And we're creating a complete closure of the rotator cuff, and in this case taking the biceps on lay over the top of the repair to augment and reinforce the rotator cuff repair to the greater tuberosity. You have post-operatively, you can see the patient regaining her active range of motion during the course. It is smooth, it is improved function, still has some residual cervical symptoms, but the shoulder has done well with this exam. We looked at the biceps grafting in 61 patients over the past years, with many of them having good or excellent results. The same scores often above 80. Most of them have returned to full gained employment, and some who had compromised of our anterior elevation did regain this. There were, however, some patients who required a repeat MRI. In this case, you can see that the bursal aspect of the tendon has done well. Some had additional Popeye deformities in 2, and 1 required a reverse shoulder due to the degenerative arthritis becoming a larger problem. I'll give you another example, however, of a 67-year-old builder. He was an athletic surfer and musician with an acute on chronic injury that limited his activities in terms of his work. He had weakness, and he also had, as you can see on some of the studies, a pacemaker placed. Patient had a CT orthogram due to his pacing issues, and in this case showing the superior migration of the humeral head when the patient was in the supine position for the study. We look at the bursal view of the shoulder. We see the size of this tear in this builder, the subscapularis now being repaired to the upper border of the lesser tuberosity, and we are going to establish the anterior vector by repairing the subscapularis before we move on top of the shoulder. In this case, we can close the top of the shoulder, primarily supraspinatus and infraspinatus tears with a similar to a double row configuration. There is some deficiency in this tissue, so we have used the biceps tendon sewn over the top to improve the stability and the anterior vector of his supraspinatus being reinforced. That being said, he has a second injury, now has to come back to the operating room approximately 2 years later, has his revision surgery now being performed, and in this case, no biceps was available, so a bovine tissue implant was then sewn on top of the repair as an on-leg graft, further reinforcing the rotator cuff repair with both structural and biological characteristics, as this will be a bioinductive implant that will allow tissue to grow within the implant itself. This will be the articular view of the native tissue against the articulation.
See me. I want you to bring both your arms up over your head, straight up and down. Bring your elbows down to your side and bring your arms apart. Turning around, put your hands up your back. If you had to rate your right shoulder, 100% is a normal shoulder, 0% is no shoulder, where would you call your right shoulder? You don't have to put it down.
I'd say it's 90%.
So when we look at what has cuff augmentation allowed us to do, it has allowed us to take rotator cuff tears and repair and improve our outcomes. This will improve both the imaging studies as well as the patient's clinical response. We're able to move more quickly. The natural healing is somewhat protected by the graft, and that the ability to have a spacing effect between the humeral head and the acromion is achieved by not only the native tissue being corrected, but the addition of augmentation or grafting. Who should we consider for this? Duration of symptoms, the chronicity. The more the muscular damage, the less likely the active return of motion. The less or more acute event, even in revision surgery, is preferable. Physical findings, I like to see whether a patient has good passive range of motion and the ability to hold their arm overhead when placed there, even with the assistance of the inspector or the other patient's other arm. In terms of imaging, the less the atrophy, the better, suggesting a healthy muscle. We can consider autograft as in the biceps. We consider allograft as in the SCR or xenograft as in the bovine tissue as currently acceptable modalities. We also have to be aware of the expenses and what is permitted in different regions of the world. In many cases, the expense of some of the additional materials is significant, as well as the additional time in the operating room. It'd be my suggestion that you consider all of these features and made biceps a popular alternative for me because it seemed to violate few of these principles. That being said, there are many successes with the use of the biceps, the exception being the biceps tended being used prior surgery or it had ruptured, in which case it's no longer available. I congratulate the organizers of this meeting and appreciate the opportunity to speak at this event.
He's not live, so that was his wife, by the way. So, all right, Kathleen, are you kidding me? Just real quickly, I know Max Park and Ty have done some great work on the anterior cable and the biceps, and just a little foreground. Steve Burkhart wrote about the biceps in like 1999, and Steven Snyder, when I was a young guy, said, "Yeah, I just sewed the infra to the biceps." I've been doing it for years and years and years with very good results. So the truth is, Paul, I've been doing less SCRs because using the biceps now and fixing the subscap. And then the other thing is when he fixes the subscap, preserve the comma tissue because that'll give you something to sew to. That's a very important principle I learned the hard way. So Ty and Max, how about your anterior cable stuff? Is this here to stay or what? Oh, okay. Yeah. I retract your question.
So I was going to say, to your point, the biceps was well described in the 50s and 60s in open surgery. If you look back at the old atlases to use exactly like you're talking about. So.
Yeah, and Ty has done some great work looking at the biceps as a stabilizer. So I'm off subject, but you know, these people are cutting the biceps and these young kids, tenodesis, nah. In the interest of time, any other comments, questions from our distinguished Portuguese contingency?
We're going to be talking about a lot of graphs. I was kind of looking hard for last week or so, and we all know that everything works in orthopedics for 2 years, and after that you start having problems. So all these new things, I was trying to think of any animal material that has been successful for orthopedic procedures, so specifically load-bearing structures. Does anybody know or heard of anything? Because I couldn't find anything, so I was just wondering. Yeah, but whatever the technology, like using animal component to build a matrix or anything for load bearing, because like that cell cleansing procedure, it maintains structural and mechanical integrity, which is great. But I don't know what's going to happen in 5 years because there's something we don't understand about that immunologic response, I think, because throughout the years, everyone thought, okay, now we got to completely clean, and then something happened.
It's maybe the oldest guy in the room. Who remembers the xenograft ACL? Like in the early 90s, it was a disaster. Toxic synovitis was what happened.
Actually, my opinion is way worse. You're talking about 2 years. What I see in the literature is they don't even reach 6 months. So in humans, xenografts.
I think we just have to be careful because I think God created all species in different ways, and there are differences, and there's a lot that we don't understand. And I hate to bag on sheep, but Steve Arnowski, he's the one who told me that, and then I personally observed it. I mean, they heal everything, even like cup models, unless you leave a big gap, and then it still fills in with scar tissue.
Ty, this is California. There's a lot of animal rights activists outside here, so be careful what you say, all right? I think it's time for everyone's favorite wise guy, John Macy. Get up here, John. Yeah. Who taught me how to use a curved espresso yesterday. Thank you.
Rotate a couple Velcro.
Right. So we don't like xenograft. We don't like allograft. And autograft hurts. How about synthetic?
I kind of like allografts.
Okay. So Paul, thank you for asking me to speak on this particular implant, which I've been using now for about a year. And I do a lot of SCRs and massive cuff tears. I have a referral practice similar to a lot of busy shoulder surgeons in this room. So at our New England Shoulder and Elbow Society meeting last year, this company approached me. I did my
fellowship with Kristen Gerber at the Balcris Clinic, where this implant was actually developed over the last several years. So we know why rotator cuffs fail. At least we think we do, and we're talking a lot about the mechanical reasons today, some of the biologic reasons. And so I'm not going to spend a lot of time in the first part of this talk here, but let's, we know where rotator cuffs fail, mostly at the suture tendon interface, and that's where we will concentrate our repair technology. We know that rotator cuff augmentation works. There have been multiple recent systematic reviews and a couple of really good current concept articles that have recently come out promoting this. And now our academy is even promoting this. Bioinductive implants, strong recommendation, dermal allografts, moderate recommendation. So we have enough experience now to feel confident that what we're doing to help our patients is actually going to be acceptable. Who do we do this on? Well, we've heard about the Rohe score. I think the Rohe score I use a lot, but the problem with the Rohe score is you need a bone mineral density to actually get this score complete. I don't know how many of you get a bone mineral density on your patient, probably nobody, right? So the modified Rohe score looks at BMI, work activity, tear size, and retraction. And I think to me, that's going to really be more predictable for me and more available. So when do we augment? Well, mainly these reasons here: poor tissue quality, muscle quality, thin tendon, irreducible tendon, short tendon stumps, and large and massive tears. So this system, speed patch fiber locker system, has mechanical reinforcement of the repair. It's a new technology that really improves the structural integrity of the repair at time zero. It includes a speed patch and this fiber locker gun, which currently fits on the end of a shaver, but will be coming out with a battery-operated handheld unit, which I can't wait to get my hands on. The patch itself is a non-woven polyester. Okay, so it's made of the same material that all of your sutures are made out of. It creates this woven felt-like material that is developed in a certain pattern. It allows integration of suture, of cells and tissue into it over time. So Isaac Merritt Singer developed the Singer sewing machine company back in 1851. And folks in Europe, Dominic Meyer's family was involved in the textile business. And he was an orthopedic surgeon, took his family history, put it into the lab, and came up with this genius sewing machine called the fiber locker device. And we'll see that. What that does is it fixes the whole patch through this felting mechanism and basically creates about 20,000 points of fixation in about 90 seconds. And so, you can see it here in the schematic, just pushing these fibers right down into the underlying tissue. And that's an actual intraoperative view of it. So, why use this? Well, it has really good biomechanical evidence of increasing that strength. There's good biologic evidence in sheep, but still in sheep. And it's very quick and easy to repair. So I'm just going to go over quickly some of this. The strength studies that have been performed really significantly increase the force required to cause failure for repairs when augmented with this particular implant. And if we look at this compared to just some conventional techniques, there's a non-augmented transosteal equivalent pitch patch, which is an implant that's used mostly in Europe, not in the United States, and then the fiber locker device implanted on top of standard repair. And the ultimate tensile strength and gap formation have significantly reduced and much better than the conventional pitch patch, which is used in Europe. About 2.5 times the increased fixation strength. So what about tissue biology? Well, it does integrate very well. There's your sheep tie. And you can see this patch at 3 months, this is 4.5 months, the patch growing over the new tendon, growing into the bone at the epiphysis. There really has been no adverse tissue reaction, which is really nice. You think about some of the immunologic reactions that can happen, but there have been really no side effects from a biologic standpoint. And you can look at some of the histology here and see that this implant really incorporates well in the tendon and into the epiphysis. And
John, did you have a control group?
Did I do this study? No.
No.
Yeah.
I'm just saying, did you have a control group?
I don't believe so for the comparison. Thank you.
Okay.
Why? Is that a problem?
No.
Okay, good.
Well, actually, it is a problem when you try to publish it, because I'll probably not the control group.
All right, we'll just look at pictures then. So the histology looks really pretty. Okay, you can see the cells integrating right into the patch and the patch being there. So when do I use it? We talked about some of these indications, but large, massive tears, poor tissue quality, revision surgery, and now bursal-sided tears. So here's one case of a massive rotator cuff tear in a 52-year-old construction worker, about 2 years of pain, not workers' comp, but still weak. Limited active motion, good passive motion. MRI, you can see large retracted rotator cuff tear, pretty decent muscle quality. Infraspinatus is a little small, but a very large tear. Large retracted supraspinatus, infraspinatus. And I think this is a very interesting shot on the left side here. You can see that articular and bursal different layers. And now that articular layer really is probably more capsule, right, than tendon. So we need to restore that back as best as we can. So I put some traction sutures on it, do all of my releases, as John says, to be able to really get this thing back over under the least amount of tension as possible. 3 anchors medially, 2 anchors laterally, pass the sutures through the implant externally, and then use a push-pull technique to put it down right over the top of the repair. There's the articular fibers restored back to the lateral margin and the bursal view. Here's another case, thin, poor quality rotator cuff tissue in a 72-year-old female, passive motion, really piss poor, active motion, very thin tendon. You can see here, pretty decent muscle, but repairing that with a standard technique has a very high failure rate. So subscap tear, and here's the comma sign that we were just talking about, and that's very important to understand. Do not release that. Use that to pull your subscap and your supraspinatus back over. It holds sutures very well. Biceps, got to deal with that pathology as well. So same technique, patch over the top of the repair, and then fiber locked in. And this fiber locker is really an amazing little needle that comes out at about 20,000 fixation points in about 90 seconds. In theory, I use it for about 90 seconds. And then put my sutures over the top and then use it again. So I'd probably use it 2 or 3 times to really get that patch to stick down well. And you can see how it just incorporates almost immediately, and on the transition at the edges of the patch into the tendon, medially, laterally, and posteriorly, it's really just a continuous thing. There aren't these big dog ear folded up edges. And so it looks really nice and probably feels really nice. Third case here of a massive cuff tear in a 58-year-old. Same thing, retracted, infraspinatus, supraspinatus tear, reducible, lots of suture, 3 anchors medially, 3 anchors laterally. And then I believe we can see the patch going in here. Maybe not. There you go. So Paul was talking about, I do a push-pull, anterior, posterior, and then slide it right in. And this was one of my first cases. I actually now have 2 box stitches on the lateral side of the graft to be able to control it as it's going in, and fiber locking it down before I put my sutures over the top of it, and then fiber locking it afterwards. And so here's the speed patch over the repaired tendon. Go inside, you can see that articular surface is restored on the bursal side as well. And this gets my rehab. This guy's 3 months out and he's actively moving, doing all kinds of things that I don't allow them to do this, but they do this. And so compliance after 3 months, before 3 months, I think it's very difficult. What I find incredible, and this is, a second look from another surgeon, Dr. Brian Hill. What happened? Did it work? So this was a gentleman that had a patch put over a rotator cuff repair about 2 months prior, ruptured his biceps, and the surgeon tried to dissuade him from fixing it, but patient apparently wanted it fixed, so he got the opportunity to put a scope back inside, and you can see the patch really incorporating pretty well over that repair at 2 months. Look at the blood vessels, look at the fluid, it is really incredible. Yeah, no. So the graft failure, anyway, this graft is made of standard suture material, polyester material. It holds sutures very well. It's easy to apply, it's quick. And this micro-stitching novel technology is really fun to play with. And what it does, I think it really improves the structural integrity of these repairs, which hopefully will lead to decreased re-tear rates, and anecdotally, incredible decreased pain. These patients are showing up first post-op visit, no narcotics, and some of them no sling, which is a problem, I think. But it may not be, because we have a fellow surgeon who is in Texas who has used this over 300 times now, and he does not put patients in slings. No sling. He also does ultrasound at 3 months, 6 months, and 9 months, and has had incredible success, ultrasound documented. So this is in the process of being written up. So you'll see. No control group, but yeah.
No, Animal studies. That's why I was criticizing.
Anyway.
I think it's really amazing technology because I remember when I was younger, a lot of my engineering friends, they were talking about developing something like this, but they just couldn't figure it out. And it's pretty cool. And I also like the fact that the scaffold not being resorbable. So I think that's a permanent thing. If it works like suture, it just goes right over it, then I think you got a great thing.
Yeah, so some people are just putting it over the top and not putting any sutures over the patch. Others, like myself, are incorporating my medial sutures and compressing the implant down over the repair.
Katarina, actually, before the evening, you got to give us her full name. She has five names.
But it's both her
Ana
and
Katarina Ligogra.
So both of you are.
So just a small question for both of you. Doesn't the fact that you create a very, very stiff enthesis worry you about getting type 2 tears in this kind of cuffs?
So, I think if this is going to fail, it's probably going to be a type 2 failure. I have not seen a type 2 failure with this implant yet. I've seen it with a very strangulated double row technique, but that is a valid concern. And this graft can actually go up almost over the myotendinous junction. And so you can microfelt it into that area. You can place the implant either horizontally or vertically and get more medial with the implant, even though it's designed to be more horizontal, anterior posterior rather than medial lateral, but strengthen that portion of the tendon. But I hear your concern.
Yeah.
Clara had a quick one, and then we'll go to
Yeah,
Pierce.
I only have 4 names, so I come after.
Well, you're not royalty. You didn't make the cut. You didn't make the cut.
So probably you don't have an answer to this question, but you said you have 20,000 fixation points.
Yes.
So this is really interdigitated into the tendon, and
Yes.
it's inert material, which is very well, I like the term. So it could harbor infectious agents very easily. So are you not concerned that you have all these 20,000 fixation points on the tendon, and if you have an infection, how will we manage this? I really like this idea. I have to say, it's just this concern.
It's a good concern. It's an inert material. It's sterile. We put it in like any surgery. I think I have not had an infection, knock on wood.
It's hardwood.
It's really amazing how it holds even without suture on it. It's like Velcro. You can peel it off, but you can't pull it off. And so it is well fixed with 20,000 points of
You
fixation.
can peel it off.
You could peel it off, but
Okay.
I'm not sure at 2 months. I have
Yeah.
not been back in to see one at 2 months. I think they would be all incorporated. And
Yeah.
if you see some of the sheep models, the tendon is actually growing over this
Don't
scaffold.
believe anything from sheep.
So always going
Yeah,
back
so-
to the animals. Okay, thank you.
Yeah, Pierce, and then we'll go to the next talk.
Wait, I got one last. Oh, yeah.
So I love the Velcro concept.
Actually, it's not Velcro. They're actually stitches.
It's cotton candy.
They're not barbs.
Yeah.
Okay.
Yeah, concept, guys, concept. So some gray area there, but it does, kind of following up on Claire's question, it does interdigitate 20,000 times with the tendon fiber. So is there any concern about altering the ultrastructure, the structure of the tendon itself, and maybe tendon necrosis, or I don't know. Has that been looked at clearly, in a sheep model, sheep heal everything, I guess. But I don't know if anything like that's been observed.
Less than a year follow-up. So no, I have not seen that. I have not re-MRI'd any of my patients. Ultrasound, and surgeon in Texas ultrasound every single one of his 300 times.
You know what scares me about this? I think it's amazing technology. It looks too good. And something's going to just, from a blind spot, it's going to come out and bite. I don't know if you guys remember thermochondroplasty. The pictures look beautiful. Patients were fine, and then they all just fell apart. But this remodeling question is something, only clinical follow-up will be answered, but it's pretty amazing technology, I think.
We'll just do a reverse.
No, thank you. All right.
Wait.
So I I don't know if this, so John, I mean, did you do biomechanical testing to see what all those penetrations into the tendon might do to structural integrity and strength and possible failure points?
Yes.
Yeah.
So there were some slides that were not presented, but there we have looked at the integrity of the sutures overlying it. And what the micro stitching does is actually incorporates the sutures, whether it's the sutures are under or over, the sutures actually get incorporated into it. And it does not disturb the tensile strength at all of the suture.
Does it make a difference if tissue quality is different level of tissue quality?
Yeah, so that one case that I presented, very thin, piss poor quality tissue. This is, I think, one of the, the indications for this.
So do you expect better structural integrity with poor quality tissue versus better quality tissue? I'm just trying to look at the relationship.
I know where you're going. I know where you're going. I mean, hopefully it will decrease the reach.
I'll get you into trouble one way or another.
All right.
Pick this up after.
Yeah, and I had one exit question for John. You're from Vermont, so what is a guy from Vermont first thing he teaches his child?
How to chop wood.
Don't eat the yellow snow.
Don't eat yellow snow.
All right, so next with that.
Why? Why not?
All right, we better stop. Okay, here's the man. Let's have Tiro. Great job, John. You're the man. You're the man. Here he is. I want to call him Smiley. He's always smiling. Even with that terrible lab experience, we'll be okay. Frozen cadaver.
Frozen cadaver again.
He's a lot smarter than me. My gosh.
Okay, my talk is ACR for reinforcement. Most of the augmentation technique, the patch attached over the tendon, but my technique is under the tendon because I want to make the biomechanical effect also. If you put a graft on top of the graft, only the biological, but under the tendon, maybe biological and biomechanical. So I studied this surgery in 2013, so more than 10 years already. First, I want to show the surgical technique, the prevention of the infection. We cover the skin using iodine drape. Also, we wipe before surgery in the chlorhexidine gluconate. And graft size here is very important. So anterior-posterior direction, same as defect side, and medial lateral direction. It's a 2 centimeter longer than the length from supraglenoid to the lateral edge of the great tuberosity. So if there is a 4 centimeter, graft size 6 centimeter. And herpes fasciata skin lesion it's small actually, because only the one layer. The regular issue around 12 centimeter, but issue for reinforcement around 6 centimeter. This is the size of graft. So the left side, the regular issue is a very thick, but issue for reinforcement just one layer, so very thin, but it works very well, only 2 or 3 millimeter, but very good the result. And the anchor on the ground side is only the one anchor for SCR for reinforcement from nearby the polo. It's a double loaded. So that's why very easy surgery. And I want to show the movie file. We release between the labrum and super shoulder capsule, expose the supraglenoid. This is a posterior view. Then this is a supraglenoid. Then from the Nevada portal, we put a suture anchor. It's a 4.5 millimeter screw type, the suture anchor, double loaded, and the tapping because the glenoid is very hard bone. And we put the suture anchor. Then afterwards, we need to take out all of the suture through the rotator cuff tendon tear using the retriever like this, because I attached all of the suture outside the body. Then the great tuberosity medial anchor, like a 2 centimeter tear like this, only the one 3 block with 2 tapes, 2 tape and 1 fiber wire. Then afterwards, the old suture take out the outside the body, then attach the graft, then insert the graft to the joint and not time the granule first, then lateral side, the same cuff repair. So using the same suture, we repair the tendon, like a delaminated root cuff tendon repair, then suture bridge. So now insert the graft under the tendon, fix the granule first, then over the graft, we repair the tendon, like a suture bridge technique. So already we published this result in 2019, I want to show this result briefly. Sugar classification 1 year after surgery. We compare the cuff repair plus SRR and the cuff repair alone. So the blue bar is cuff repair alone. It's a control group. And the return rate 4.4%. Because just a medium-sized tear. So the return rate is not so high, even cuff repair alone. But SGR plus cuff repair, 0% retear. And good thing, most of the cases, type 1. Type 1, it means a very good quality of the tendon after surgery. And actually, the 357 cases until 2024, actually, until 2023, I have never seen the graft tear, but 2024, one case graft tear, unfortunately, because the young physiotherapists did their very aggressive physiotherapy. So that's why we found one graft tear and the cuff tear, but otherwise, they are all healed. All cases we take MRI, but actually they are almost 0%, 0.3% actually. So now I can say sure can prevent retear after local repair. So that's why now I really recommend this surgery because they are very reliable. And I want to show some cases. This patient, muscle quality is okay, but the tendon very thin. Then after surgery, there looks like very nice the tendon tissue, but that was fasciata and mostly fasciata and the cuff, very degenerated rotator cuff tendon. But the MRI looks like very nice tissue. It's a type 1 classification. And the case to need a 40 years male. It's a tendon is weird, actually very elastic looks like because of many steroid injection. Then after surgery, very nice tendon tissue again. And in those cases, 23 years old professional baseball pitcher. Since he became a professional level 2 years ago, he has never thrown the game due to severe shoulder pain, and all of the non-operative treatment did not work. And he came to my clinic to have a surgery. And the MRI looks very thin supra because he did many times steroid injection before when he was a university student. He said more than 50 times. So that's why the tendon quality is very poor. So steroid. And this is a scope view finding the severe defect in the supra. That case, we put the suture anchor. It's an all suture anchor in the supraglenoid. Then the medial footprint of the great tuberosity, we put this all suture anchor again because they're 23 years old. Then this is a graft inside the joint. Then we fix the granule first. Then over the graft, repair the tendon at the maximum external rotation position to prevent the external rotation deficit after surgery. This is the MRI. Before surgery, very degenerated, very thin. And 6 months, still you can see the border between the graft and the tendon. But 1 year after surgery, you cannot figure out where is the graft, lateral side. Medial side, still we can see the graft, but the lateral side, we cannot find which is a tendon, which is a graft. And 2 years already, there are almost normal tendon tissue. And the SR graft was integrated with the supraspinal tendon. And 1 year after surgery, he returned to the game, and it is 1.5 years, 152 kilometers per hour. So he returned to the pitch. Actually, he started his career in the professional level. Thank you very much.
I was wondering, I was just confused when you do your small graft. Do you sew the supraspinatus to the graft, or you just lay it on?
Yeah, actually, the graft attached to the bone, and the supraspinal tendon attached to the graft, not bone.
So you sew it to the graft.
Yes.
You don't just.
Yeah. So actually the same using the same suture is from the suture anchor. We fixed together.
And I know I'm in the audience. He puts an anchor in the glenoid very immediately. I was saying Hail Marys because the nerves nearby.
glenoid.
The glenoid, yes.
Oh, okay.
You go very immediately, but you don't get too concerned about the suprascapular nerve.
Oh yeah, good question. Actually, everyone asked me, but I exposed around the 2 centimeter, so I've never seen the nerve, and no problem at all so far.
Yeah, and the last question is, there's actually a lot of literature for some of the biologics. If you have a partial undersurface cuff tear, which Dr. Stoller may say is a capsular tear, just putting a graft like some of the biologic collagens on top actually causes reconstitution.
Right,
you know, the Regen 10 folks and everyone. So would you consider just putting a graft on top in that baseball player?
I don't think it works. Actually, I don't know. I don't believe this concept actually. That's why I put a graft under the tendon. Yeah.
You make it look easy. That's a lot harder to do. Any questions?
So it's just a comment. That's what I was trying to explain on my lecture this morning. There are two different tissues, have two different roles. And by having that underneath, it's going to protect the repair. It's going to keep it in. So I think that's a very important thing. But this question, I do have one question that may be really relevant for American surgeons is how much time does this add?
How much time, Matt?
How much longer does
30 minutes.
30 minutes?
30 minutes, a very small harvest, easy to close. You literally just have to slide it onto the glenoid with one anchor, and then the rest of it's a rotator cuff repair. The sutures are already through the graft.
Yeah.
Well, you also have developed enthusiasm.
Well, you have to want to do it.
I know.
But if you see the MRIs, you're not going to want to do anything else.
I mean,
and the other thing is, I
beautiful.
think it creates, and maybe Taro can comment on this,
Yeah.
I think it creates what the native superior capsule actually is, which is a periarticular sleeve that extends the footprint insertion for the cuff. And so I think what we see on the early MRIs, we've done 15, is you see really early graft. You see that the tendon is really healing early to the graft beyond the footprint, medial to the footprint. So it must unload the repair of the cuff as well as stimulate biology. So.
Yeah, so not only me, many Japanese doctors actually can feel same thing. Yeah, can get a good outcome.
Yeah, I'm just trying to think in my own mind who I would do the partial for because, one comment I'll make is I think margin convergence is a lost art. Industry wants to use double row for everything. But Steve Burkhardt actually wrote a paper in 1998 or so saying that results of with without anchors, no difference. And then what happened? He invented the swivel lock.
Okay.
So I think you have to always think about biology and tear reduction.
Okay, thank you very much.
Okay, next we have Brett Sanders who's going to talk about Back to the Future, transosseous options.
Thanks so much, Brett Sanders from Chattanooga. Paul, thanks so much for a great meeting and what you're doing. It's amazing. The esteemed colleagues here are all amazing. And I really appreciate it. And I appreciate you trying transosseous as well. I do have a relevant disclosure. I've been going pretty hard on transosseous applications for reusable value-based medicine for the past 20 years. I started a company on it. And there's a lot of analogies here, actually, Dr. Mahata, to the SCR, the autograft. There's some industry pushback. These techniques aren't dead. They're just less profitable. So some of our European colleagues are a little more open-minded to the benefits of transosseous. It has obvious cost benefits, better biology, equivalent or superior biomechanics, better pain. There's level 1 evidence on that. Better revision considerations without type 2 failures. Outcomes are equivalent or superior time. And you have these synergies with fixators, which I'll show you. So it's not one or the other. We can use both. This concept has been around in the zeitgeist for 114 years. We started with open transosseous, then mini open thinkers. The scope came along. We didn't have any way to do transosseous, so we went single row, double row, transosseous equivalent. Dr. Parks here. And then now subconsciously, the all suture anchors should be in here. And I think that's a subconscious realization that hard anchors aren't great. And if we tie a knot in a suture and you think that can fix in the tuberosity, topologically, that's the same thing. Why don't you put your suture in first and then tie your knot afterwards, and then you get twice the biomechanical efficiency. That's a true transosseous repair. And now we can also do hybrid techniques. And I'll show you what we're coming back around to the ability to do advanced techniques. Again, this is the oldest, or this is the longest follow-up in the literature, to my knowledge. Christian Gerber, Gilles Walsh, Philippe Collin. If you read the paper, they have excellent results. If you read the paper, they're talking about transosseous sutures. This construct here on the right Gus Mazaka studied that. The ultimate failure was 1,100 newtons. You could rip the surgical neck off the humerus that way if you put enough sutures in. Median failure was 800 newtons. So it's pretty solid. Now, you can get cuffs to heal with and without anchors, but there's some problems with anchors that we're going to point out. The first single row repairs arthroscopically didn't turn out too well. They all failed, essentially. And so we have cysts, we have imaging artifacts, and they tend to heal at a high rate with this Gaia 3 type healing, essentially because of the modulus mismatch, I think. If you look down here, we get this, they tend to heal better. I don't know exactly why, but there's something about it, whether it's the biology or vascularity, I don't know, but it's more of a Gaia 1, very homogeneous T1 signal. We know that there's 4 times better blood flow from ureta, and we know that there's level 1 evidence on less pain, probably from not inducing plastic deformation and increased intraosseous hypertension from cramming an anchor into the tuberosity that never goes away, and reduces vascularity as well. A couple times a year, we'll get this normal cuff read post-op where the radiologist can't even tell it's been operated on. So in my mind, you'll never get that with an anchor, and it doesn't get better than that. Now, this type 2 failure is anchor induced. That was caused by anchors because of modulus mismatch. It's too stiff. So it's like laying on 2 nails instead of a bed of nails. Speed bridge would be 2 nails. So it transects the tendon. And of course, you get the cysts, breakage, the tunnels, the bone voids that are unreconstructible. And there's evidence on having problematic osteolysis of the greater tuberosity for your reverse. So there are some complications to be avoided. Dr. Juhan Oh is a brilliant clinician scientist out of Korea. I gave him a set back in 2016 and forgot about it. Honestly, he sent me like 1 email and never heard from him. And then he came out with this paper in 2023, which was amazing. So he actually looked at intraop failure. So cut through, cheese wiring through, which was 8% with transosseous, and anchors actually pulled out more, 15%, especially soft anchors. In his hands, master surgeon, 5% re-tear with transosseous, almost 20% re-tear with anchors, 0 cyst formation with transosseous versus 16% with anchors. No difference in outcome, no difference in time. And so this is straight from his paper. You see, again, the Gaia 1 type healing versus the cysts and the inert material that never really goes away. So let's talk about specific advantages for SCRs. So all the anchor pullouts or cut throughs laterally, as you see on the right, you just don't get those. And so the downside of a suture failing or cutting through is much less. In fact, we found that tunnels are not the problem in soft bone, they're the solution. So these advanced techniques allow you to tunnel through voids, cross voids, and it gets your hardware fixation out of the zone of pathology, just like you would do in trauma surgery. There's no type 2 failure, it's load sharing, it's reloadable. If you unload it in surgery, it's revisable. And then you have these biomechanical efficiency with coupled fixation points. So you can actually slide things in a lot easier. You don't have to measure and precisely measure when you're spot welding with anchors. You can slide them in, it's like an ACL through a bone tunnel. You put the knee and you fix it. You pull it and fix it with 1 move. So there's some interesting techniques that come out of it. It's also very bone preserving and has improved imaging. So it allows these kind of advanced techniques that you can get a complex construct with just tying 2 sutures together, essentially. So this is where you start when you're first learning these techniques. Crow's foot, or they call it a parachute technique in some places in Europe. That's just a simple tunnel with 3 sutures. You can do 2 tunnels, and you can do 2 tunnels with 3 sutures, right next to each other. On the left, you see I'm introducing, we've made a 3mm poke hole, and we're going to pop in, rotate, and we don't drill or remove any bone. We compact bone to increase the bone tunnel, and we eliminate steps by just being able to push in this. So we get all the way down to get a big bone bridge there, and then we introduce the 1.9mm all pusher. So that's just a poke hole. It's a simultaneous passive retrieval of that suture, so you don't have to do anything with your thumb or to try to get it right. So that's what it takes to make a tunnel. It's about 13 to 15 seconds, and then you can move along and put in as many as you want within a case. So this technique is the workhorse, the true transosseous hybrid. So this is what I developed in response to the market demand for or the concerns over bone quality and tying knots. So this is a true transosseous X box with 1 anchor down low. There's no inert material in the healing zone. It's an in-series load sharing construct. So if your anchor fails, your knots are still, it's a belt and suspenders. It's going to actually help you. The whole construct doesn't go down. And it allows you to retension the construct. And this has the advantages of increasing your value dramatically. So you get these constructs that are very high fixation point density. It looks like there's 4 or 5 anchors in there, but there's only one. And then we move to the next iteration, which is this double box hybrid. So 8 fixation points. So you could pretty much do anything, any size with this one. And here's one we did with suture. So high fixation point density, load sharing, multiple sutures crossing the repair site, which is correlated with strength. But again, nothing in that healing zone. Here we're doing it with tapes, and you can make these cargo nets. Now you can do anything you can do with anchors. This is a lower trapezius transfer. You can do without anchors. And we could have stopped there, but we wanted to kind of piss off our Arthrex friends a little bit more. So we took all the anchors out now. So this is the triple row transosseous without the hybrid. So now you can put in, unlimited fixation points. We worked out the biceps technique. This is 4 transosseous, or this is 4 fixation points in series. We call this the Tokus technique, which is quite promising, and you can do that in situ. And then as we're moving along to autographed concepts of biceps, SCR, anterior cable reconstruction, it's quite easy. You would do that just like you do an anchor. And then the traditional SCR, which has massive cost advantages where we can almost decrease the cost here by an order of magnitude. You can take an $8,000 procedure and take it down to, about $1,000 or close to it. It's bone preserving on the humeral side, has better vascularity. I've got 10 years follow-up on him. He was doing great. So again, we're just illustrating what you can do. We're translocating the biceps in this 10 fixation point repair to the mid-sagittal plane, and we're simultaneously tenadesing the biceps suprapectorally. So that's 10 fixation points, 2 anchors in that one. Greg Colbath and I worked on this in the lab. He showed me this transposition technique. So suture with transosseous, you can put your sutures in first, or you can put them in. You can put them in the tendon first, or you can put them in the bone first. And then once you put them in the bone, you can center the biceps with one move there, and bring it over, and then repair the rest of the construct. Again, you're preserving your bone. You can do patch onlays with stick knots. These slide in very easily, and you can do post-repair fixation points. So you can put the awl right through the middle of it and then just do a racking hitch. It's very simple. So I don't accept dog ears, on anything, even though it's painful sometimes to open up another anchor. This is a novel concept where you can actually put grafts pop them into the active merosource and go through the bone and through the tendon. So it's going through and through. So I'm not aware of anything that can do this, but these are techniques that you can see out of China. There's one, and here's one where we did it with a subscap, putting an allograft tape through the bone, through the subscap. And I call this a double cable reconstruction. So the transosseous tunnels allow you to slide in the anterior and posterior cables. It's similar to an SCR, but you can see through it. And this is intra-op with the cables in position. So there's no hardware in there, but we've reconstituted the cables, and then we repair the cuff over it. And that worked pretty well for him. So if you like BioBraces or onlay, this is a U-shaped graft technique where you can pull them down by pulling on the inferior limb. And again, you don't have any hardware in there. And you can augment your tendon, and you can repair a simple suture first and then decide what you want to do, so you don't have to commit when you're putting anchors in those constructs. And here's a rare example of a failure where we did this BioBrace construct, and the patient fell post-op, and the brace did support the tendon, but it tore a little bit behind the BioBrace, and we were able to extirpate all that material. And because it's bone tunnels, you just take the sutures out. I was able to tunnel directly into the same tunnels and then reintroduce a single layer SCR anterior cable, and then repair the cuff back over it, because there's usually type 1 failure, so you have tendon substance to actually repair in the revision scenario. That's him at 3 months. So thank you. Hopefully that'll give you something to think about.
I'm going to phone a friend. Tony, you and I are old enough. Remember, this was big years ago. It kind of fell out of favor. And correct me if I'm wrong, but Steve Burkhart, and he's a very good friend. He had an article. He was promoting anchors, and he showed in his lab that cyclic loading, you had more of the cheese cutter on bone, and that the anchors did better. Remember that study, Tony? That was the basis for anchors. What's that? It's probably something like that too. So I wonder why this is making a comeback. And you make it look easy, but I think the biggest rap 15, 20 years ago was the difficulty that they had this oscillating thing, Brett, that would like ratchet things. But interesting. I think our hospitals are going to really love this very much because, the price of anchors these days. So
I think this is really great. I have it on every one of my rotator cuff lectures that this transosseous technique, it took 20 years for arthroscopy to catch up with all the anchors. And then basically you're creating a similar mechanical environment for healing and having the tendon work. I think, again, it's great. I think probably one set of data that may really help your argument is the bone density variation around the tuberosity. There's papers published on it. Though my name was on one of them, I really didn't do anything, just talk to them. But I did read the paper before they submitted it. But I think that addressed that question because I've seen it with, obviously, I don't go into operating rooms, but even in the lab, like sometimes you put an anchor in, you think it's at the right place, and you pull it, and it just pulls right out. So I think that'll be a very strong argument because you're distributing the stress from anchor fixation point to all throughout the tunnel. So
yeah, that was the purpose of the hybrid technique. So you can put sutures through the soft bone, and then if you want to use an anchor, you go way down to the cortex where it's actually hard again. So out of the zone of disuse osteopenia. But this concept of, reading Burkhardt's literature, where back when they were repairing, 88-year-old females with irreparable cuff tears that get reverses now, and it was just butter bone and everything cut through, they were really happy. They viewed it as a success to transfer the failure mode to the rotator cuff. In my mind, we need to think that through. The bone is the only regenerative tissue in the body that actually regenerates with more bone. Cuff is the only thing that can almost never heal, right? So you're taking your failure mode and you're transferring it to the worst thing. Instead of having your failure mode like a crumple zone in a car, you want it to cut through. That's what transosseous does. If you fall post-op, it'll cut through the lateral bone. 6 weeks later, it's healed like a fracture. You can tunnel right through it, and you have a type 1 tendon that you can then repair. Whereas same thing with a speed bridge, it's going to transect the tendons, and you're looking at an SCR. It's catastrophic.
have you seen any fractures or heard of any, Brett, with this?
No, it's just little poke holes, and they heal pretty rapidly. The ones I've been in on 6 to 12 weeks, the bone basically heals back to a suture.
Wow.
Yeah, my radiologist sometimes reads the early MRI, if I get one, as a fracture through the tuberosity, but what they're seeing is the tunnel and some edema from the tunnel. And then the follow-up MRI, they'll quote that the fracture has healed.
Is that 3 months? Yeah. And you'll see there's papers that show bone edema around anchors out to 6 months or more. And we think that, may correlate with pain because maybe you're venting the pressure. I mean, we're not sure about this. There's a lot of stuff that it's not well studied, but it clinically it works.
That's very good. Thank you very much. Next, we have Pierce the third, and Pierce, I'm the fourth. And I had a fifth last night.
It's also an Irish thing, I think.
That's an Irish thing.
Yep. Well, thanks. We're almost there. Just a couple more talks, right? Well, thank you, Paul. Thank you, Tira. I feel honored to be here.
How cold is it in Minnesota, Pierce?
We had 7 inches of snow on the way out.
So how cold is it? It's so cold. When he left, he saw a dog frozen to a hydrant.
And they were still frozen, correct? Well, we live up to our reputation. What can I say? But no, thank you very much. It's my honor to be here, and I really also appreciate all the work that Paul put in. Organizing a conference like this is not easy, so I just want to recognize you, Paul, for doing that work. So I've been quietly doing Mahata SCR in Minneapolis since 2019, and kind of my journey to that was simply observing less than spectacular results with dermal allograft. But I read all of Dr. Mahata's papers, and the biomechanics were very convincing. So I thought, I taught myself how to do it and started doing it and kind of ramped up. And I've done about close to 100 now over that period. What I'm going to talk about today, though, is kind of merging the Mahata technique with what Dr. Sanders was talking about, and that is on the humeral side, transosseous fixation. And I'm going to blend in some healthcare economics because when the world stopped during COVID, I went back and got my MBA and got very interested in healthcare economics. So without further ado, I have no disclosures. I've split this talk into 2 parts. One really focuses on the surgical technique of transosseous humeral-sided fixation. The other kind of gets into the economics of maybe why we should consider doing this outside of the clinical benefits. So with respect to the surgical technique, a lot stays the same, but obviously some things change. So what changes is the humeral fixation of the graft to the greater tuberosity. We're doing that using a transosseous technique. We're going to use transosseous fixation for the repairable portion of the rotator cuff. If we have a situation where the subscapularis or infraspinatus is repairable, torn and repairable, we're going to use transosseous technique to repair that as well. What doesn't change, graft harvest and preparation, that's exactly the same. And then I also use anchor-based fixation on the glenoid. I haven't quite worked out how to do that transosseously yet. And I typically will use a 2.6 millimeter size all suture anchor to fix it to the glenoid. I've had some pullouts with 1.8. So kind of the step-by-step, and please forgive my kind of homemade illustrations here, but hopefully we can follow those. But the step-by-step process in humeral-sided fixation is, first of all, once you prep the graft, the key is to place 2 luggage tag sutures in the lateral margin of the graft. And kind of as Dr. Sanders was talking about, this is going to allow you to differentially tension the graft once you've passed these sutures retrograde through the transosseous tunnels. So our transosseous tunnels are made. We're going to take each of those luggage tag sutures after we've finished our glenoid-sided fixation. And as shown in the upper right-hand corner, we're going to actually shuttle those retrograde fashion through the lateral apertures up through the medial and then pass them through the graft. Then we tension them, tie them over the graft, and you could stop there, but you can get even better compression if you continue with additional transosseous sutures and perform an X-box or whatever type of configuration you think provides the best compression over the greater tuberosity. So a few pearls for performing this technique, which I think apply to transosseous technique in general. One is kind of how you're going to get this. And I do use the tensor tunneler device to create the tunnels. I think, John, what you were talking about is the old Arthro tunneler, which was a Tournier product, which is a little bit what I'll describe as Fisher-Price in your hand. It kind of feels like it's going to break all the time. And it's also very meticulous. You have to deploy a loop and you have to drill and capture. And so the device that Brett and Justin developed really simplifies a lot of that process and makes it more reliable. But the way you actually introduce the device into the shoulder is important. And so kind of getting a low anterior inferior portal is important so that you can, and I'll show that in a video, so that you can easily seat the tip of the device into the prepared medial pilot holes. Also, I think this is just a general tip for SCR. I always pass my posterior seam sutures prior to introducing the graft. Some will put them in the graft itself. I put them in the rotator cuff so they're waiting, so then the graft is in place and I can just pass those sutures to suture that posterior seam with the infraspinatus. Also, for those of you who haven't done many, which is probably not many people in this room, but you make a very generous, at least I do, the skin can actually hold up graft passage sometimes. So I make a larger incision for my portal through which the graft is going to be passed. And I usually use a flexible cannula, like a passport cannula, and I'll cut the diaphragm of the passport cannula out, which facilitates that. Sometimes I'll split it down the middle. And then also, skin is sin, so I cover the skin with Ioban. It adds $10 of variable costs in the US and makes me feel better about preserving skin prep as well. Suture cutout, I have not seen that to date. But this is just a picture of what Dr. Sanders was talking about in terms of hybrid backup fixation. So that's always an option if you need it. So we'll run through a quick case. In Minnesota, it's not uncommon to have someone in their 60s come in and say, well, my mother lived until she was, in fact, she's still alive. She's 95. And my dad will probably live till he's 100, and they still chop wood and heat their home with a wood-burning fireplace. So people live a long time, and they're very active. So a 67-year-old right-hand dominant active male who comes in probably really is very, very active, and he hunts and he doesn't want to give that up. He probably bow hunts and he doesn't want to give that up. And so like putting a reverse in this individual is probably not going to be something he's going to be happy with. And so these are operative imaging. We'll go back and see if, can you start those? Can we run through those? I don't know how I'm going to be able to start each one individually, but if you could click on those so the audience can just see what we're starting with. And, this is, I think, right off the bat, one of the more ideal candidates for an SCR because we have an isolated supraspinatus tear. The infraspinatus had the anterior portion acutely torn, but was repairable. And we can see the intramuscular edema on the sagittal cuts there. So we'll run through this quick video. So quick diagnostic, we can see the subscapularis is intact. Moving into the subacromial space. After all of our releases, we still have inappropriate tension for a primary repair in our supraspinatus. And we can kind of visualize the upper border of the teres minor. I will show you a quick technique for the biceps, which we also do transosseously, although after watching Clara's talk, I'm not sure I'm going to continue doing that. We may just use it as a reinforcement technique. So here we're creating our medial pilot tunnels, just like we would put in medial suture anchors. This is creating that tensor portal. We really want about a 15 to 20 degree superiorly directed angle to facilitate seating of the tip of this hook into our holes. This is the biceps tenodesis portion. We're actually going to use the protective sleeve to slide our biceps out of the way. And then we're going to pass that shuttle suture, which will allow us to subsequently shuttle multiple sutures through that transosseous tunnel. Then we're going to put 2 girth hitches, one proximally and one distally, and then we'll retrograde and antegrade past the tails from those girth hitches and then tie those over the long head of the biceps tendon body. And once we've done that, we've got 2 very firm fixation points. We've got a girth hitch, which has a property that many hitches have, which tightens when tension is applied to it. And so we've got a very secure tenodesis. Now we're creating our fixation for the graft. And once we've done that, as you'll see in just a second, we've got even spacing, much as you would have using a suture anchor construct, so that we can measure our graft if we haven't measured it already. Once we've finished preparation for graft passage, we have our glenoid anchors in place. Then we obtain our graft. I'm not going to go into any detail on that because that's really been detailed already. But you saw the luggage tag sutures there, and then we'll introduce it. I do use a double pulley mechanism, as has already been described by several presenters today, to help pull that graft into place, tuck it underneath the supraspinatus there, and then I've used some knotless suture anchors for fixation, but I had a couple of issues with that, so I went back to just tying knots, which is very reliable. I do advance the supraspinatus, as has been described before. And there we've completed our seam with the infraspinatus and our completed superior capsule reconstruction. I do like to extend the graft a little bit over the lateral margin of the greater tuberosity so I can just get some additional tuberoplasty effect. So that's the technique. Just to try to stay a little bit on time, I'm going to move quickly into a margin analysis in the United States, where we have to pay increasing attention to the costs that we incur. There's a lot of publication on cost reduction using transosseous technique. I'm not going to detail all of this, but it's available in the talk if you want to look at the sources. What I did do is I pulled some I thought it'd be interesting to look at some actual payer data from our surgery center, which is a large six-room surgery center. It's a multi-specialty, but it's considered orthopedic dominant because over 50% of the cases done are orthopedics in nature. And what we've done here is we've compared dermal. So I pulled some old cases of mine where I used dermal allograft and anchors, compared those to fasciolata and anchors, and then fasciolata and transosseous technique. And so what we're going to look at first is just variable costs per case, right? So we're looking at the total variable cost, and clearly the 2 drivers of that are anchors and biologics. And that's been established in other papers. It's intuitive, but it's also been established and published. There's a pretty dramatic, not quite an order of magnitude, but a pretty dramatic reduction if you move from dermal allograft-based SCR to fasciolata-based SCR with transosseous technique. And if you're in a surgery center and you're responsible for the financials, that's a big difference. The second thing we wanted to look at is contribution margin, right? So for those of you who are not familiar with it, contribution margin is what's left over to pay your fixed costs, right? So it's what you have after you've paid all your variable costs. And so it's an important metric to compare kind of economic efficiency between surgeons or between procedures, right? And so looking at contribution margin is an important metric. And, when we look at the payers that we have in the United States, I basically pulled data for these 3 at our center. So workers' comp, which is actually a fairly rich payer in the state of Minnesota, so it's our best payer. And then Medicare, which is fairly constant with some geographic adjustment across the United States. And then commercial payers. This particular center has fairly rich commercial contracts as well. So what you see here may not be as good as what you have in your centers in the United States. But what we see is basically you lose your shirt on Medicare. And that's especially if you do a dermal allograft-based superior capsule reconstruction with anchors. You can almost break even with respect to contribution margin for commercial payers, and you can still have a margin with workers' comp. Okay, now clearly, if you move to the fascia lata-based SCR with transosseous technique, all of those numbers improve dramatically. But again, this is just contribution margin. This is not what's dropping to the bottom line. What's dropping to the bottom line is your fully loaded case cost, right? Which is your operating margin. So when you start looking at operating margin, you look at that total cost. So we start to factor into things like lease payments and labor and some other kind of fixed costs, and we allocate those appropriately to the different cases, which there's some argument there in how you do that, but it's an important thing. It's an important exercise. You basically lose your shirt on Medicare, right? So you just can't do those cases in your surgery center. And even if you moved them to an HOPD or hospital outpatient department setting, you'd still lose your shirt. And if you move them to an inpatient setting, you probably wouldn't get it paid for because they would want to try to deny payment because this is an outpatient procedure. So you're not really going to get an MSDRG payment for that either. But clearly, so you basically on commercial payers, once you look at the fully loaded operating margin, you know, you might break even. So about $1,000, which is going to be a break-even point, right? But again, very strong financial argument to consider both fascia lata SCR and transosseous fixation technique to maintain your margin at your surgery center. The final thing I did is say, well, you know, what is your payer mix? So there are different payer mixes. This is the payer mix at our ambulatory surgery center. So we have about 60% commercial. If you move into a hospital setting, you're going to reverse those, right? And so if we just average that, we get a blended cost over that payer mix. Once again, we're going to really cost our center quite a bit per case if you annualize that, if we're using dermal allograft and suture anchors for our repair. If we move on to fascia lata, we've already improved that because the number one driver of cost in this setting is the biologic. And then if we drop suture anchors, we're even better. So that's, again, just looking at it from a blended case margin, which is also kind of what you have to do. I did have one more slide that looked at what if we factored in the extra time. As people say, well, I don't know about that. That might actually come out equal because, you know, you have to take the time to harvest the graft, and that's going to be anywhere from, you know, 25 to 40 minutes, depending on whether you have help and they're skilled. Even if you do that and you adjust it for inflation, and there actually is published data that tells us how much per minute, you know, our OR time is going to cost. There we go. It still doesn't equilibrate, right? You still come out behind if you're using a dermal allograft, even if you add that in. That's what I've got. Happy to take questions. Hopefully I didn't bore you, but I can really nerd out on this all day. So happy to talk to any of you about this.
Something to think about, Pierce. Can you help me with my taxes later on?
Happy to, John.
Amazing analysis. I mean, nobody does that with real data. When we looked at ours, you know, just question, do you know, can you do Medicare rotator cuffs in your ASC profitably with anchors?
No, you can't.
And so I was the only one that we could in ours using transosseous. And so all my anchor partners were losing every Medicare, and Medicare cuffs were 60% of cuffs. So you're really making up your nut on a small percentage of that, and that goes away, then you're going to lose.
Yeah, so this is variable from state to state as well. But, you know, so Medicare won't reimburse additional for implants. Okay. And they won't do it in the ambulatory setting, they won't do it in the HOPD setting, and they won't do it in the hospital setting, right? And so for those of you who aren't from the US, right, we have 3 different ways you can get paid for stuff. You can get paid by a certain CPT code in your ambulatory surgery center, and there's something called a hospital outpatient department where ambulatory cases are done in the hospital. There's a separate fee schedule for that. And then there's inpatient, right? So 3 different fee schedules, which makes it confusing. But Medicare pays very little for any of these. And so if you use suture anchors for rotator cuff repair, more than 1 anchor, you're not going to make any money.
Is the tensor Brent, reusable or single use?
That was the big paradigm shift, was to figure out how to make it reusable, which paradoxically improved the targeting efficiency and usability, which was the barrier that you were just alluding to. And that was the problem, is that people couldn't adopt it because they felt it was too difficult. And, you know, making a well-designed instrument that's like a nice shotgun that you reuse and you just buy the shell instead of throwing away the whole gun every time, which we used to do.
You told this guy's from Tennessee.
You know, so exactly. So so it's reusable, modular, breaks down, a part breaks, you replace only that part.
Right, thank you. Right, thank you very much. For the interest of time, I guess we'll go to the last talk. We have.
Wait. So while it's coming up, I'm almost kind of getting a feeling that we're trying to bash the industry, but I don't think that's really true by any means, because without industry, the innovation would go way down. So they're very important partners. And I think as leaders in this field, I think we should try to work with the industry and help them. And financial climate, I don't know that much about it, but I know it's changing a lot. So we just have to adapt and do the best thing.
Good afternoon. My name is Jay Buganim, and I'm presenting a study that we published just in 2025, and it's the biomechanical effects of superior capsular reconstruction for reinforcement of rotator cuff repair in degenerated reparable supraspinatus tendon tear. So this is the SCRR biomechanical evidence. This is the lab where the biomechanical study was conducted at in Pasadena, California in 2019. And this is Miss Michelle, Dr. Taikyu Lee, and Dr. Mehata, and myself back when we started the study. This is a rendering of the device we used to do the biomechanics, and there's an actual picture. The background for this is that although superior capsular reconstruction for reinforcement of rotator cuff repair is reported to prevent post-operative re-tear, the biomechanical benefit is yet to be explored. So the SCR reinforcement, we got clinical data before the biomechanics compared to the SCR primary. And this is an actual human shoulder specimen loaded into the biomechanics study platform. The hypothesis of our study was that SCR for reinforcement would restore superior glenohumeral stability and decrease subacromial contact pressure in a simulated degenerated supraspinatus tendon. It's a controlled lab study. We used 8 fresh frozen cadaveric shoulders, and we tested them using the custom shoulder testing system. We tested subacromial peak contact pressure, glenohumeral superior translation, and glenohumeral range of motion. We compared 6 conditions: intact shoulder, a traumatic reparable supraspinatus tendon tear, rotator cuff repair of condition 2. Condition 4 is the degenerated reparable supraspinatus tendon tear, and condition 5 is repair of condition 4. Condition 6 is SCR reinforcement of condition 4. And this is to elaborate on the different conditions we tested. The condition 1 is the intact. The condition 2 is the just regular thickness, non-degenerative rotator cuff tear, or we called it traumatic cuff tear. Condition 3 is repair of condition 2. Condition 4 is degenerative. You see here, when we're preparing the specimen for condition 4, we're removing the inferior portion of the cuff, the capsular portion of the suprainfraspinatus, and then you see the condition 4 repair, and then you see the augmented repair on condition 6, and you can see the graft here. The graft that we used for this is thinner. We were shooting for between maybe 3 and 4 millimeter thickness fascia lata instead of the 6 to 8 millimeter, and similar technique to the one that Dr. Mehata just presented for his clinical data. This is a summary of the results. Creation of the degenerated reparable supraspinatus tear significantly increased superior glenohumeral translation at both 0 degrees and 30 degrees. The repaired tendon did not significantly improve the superior glenohumeral translation in any abduction position. The superior capsular reconstruction reinforcement significantly decreased superior glenohumeral translation at 0 degrees, 30 degrees, and 60 degrees with significant p-values for all 3. There is a significant decrease in subacromial peak contact pressure at both 0 and 60 degrees for the SCRR. Neither rotator cuff repair nor SCR reinforcement significantly decreased the range of motion. This is in comparison. We were interested in looking at the range of motion to compare SCR reconstruction versus SCR primary, because the SCR primary did affect the range of motion. There was no decrease in the range of motion with the SCR for reinforcement. And this is a quick summary of the results for our biomechanics study that indicates that superior capsular reconstruction that had that significant effect on superior translation and in contact pressure with significant p-value. The conclusion of our biomechanical study is that superior capsular reconstruction for reinforcement completely restored superior granulohumeral translation and subacromial peak contact pressure, whereas rotator cuff repair alone for those degenerative tears did not provide a significant improvement. Any questions?
A couple. One is, why do you think the repair alone didn't work? Because you didn't repair the capsule?
In the degenerative cuff model, we're taking the bottom of the capsular portion of the supraspinatus is excised. So it's a thinner degenerative model. It's similar to the MRIs that we were seeing earlier from different surgeons, where we're seeing this flimsy, thin tissue connecting, but it's not really meaningful. Tissue shows it's the muscular, weaker portion of the cuff. And that's why it didn't affect the translation or the contact.
And one comment too, and then for the founding fathers, Hiro, I want to call on you. We have to define our terms, because Hiro did some great work about 10 years ago looking at the footprint of the infraspinatus, how it came converge with the supra, and only 1.3 millimeters of exposed bone was pure supra. So all these studies saying had a supraspinatus tear, I think it's also infra. So if you look at the Mujizuki paper that I quote all the time, it really is both tendons. So you're fixing a 2-tendon tear here, my friend. I think so.
Yeah, the footprint is
The
so
Nomura
small.
paper showed the capsule was 60% of the footprint.
Mhm.
That was also Hiro's work.
And if we go back to that slide, it's kind of telling when you're, that slide. Can't go back there.
Cut you short, but we're running short of time, and we want to get Max up if that's okay. Yeah, thank you for presenting.
So I think everybody knows Max. There's one thing about this guy that you guys don't know. May surprise you, may not. This is probably out of my over 30 years of doing this. I had tons of residents and fellows. This guy is so OCD, I think, that when he prepares a specimen, you can practically eat off of it because it looks so clean.
Oh, thank you.
Now that he's bashed you, Max, you want to get started?
So I want to thank Paul and Teru for this amazing meeting and venue. I've known Teru a long time, and what upsets me is, why does he always look so young over the years? But thank you for always pushing to do the right thing in this meeting. Just the fact that it's about restoring anatomy versus reversing anatomy. I like that a lot. No conflicts of interest. So what is anterior cable reconstruction? As defined, it involves a cord-like graft providing an anterior cable structure that suspends native capsule in order to restore superior capsular function. The key relationship occurs just posterior to the bicipital groove, which we've all been seeing today. Dr. Stoller highlighted that in the MRI as well. This is where the anterior cord converges with the anterior cable. And all MRIs show this convergence of cord and cable just posterior to the long head biceps tendon. We just have to look for it. Here we see the torn cuff in a left shoulder, clearly showing cord and cable structures. There's a hole in the crescent region, so that's what that hole is. Unusual picture, but it just really highlighted the anatomy in a real patient. You can see that the cord and the cable interdigitate on the footprint where the cord dynamizes the cable. And this is the work by Paul, and he highlighted the fact that anterior cable tears are distinct and can be characterized. RCR is really rotator cord and cable repair, in my mind, and not just a tendon surgery. For example, the 50% rule for POSTA lesions is literally speaking to cable, not tendon at all, and call it what you want, but a POSTA lesion is technically a POSCA lesion, a partial articular sided supraspinatus cable lesion. And Dr. Mahata has showed us that achieving capsular continuity is a primary goal in SCR surgery in order to retension adjacent redundant capsule. So the concept, about 2017, was it? Around that time, I was thinking, in my practice, a lot of the time, these large tears, they could be repaired to a certain level, including the infraspinatus. So just for the concept, The long head biceps tendon is a surrogate for an anterior cable structure, allowing the reactivation of adjacent superior capsule that has become insufficient. But most importantly, at least one half of the infraspinatus must be available in order to perform the ACR. An ACR has the potential to protect your tendon, suspend the tendon, reactivate the native capsule, and dynamize the graft. We validated the concept showing that the autograft long head biceps tendon ACR was comparable to Dr. Mahada's SCR, at least with respect to the biomechanics, tested with similar methods and literally in the same lab. Biomechanics were sufficient in two conditions: the complete supra tear condition and the supra with 1/2 infra tear condition. This drawing is of the capsule and the biceps cable graft only, with the muscles and tendons removed. But note the dysfunctional superior capsule in the schematic, similar to what Dr. Mahada highlighted in that one paper I showed earlier. Here, the rotator cable and capsule are restored using side-to-side sutures. Similarly, we validated the biomechanics of the allograft ACR using semi-T allograft. And again, side-to-side sutures retension and reactivate the native superior capsule and cable. Indications for treatment can be based on tear size. The key for ACR is that 1/2 infra rule, where at least 1/2 of the infra with its native capsule is available for reactivation. ACR patients can include those with an irreparable supraspinatus, 1/2 of the infra available with or without repair, an active subscap tendon, long head biceps tendon present or absent given the allograft option, and up to Hamada grade 3 x-ray showing a decent glenohumeral space. The most recent iteration of the allograft ACR uses the glenoid margin for fixation, consistent with the fact that the autograft long head biceps tendon ACR is based off the glenoid margin as well. And technical efficiency is improved with no special portals required and only 3 knotless anchors. And this is highlighted earlier by Clara and Anna in their approach to the glenoid. The graft is secured to the glenoid margin, thus obviating the need for an divisor portal and the standard anterior portal being sufficient to reach this area. The side-to-side sutures, again, reactivate the native capsule and dynamize the graft. So here's a shortened case video. The MRI is shown and the tear is retracted to the glenoid in this 74-year-old woman. So here I'm just trying to reduce the supraspinatus after releases, and it's not getting there. So I've elected to do the ACR, use a semi-T graft. And if you're savvy in ACL surgery, it's preparing the graft is like an allograft ACL. And so through the anterior portal, I'm placing the knotless anchor, and I'm just going to slide down the graft and pulling on it, making sure it's well seated. The key is to load the sutures ahead of time because you're going to place that blue suture at the sulcus where the capsule normally attaches, and then the black sutures for the distal lateral fixation. But here I'm just tensioning the graft, and then I just go back in to retrieve the sutures and place those through the same anterior portal, and that's the distal lateral fixation. You have a tuberoplasty effect. The cable, this is the infraspinatus being repaired. It almost looks like a full repair, but it's actually not. And through the anterior portal, I'm going to do the side-to-sides, which are very critical to reactivate that capsule, that native capsule of the patient. And other thoughts would be, can this be augmented in other ways? And also, can the graft be fixated through a transosseous tunnel technique, perhaps? So clinically, I reviewed a cohort of my first 21 consecutive ACR cases, average age 69 years old, 14 males, 7 females. It was a retrospective IRB approved study with an average of 2.5 years follow-up. Auto and allografts were used for L-shaped tears and tears with or without common tissue available. Demographically, there was no difference between the auto and allograft groups. Notably, 43% were Hamada grade 3, 52% had supraspinatus guttalia grade 4, 81% had supraspinatus guttalia grade 3 or higher, and 24% had infraspinatus grade 3 or higher. Pre and post-op, on average, the acromihumeral distance improved 1 Hamada grade level to Hamada grade 1. Active forward elevation improved from the head level to the overhead level. 3 out of 4 patients had pseudoparesis reversed. ASCS, sane, and modified constant scores were all above 90%. And manual muscle testing improved by 1 grade on average for more than half the group. And overall, the study showed positive results for a cohort with irreparable supraspinatus tears and limited goals expectations. Numerous studies have shown, applying the ACR concept, that clinical benefits have been reported. And there's been a deluge of reverse total shoulder arthroplasty. If you look at the literature, there was a time when reverse total shoulder arthroplasty was strictly considered a salvage procedure. And the current ACR series has shown that patients can be pain-free or have a pain-free status restored, active forward elevation restored, ADLs restored, and sleep restored. So although the supraspinatus was irreparable, we could, through the ACR, create factors that would reverse the indication for a reverse. So we went to medical school to learn how to restore. And in orthopedics, it's the same thing. We want to restore the body as a primary thing, not reverse it as the default. So yes, indications exist for reverse, but as a group, I believe we should put some resources and energy into restoring human anatomy, not necessarily reversing it, at least so readily. So just to summarize, ACR is a form of SCR. The principles come from Dr. Mihata's work. And we've looked at this biomechanically. It's been a slow learning curve for me from the concept to where it is now, mostly because I want to do no harm. So it's been a process to get this going. But I think that currently I'm happy with this technique. Obviously, prospective studies are needed. And it's one of the several procedures that has a potential to reverse this tide of reverse total shoulder arthroplasty. It's something in our toolbox, so to speak. And then finally, I was going to end on a question, like when considering technical ease, could the SCR like the ACR benefit from glenoid margin fixation? And kind of Clara and Anna has kind of answered that question to some degree. But I think that there's so much to be learned. And it's a process of optimizing all the different tools we have to make the SCR successful and common as more of a default in patients where you want to just create what we were as created. So anyway, that's it. Thank you for your time.
I've gotten to know this young man. Not only is he brilliant, but he's very good and ethical. You can see it. One question I have is Larry Field had a paper about a year ago. And, he just basically slits the transhumerus ligament. He translocates the biceps, leaves it in situ, and sews to that. Is there any need to really detach it and anchor to the tuberosity? Because I've been doing Larry's thing for years, actually, with good results.
So he fixated the biceps in the groove in situ?
No, he just releases from the groove, translocates it, but leaves it intact. You cut and tenodese it.
I see. Yes.
Is that really necessary to tenodese it to the tuberosity?
I'm not sure I understand the question fully, but I would say with respect to this concept, it has to do with the functional anatomy. So you want to restore the structure, which is a ligament, where it attaches on both sides of the joint. So for me and for Ty too, when we were coming up with the hypothesis and how to test it, we wanted to be right behind the groove where the cable resides. The other thing that I didn't have a chance to mention is that the kinematics are very important, that we found clinically that we needed to rotate externally the humerus before we fixated at that point. So we wouldn't lose external rotation. And I think that I was talking to Anna earlier, but Dr. Romy had the one slide that caught my eye and we might have all overlooked it, but it's the one where he had it in 45 degrees when he was tensioning and thinking about what we're doing, because it is a stability surgery, so we don't want to over-constrain either. So it's just something to think about, that you want to consider not just the technical part, but just what's going to happen afterwards. And then when Ty was talking about like graft thickness, I think that along the same lines, when we have the arm in traction, that's affecting the tension. When we fix a tendon, it's okay to be in traction because we're going to take it off traction. So there's less tension on the tendon. But if we're talking about a ligament and it's distracted and then we take the tension off, then the question is what's happening to our tension? And I think that in that gray zone, the thickness could make up for that lost ability to reproduce the good results, because if it's thick enough, perhaps that's the compensation that Ty was talking about when we're missing something else. So,
Burning questions before we conclude? Thanks, Max.
Max, great. I want to talk to you more about cable stuff. So,
Okay.
we have a small adjustment in the schedule.
I want to make one last comment. I mean, obviously, Max is 1,000 times smarter than I am, but initially when all these two-dimensional, three-dimensional, like double row to TOE techniques came out, even Max's drawing, I guess he was young back then, see it as a nice flat tendon sitting on but it actually is not, because they're doing different things. So I think I'm not a real surgeon, but my main message to everyone is that form follows function. If it looks different, it's doing something different. So should kind of keep that in consideration.
We're actually going to try and finish on time. So thank you for great moderating and jokes. And we're going to make a small adjustment in the schedule. I'm going to give a very short presentation on where we are with the association. And then Taro's going to take us home. So. Okay, so in order to support, this meeting started because of Clara, Katerina, and Taro and Gary were having a cup of coffee in Munich, looking at a 2-page proposal because Taro had said we should do a symposium, so I threw 2 pages together. Here we are. In order to support this, I didn't really know what we were getting into, but here we are. We had to form a 501c3 nonprofit corporation, which we use now as the administrative and business side of the support for the International SCR Association. The nonprofit board is very small just to keep it agile. So Dr. Mahata is the president and Ty Lee and I are the other board members, and I'm the executive director of that, which just means that Debbie's the secretary, so we do all the administrative work for this. The academic board, which is what all of the founding board members and the founding members are, really guide and direct where we go as an organization. Of course, Taro Mahata is the president of the academic, and I'm secretary of it, mostly just to support what we do. And so we'll be having a board meeting shortly to help discuss, what we learned today and where we go next with this organization. So I appreciate everybody sticking through a day. We made it through a very good program. And these are, the tools that we used to get here. We had very good support from our web team. I appreciate Rosa from the Netherlands who flew out to help us to make sure we could live stream the app. So those of you who were on the app, the live stream allowed anyone to translate into their native language while they were listening. The on-demand doesn't let you do that, but the on-demand is available for 6 months, and all of the MP3, they're going to be the MP4s is what they're going to be file-wise. Once we develop the website, we'll have everything that was discussed here. There will be a post-meeting PDF that's created from everyone's talk with the help of Ia, who lives in the Philippines, my assistant, and ChatGPT. I'm sure she'll be using that. And we'll make sure that's available for everyone. So the app is designed to be our community vehicle, right? So please stay on the app. There'll be announcements that come out about the International Association and any future events. We don't really have future events planned yet, but here's what's been going on. So, we did this on the 19th. We did a demo. We did a lab. If you're going to be at AAOS in New Orleans, Taro got invited by John to be the key speaker for the innovation on the Anna Specialty Day. I'll be down there as well, so please let me know if you're coming. We'd like to have a presence over there. There's been some talk with Dr. Dunbar, who had to leave, about having access to a lab and maybe doing something Friday afternoon as a training session. So we'll see if that develops. It's only 2 weeks away, so we'll see. I'm giving a talk I got invited because of Taro. I was talking to his Egyptian surgeons, and I got invited to Egypt to present on the agreement that if they let me come talk or had me come talk, that we were going to start talking about developing them as a regional center for that. Coincidentally, Anna is the guest association at the Egyptian Association. Mark Hutchison called me and asked me to join in that. And Mark's comment about when I told him what I wanted to talk about, the title he gave me tells it all. He sent me a title goal that says, SCR, don't give up on it yet. And I wrote back and I go, well, that's interesting. That captures everything. I go, how about this? SCR is alive and well, and we'll present the current outcomes and updates on the fascia lata. So that's our actual title. I'm also giving a talk on the cable, which I want to talk to Max about because we have to make sure we present the cable concept.
One addition, make sure our program director is invited Ty Lee and address on how we did it, whatever the title is going to be.
On the specialty day?
No, the day you'll get it.
Oh, fantastic. Fantastic. Right. Fantastic. Thank you. I'll get that on there. So good. And let's see what else we got. So we've got an instructional course lecture application with Dr. Mahata as faculty, John as Ty as moderator, John
Or is it the way? No, John is moderator, Ty is faculty, and I'm faculty, and Clara. We'll see if that gets accepted because that's really an ASES dominated program. So probably not, but we'll see. Let's see, and then I've got a couple abstracts. So if there's other events, please keep us posted. Going to Athens Shoulder, if you're going to be talking, representing NASCAR, we want to help support you. So let us know if you're involved with that. And I think I wanted just to point out, this is one of our, I feel like we're playing Risk. I have global aspirations. Global aspirations. This is what our current contact points are. This is somewhat like sales. This is current contact points in the world, which is really substantial. I had no idea until Terrell started sending me names to add to this. We have 20 countries involved, 20 countries. The U.S. now has 3, probably 4 surgeons involved in this. So we're growing. We're trying to recruit more. We're trying to recruit more people from the U.S. to be involved in this work. And so, you know, we have 10 states represented at this meeting. And so we're trying to get U.S. penetration as far as the concept goes. We're trying to change the narrative and the dialogue about this. And we want any procedure that we can prove works, you know, to be included. My original name for this association was shot down unanimously by the board because I'm somewhat of a zealot. So I was like, it should be the International SCR Fascia Lata Association. They said no, because it has to engage. We have to include, and they're right. I've learned a lot about working with others. They're right. We have to engage. We want conversation. There's a lot to learn, as we learned today. So this is our mission. And that's it. That's all I have to tell you before I let Taro take us home. We have a board meeting next to the bar at 5:45. Please do not get lost in the bar. I'll meet you in the boardroom. So.
On behalf of all of us, we really want to
Yes, thank you very much, my friend here, for your dedication and hard work today. Although maybe most of the surgeons have jet lag still, maybe now getting sleepy, I think. Yeah, I think it was a truly outstanding meeting, wasn't it? Actually, yeah. So I'm very surprised and I'm very glad to see this meeting here. Before we close, I want to introduce their sponsor, actually, and Alfred's company. It's a diamond level, right? Yeah, thank you very much. And the silver level is a 10th floor and debut synthesis and Zuri Mets. Thank you very much. Yeah, and also I want to express a sincere appreciation to the Paul and the Paul's team, maybe Debbie and Ashley and Ian. So please, big applause. Yeah, thank you very much. Without your help, maybe we cannot make this meeting success, I think. And today, the SCR surgeons from over the world have gathered in the one place here and discussed together. I think that finally we have opened a new chapter in the history of root cavity treatment and SCR surgery. So I hope we can grow the International SCR Association for the benefit and the patient and of the root cavity and also young surgeon. So thank you very much, and I'm looking forward to seeing the second academic meeting, maybe 2 years later, right? We don't know yet, but maybe soon.
We'll be deciding at 5:45.
Thank you very much.
Reminder, there's the celebratory dinners at 7 o'clock in this room. They do need us to clear for a couple hours so they can set up for the dinner. The food is excellent here, so hopefully everybody comes and enjoys the dinner. Yes, thank you. I'm sorry. You have some idea.